surgery is three-pronged. The, the goal of surgery has changed now. It's not like that you operate, you do a sinus surgery and the patient is cured. The goal of surgery, number one, is to open up all sinuses and establish the ventilation and drainage. Number two, to remove the inflammatory load, which can be taken further with the topical management. And third is to give access to the topical medications, because now we open up the sinuses and according to the load, we widen the sinus opening, sinus osteas, so we can introduce more and more topical steroids deep into the sinuses, which is actually the site of inflammation. So the goal is three-pronged: to establish the ventilation drainage, to remove the inflammatory load, and to give access to the topical medications. And in order to achieve this, we have to operate in this area, which is very closely, associated with the orbital skull base and many important structures all around. So the margin of safety is very low. If you are disoriented, you can end up in major complications. So the CT scan has a big role in giving us three-dimensional anatomy of the region where we are going to operate. Here, even the submillimetric, disorientation can lead to fatal complications, can lead to orbital complication, can lead to cranial complications, can lead to carotid artery injury, optic nerve. There is so many things which are around. So like so many tigers hidden, in the vicinity of the paranasal sinuses all around. And we have to be very, very careful and diligent in executing our surgical plan. And here comes the role of CT scan to direct us to get, allow us to achieve this goal in the safest manner. So I'm going here to share with you the CT scan, the kind of CT scan we need, we must know. See, in all these patients, earlier, particularly in India, I don't know what happens in the Western settings. There is a habit of advising CT scan, that's it. And the patient comes with the printouts. For me, that is hardly of any value. Once it comes to CT scan, we should order an adequate scan to get complete three-dimensional dynamic information of the area where we are operating. What we order is a fine section, 0.5, 0.6 mm CT scan in axial section, and with our software, this radiant dichrome viewer, we can reconstruct in all planes to get us dynamic information. So that's how it becomes a very, very important teaching tool as well to the junior colleagues to discuss and to share with our colleagues as well the kind of information, the kind of anatomy, abnormal anatomies, abnormal cellularity in this region, all can be deeply and carefully accessed. So, like in this particular patient, we have three-dimensional, CT scan. See this, if I reconstruct into three planes, how it looks like. The CT scan was shot in axial plane, and the same structure you can see in all planes. Like sphenoid sinus, you can see the sphenoid in all planes. Frontal sinus, you can see the frontal in all planes. That's an amazing teaching tool. Amazing tool to orient three-dimensionally to all the anatomical structures. So once it comes to CT scan, we should be able to read ourselves three-dimensional dynamic CT scan. Why I'm saying so? There is a gap. There is a lack of association amongst the radiologists and surgeons. I don't know your setting, but by and large, what I'm talking. To order a CT scan PNS, the radiologist will report in no time that the patient has a bilateral pansinusitis. That's it. Doesn't carry any value to us. We want information in complete anatomical details. Each and every anatomical abnormality we want to know. Sometimes critical distances we want to know. Like patient has any abnormal cell, Onodi cell, patient has an agar cell, patient has frontal cell, patient has a dehiscence of the lamina, patient has a dehiscence of the skull base, the craniform nasal septal, high septal deviation, turbinate, concha, each and every information we want in detail and dynamic from surgical perspective, which radiologists fail to deliver. While that probably is everywhere because they may not, they probably cannot give that much of time, they cannot devote to give us a complete. Right. Tried with many radiologists to club. We have given them pro forma to fill up all these points in details in every case. So more than 300 points to be filled in that pro forma, and radiologists refuse. They can't devote hours and hours to deliver this report. So the onus is on the surgeon actually to read the CT scan on his own, to get the complete dimensional perspective of the area you are operating in, the surgeon's mind itself. And that is what I am going to show you. So, by and large, it has been a trend to see the coronal CT scan. And it is right, by and large, coronal CT scan gives you a good amount of information in, from the surgical point of view. It is very easy to understand, easy to relate as well, because we get the anatomy in the same plane while we are operating. So it is much easier to understand. But the axial is very useful, particularly in delivering certain information of certain areas. Like frontal recess area, like nasal septal deviation in toto, the anatomy of the orbit and relation of the orbit to the paranasal sinuses, right from anterior to posterior, the lamina papyracea, the Onodi cell. There are certain areas where the axial gives better information than coronal. And for that particular region, you must switch over to the axial to get more detailed information for that particular point of view. Sagittal is immense useful for certain areas like frontal sinus. I cannot operate frontal sinus without having a sagittal section in between. There is immense, amount of anatomical variation in the frontal recess region in every patient. There are groups of cells which narrow the overall drainage pathway of the frontal sinus. Certain cells are lying anterior and narrowing the frontal sinus pathway from anterior. Certain cells are posteriorly placed and narrowing the drainage pathway from posterior side. Certain cells are medially placed and narrowing the pathway laterally. Certain cells laterally placed, narrowing the pathway. So, in every patient, you need to have complete dynamic information of the cellularity of the frontal recess for that particular patient, so that you can deliver optimum work. Otherwise, what happens in the event of lack of adequate information, for the fear of giving complications, surgeon ultimately ends up doing some standard job, and that involves the need of the problem of persistent disease, the need of revision surgery, and so on. So the adequate radiological information is the core important point in delivering the good surgical work. So the sagittal sections are immensely useful in the frontal sinus, in showing the skull base slope, in showing the certain areas of the sphenoid sinus, nasolacrimal duct area, and so on. So by and large, we should be able to draw the information from all three planes, dynamic, reassess certain things in all three planes. Like if I have to assess the frontal recess, I would like to reassess in all three planes in spite of getting good information in the sagittal plane. So that is so important. So let's go, say one by one. Let's go without wasting time in the coronal plane, which is most useful, what we believe, as we get the information in the same surgical plane. It is. Can you see in the left lower down corner how thick is the slice is? Can you see Dr. Rokade here on the screen?
Yes, yes, we can.
Can you see?
Yes.
Yes, we can.
Every movement will take me 0.3 mm away. This way in the paranasal sinuses, I cannot miss any smallest damn thing, which is very important. Suppose I have a 5 mm section. We see many a times patient coming with us a scan in hand with 5 mm section. Every scan, every slice will jump by 5 millimeter and we are likely to miss a lot of important information. Like suppose ethmoidal artery, which is a sub-millimetric structure having a diameter of say 0.9 mm or so. If you have a thick section 3 mm, 5 mm, we are surely going to jump that and we are not going to have any information. So this is very important. 0.3 mm. Every time I will move by 0.3 mm. Like see now, coming from anterior to posterior, quickly to enumerate the important anatomy of finding positive findings. You can please feel free to interrupt me anytime. Please.
Sure, sure, yeah.
Sure.
See this, the most anterior structure, what you see is, these are the, nasal septum, cartilages, nasal septum, alar cartilages. As I go now, see this frontonasal process coming in the picture, the upper part of the bony nasal septum, and what you see this high deviation. This is such an important finding, believe me, high deviation. High deviation means that this is one of the findings which prevents you from accessing the frontal recess region adequately, and most of the time you need this correction. Otherwise, what happens? You pass your scope and instrument to the narrow areas and ultimately end up giving synetia. The success of sinus surgery depends upon postoperative irrigations now. Postoperative steroid irrigation is purely steroid-based disease which requires long-term irrigation. And if you're because of uncorrected high deviation, synetia happens to occur, won't allow the steroid to reach effectively into the depth of the paranasal sinuses and can result in failure. A single miss out, single uncorrected problem, this high deviation can lead to ultimate failure. So how important it is. And secondly, you can counsel your patient that along with the sinus surgery, you need some sort of septal correction as well. And this helps in unnecessarily otherwise medical legal issues. So what you see the high deviation on this side. Now the nasal bone coming into the picture, both nasal bones, see this, and the frontal bone. As I go behind, see now the pneumatization of the frontal bone coming, two frontal sinuses coming into the picture. See with the intersinus septum. See the frontal sinuses, they are never equal. Septum never in the midline, it is almost always eccentric. And see why I'm calling this as frontal sinus, because this is pneumatizing the frontal bone and it is floored by the thick bone that is beak. I'm repeating, it is floored by the thick bone. As I come from anterior to posterior, see this is floored by a thick bone, beak. As I go posterior, as I go posterior, as I go posterior, see now, the thick bone is gone and the frontal sinus starts draining in the frontal drainage pathway. So this is frontal recess region, which is most posterior. This is to be, very carefully understood. See, let me reconstruct the same thing what I am trying to say. The drainage pathway is in the most posterior part. See this. See this for the beak. See this is the beak in the coronal sagittal section. If I come from anterior to posterior, this beak forms the floor of the frontal sinus, and as the beak ends behind, the frontal drainage starts. This is going to be my catch point in frontal sinus surgery, and this I always mention in our teaching courses. The best landmark for the frontal sinus God has given us, in spite of the number of cellular abnormalities, cellular variations, the thing which cannot change is the beak. The most I would say reliable landmark is the beak for the frontal sinus. So once you see it, the same thing will correlate intraoperative as well. You see the beak, Follow the beak anterior to posterior, and where the beak ends. Where the beak ends is the frontal sinus drainage pathway. As simple as that. This cannot change. This is a God's given anatomy, and the beauty is, in spite of the multiple revision surgeries, where you have a frontal recess, complete excentrations, fibrosis, adhesions, whatever, you're re-exploring and you really need a good landmark, the beak is always there. So in spite of the multiple revisions, this landmark cannot go. So I'll show you intraoperatively, correlate the same way the way we are looking at the CT scan. We'll follow the beak from anterior to posterior. The moment the beak ends, the frontal drainage pathway starts and it cannot change. The most reliable landmark of the sinus. So we come back to the coronal. So what we see, what we have found, see this now. Going anterior to posterior, anterior to posterior, anterior to posterior, and where it ends, now is the frontal drainage pathway. Now the frontal sinus is over. Frontal sinus has been left anteriorly, and this is frontal drainage pathway. And see, there is a lot of mucosal edema, collection, whatever, thick mucosa, whatever, obliterating the frontal drainage pathway. Now see, as I go further behind, see now, what I see, the cribriform plate coming into the picture. Let me go back anteriorly. This was frontal sinus. As I go behind now, the frontal sinus ends at the level of frontal recess, and then the cribriform plate starts. Now, what is this looking like? Frontal sinus still there at the level of the cribriform plate? The cribriform plate is a centimeter behind than the frontal sinus itself, the beak of the frontal sinus. Still, this pneumatization, sometimes this can be bigger than the frontal sinus itself. Looking like frontal sinus, this is not frontal sinus. This is over pneumatization of the orbital plate of the frontal bone. We call it as a supraorbital cellularity, supraorbital recess. This is over pneumatized supraorbital. We have seen this pneumatization extending many times right up to the zygoma. This can extend anywhere. So this is extensive supraorbital pneumatization. With the cribriform plate seen there, it cannot be frontal sinus in the same picture. Secondly, to avoid confusion, I'll give you another clue. Go back. See, this is frontal sinus where the beak is there. No maxillary sinus you will find in the picture. As long as the frontal sinus is the most anterior anatomy, as long as you see the proper frontal sinus, you will not see maxillary sinus in the same picture on coronal scan. Now, as I go behind, see now as the frontal drainage pathway starts, recess starts, see the maxillary sinus starts appearing in the picture. That means two posterior section to show the maxillary sinus in the same picture. So this is maxillary sinus on either side, and this is supraorbital pneumatization on either side. Supraorbital pneumatization. With the beak, I told you, and I'm repeating again and again, with the beak as a supreme landmark for the frontal sinus, believe me, if you follow the beak as a landmark, frontal sinus opening, identifying the frontal sinus, reaching the frontal sinus, widening the frontal sinus is a child's play. It's a literally child's play. No need to get confused in so many exploited concepts. We've done thousands and thousands of frontal sinus surgery and come out to this most simplified manner of radiology. You look at the beak, and accordingly you define your frontal sinus drainage pathway so easily during surgery. Now I am coming back to the reconstruction. See this. In the sagittal section, see this. This is the beak. Let me enlarge this. This is the beak, thick beak. See, this is the thick beak. How thick the beak is, I can measure with my software the beak thickness. See, 1.6 centimeter. My goodness. Now why it is I am showing, I am coming with my scope from here. For the frontal sinus, we always recommend a 70-degree to look back anterosuperiorly. And the biggest obstacle is this beak. See how thick the beak is. So when you come with endoscope, you need a 70-degree to look back anterosuperiorly. But if there are abnormal cell riding high up in the frontal sinus, like type 3 or type 4 cell, like frontobular cell or whatsoever, going above the level of the beak high up, with your regular instrumentation, you cannot reach high up to get rid of those cells. And in those situations, you have to drill away this beak to get head on to those cells to get rid of that. And that is what described by the draft as various draft procedures. And that has been modified now more and more for a convenience to different indications. So draft involves basically drilling the beak, ipsilateral, bilateral, with removal of the upper part of the septum, intersinus septum, modified endoscopic lothrop, this and that. There are so many variations from draft 1 to 3 and so on, modified, subtotal, mini lothrop, so many things. But all the basic thing in all is drilling of this beak to reach high into the frontal sinus. And this has opened the gateway. This has opened the gateway for various procedures in the frontal sinus by the endoscopic route. This is like for the frontal sinus now for me, for endoscopy, boundaries are unlimited. Now the indications have expanded with these extended approaches to the frontal sinus. Now for any CSF leak in the frontal sinus, tumors in the frontal sinus, variety of benign tumors, there's so many other extensive diseases in the frontal sinus. Our choice of approach is endoscopic, as we can drill with the high-speed drills, drill this beak and reach into the frontal sinus heads on. So this has become our preferred approach for all these. Otherwise, in the past, what is to be believed? In the past, people would believe that any lesion, let me draw, any lesion beyond the mid-orbital plane like this, any lesion lateral to this is not accessible by the endoscopic route, and you have to, combine with the open route. This was earlier believed now, but now with the advancement in the surgical techniques, what we do with variety of lothrop procedures, orbital transposition procedures, we can reach out to the farthest lateral limit of the most stigmatized frontal sinus, even to the level of the pterion, endoscopically with our angled instrument, microdebrider drills, and so many other things. So that is what the advancement in the technique is. So understanding CT scan is the key for, when you define the need of all these procedures. So what we were looking at, this is a cribriform plate, and this is supraorbital recess. This is very, very important. Supraorbital recess is so important to know. See, this is the orbit. The orbit, this is bone window. Again, let me tell you, when we order the CT scan, a radiologist give us details in both bone and soft tissue windows. See, let me tell you, this is bone window, okay? Now I'm bringing in soft tissue windows for you. Soft tissue window means in this bone window, the bone is so precisely delineated, even the slightest bone erosion you can identify with hardly any soft tissue details. Now, in the soft tissue sections, the details of the soft tissues are more on the CT scan as compared to the bone. Let me bring this soft tissue together. It's working slow, and it will give us an immense, information of the soft tissues inside the orbit as well. We'll show later. So what we see here is a cribriform plate. Now coming at this level, we need to see certain anatomy. Number one, this cribriform plate configuration is very important, how deep it is. Why so important? See, this cribriform has two lamella, the medial lamella, lateral lamella. and this is roofed by the frontal bone from above. If you have a too big a lamina working in the frontal recess is very, very close to the long distance of the cribriform lamella, and you're more likely to injure as compared to a short lamella. So in cases of deep olfactory fossa or the long olfactory, this cribriform lamina, you have to stay extra careful. That's why the dictum when we teach frontal sinuses or frontal recess work, to direct your instrumentation laterally, always laterally away from this. Now the important structure to be seen here at the junction of medial and upper lateral lamella is this the structure coming down. This is middle turbinate. The first vertical part of the middle turbinate lying in the sagittal plane. This is the first part of the middle turbinate lying in the sagittal plane. This is very important to see on both sides. This patient has a serious high septal deviation. This is pushing the turbinate also on that side. See the turbinate on this side and see the turbinate on this side, which is pushed laterally, further compromising the middle meatus region. So this is important to see the attachment of the middle turbinate, and that's why it has been always advised to handle carefully this turbinate, particularly in the upper part, as it is close to the cribriform, attached to the cribriform, to the part of the cribriform which is very, very thin, and that's why if you don't handle it carefully here, can lead to a distal CSF leak at the level of the cribriform plate. So this is important. The configuration of the cribriform, the attachment of the turbinate, this is the lateral and the medial lamella. All these things are important. Now, see again coming back from anteriorly. From the level of the beak, see now how posterior I am going. See now how posterior, the beak has gone, the frontal recess has come, after that the cribriform has come. See the supraorbital cell. Now the supraorbital cell is ending. See the cribriform is going to end, and now at what this level posteriorly, what is coming? This peaking of the orbit at the most posterior part of the anterior ethmoidal roof. That's what I'm trying to say. This is where the anterior ethmoidal artery is leaving the orbit, heading towards the cribriform plate, where it perforates the cribriform plate and enters the olfactory fossa, the intracranial course. So this artery, which is a branch of ophthalmic artery, see here, this is superior oblique. This is superior oblique. This is medial rectus. At the confluence of this is peaking of the orbit, where this vessel leads into a canal, bony canal, orbitocranial canal, in the roof of the anterior ethmoid, in the roof of the posterior most part of the anterior ethmoid, and then enters and perforates the lateral lamella to mark at the thinnest part of the skull base, entire skull base, and then enters the olfactory fossa. In the olfactory fossa, it comes anterior, forming a sulcus. It gives off a branch to the fox cerebri, and then comes back down in the upper part of the nose again. So interesting. So it is given off in the orbit, first compartment, run in the roof of the ethmoid, second compartment, run in the intracranial segment, olfactory fossa, third compartment, then comes back in the upper part of the nose supply, the uppermost part of the medial and lateral wall, where our favorite Professor Paul Casanova has devised a flap based on the anterior ethmoidal artery we use very often for sacral perforation and other pathologies, sometimes for lining the frontal sinus and all that, very useful. And from fourth compartment, it comes to the out of the nose to the dorsum at the junction of nasal bone and the upper lateral cartilage to run on the dorsum. Okay, so that's the fifth compartment. So important thing is anterior ethmoidal artery. The most important thing is it is a very, very posterior structure in the anterior ethmoidal roof. Why I'm saying and mentioning again and again, the reason being the moment the surgeon starts working in the frontal sinus, start bothering about the anterior ethmoidal artery. First of all, this frontal sinus beak is 1 centimeter behind the beak is the cribriform plate starts. And in the cribriform plate, which forms the anterior ethmoidal roof, in the posterior most part of that is the artery starts. You don't need to, all the time terrorize yourself with ethmoidal artery by working in the frontal sinus. It is far, far off from the frontal sinus area, and then it is the posteriormost part. This is the ethmoidal artery. If I go posterior, this is the artery level on both sides beaking. A few millimeters behind now, see if I go posterior, the ethmoidal roof ends. That means this artery runs through the posterior most part of the ethmoidal roof. And now the thick postethmoidal roof starts. See the difference? Difference in the thickness of the ethmoidal roof and difference in the thickness of the postethmoidal roof. And now see a lot of things change as we go posteriorly. This is very important. See the orbit which was so big. Now the orbital cavity is narrowing. See the maxillary sinus which were globular is becoming oval and ending as we go behind. There's a thick postethmoidal skull base. Now the cells as you go behind, see this, the big postethmoidal cells. See this entire thing, the entire roof of the anterethmoid, postethmoid and frontal. The entire thing is roofed by the frontal bone. See this all together in entirety is the frontal bone. See all the way, from everywhere it was frontal bone. Now this is postethmoid. The moment postethmoid ends, this is very important for the surgeon to relate. Now, as the postethmoid ends, the sphenoid starts. And the sphenoid is not roofed by the frontal bone. See now, carefully, as I go behind, see now, this is the rostrum. As I go behind, where is the roof? The frontal bone disappears, kept anteriorly. And this is roofed by lesser wing of the sphenoid. And this is the true sphenoid sinus now. That is how you can relate with the CT scans, your anatomy three-dimensionally in a proper way, so that when you operate, you have a complete three-dimensional picture of the area you are operating. So this is now the sphenoid sinus. Now another difference is, until the postethmoidal roof was, the entire septum was right from the top to bottom was existing. This was the entire nasal septum existing. The moment I go behind, the moment the sphenoid sinus starts, the septum is missing now. No septum now. Now this is the intersinus septum of the sphenoid sinus. Two sphenoid sinuses unequal. This is the greater wing of the sphenoid. This is the, the process. This is your impression for the optic nerve. And this is your impression for the carotid artery as you go behind. And there are multiple foramina, so many nerves passing through the, the greater wing of the sphenoid, including this V2, median nerve, and so many see, this is median nerve, this is median nerve, and that marks the level of the medial pterygoid plate. See, this process going down is the pterygoid process, marking the medial and the lateral pterygoid plate, and at the confluence of the body and the medial pterygoid plate is the median canal. That's the median canal. You can see as you go further behind, this is the mandibular foramen, the foramen ovale. So you can see all this anatomy not relevant to this case. What all is relevant is, see this is in spite of the adequate medical management, there is a lot of inflammatory disease. See this pen sinusitis, opacification. This is non-contrast CT of the paranasal sinuses. In slightest of the doubt of any other pathology beyond this inflammatory disease, the thing which is to be ordered is MRI. In cases of complication, in cases of disease going beyond the confines of the paranasal sinuses, you need to order MRI. In case of doubts on diagnosis, you have to order MRI. Otherwise, this is good enough for this inflammatory disease of the paranasal sinus. So this is in brief about the CT scan. This discussion on CT scan or the imaging is never ending. If you want, I can talk later also. But this is something you can see by and large regarding this patient, this positive findings on CT scan. Anything you wanted to add on, Madam Catherine, if you want to add on, or anything. If you disagree or anything, please feel free to comment.
Yeah, that was a very nice description of the anatomy for your surgery. It looks really good. Nice, interesting case for us with interesting frontal sinus and anterior ethmoids that are off the skull base. It's a good case.
Thank you.
Dr. Satish, you make a very interesting key points, and thank you for taking us through in such great details. I think the access is the key. You make that point very clear, and keeping the low threshold for performing septoplasties so that you get adequate access to perform adequate surgery.
Sir.
Then you also mentioned about thinness of the CT scan, which is important, having the adequate thin slices. That also has another aspect of it if you are using the surgical navigation, because navigation requires certain thinness. And if you are using it, especially in the complex cases, you need adequate thinness. Again, you make a point about not only relying on CT scan, but anything beyond any doubts, going for MRI scans. You mentioned about Prof. Paolo Castronovo. I think he has operated yesterday and demonstrated beautifully the flaps based on anterior and posterior ethmoid artery. We use that flap for skull-base reconstruction. So I will suggest our viewers to access that broadcast from yesterday. If you are interested, it will be available soon on our GRN website. So really looking forward to all this anatomy to see live in the surgery. So thank you.
Thank you. So we, in a couple of minutes, we'll be back to you with a live picture, endoscopic picture. And please feel free to interrupt me any point of time. Your questions, your suggestions are definitely beneficial to everybody, including me and for the entire audience. So I would request you for more and more discussion to make it more and more useful. Thank you very much.
Sure. Thank you. So Catherine, talking on this CT and some of the key areas you mentioned about anterior ethmoid artery, then about the thinness of the skull base. So these are the areas which average rhinologists or ENT surgeons are scared of in a sinus surgery. So yesterday on the broadcast, all the three surgeons have demonstrated the anterior ethmoid artery and how to deal with it. So what are your tips on that?
I think the first thing is you need to know your scan really well, just as Dr. James just demonstrated. So before you start any surgery, make sure you know your anatomy. Is the anterior ethmoidal artery in running through the skull base, or is it on a mesentery? And is it in your surgical field? So if you're doing your frontal sinus approach, you want to know exactly where it is in relation to your frontal sinus so that you avoid it and prevent causing any damage to it, if possible. Obviously, with the larger skull-based resections as yesterday, then you will have to deal with the anterior ethmoidal artery as you come across it. And you can diathermy the artery if needed, if you need a greater exposure and need to be able to clear the skull base on one side. But having a nice flap based on it equally from the other side is a fantastic use of skull-based closure. But I think looking at your scan, studying it right from the front to the back and looking at it in multi-planes is a really useful technique before any sinus surgery to make sure you know exactly where your artery will be running and being aware of it when you get in. Because the main thing we all don't want is one of those retrobulbar hemorrhages, which can be catastrophic to a patient if not picked up and dealt with. Fortunately, I've only ever seen one, but I certainly don't want to see one again. And the patient ended up with a lateral canthostomy and recovery, and then a medial wall decompression back in the operating theatre to prevent any orbital damage. What about you, Ashok? What do you look at, and what do you do to deal with the anterior ethmoidal artery?
Yeah, I mean, absolutely. Anatomy is the key. Knowing where anterior ethmoid artery is the key. And again, if you ever have to deal with anterior ethmoid artery endoscopically, you secure the artery as laterally as you can. So you're left with a good stump, which is unlikely to retract within the orbit. And you mentioned about your horrific experience about dealing with one of the retrobulbar hemorrhage. So for general ENT surgeons, it's important to have that skill set about performing the lateral canthotomy. And if you're endoscopic, you're there endoscopically performing the medial orbital decompression if you are in that situation. And if you know what to do, you don't feel so much scared about it if that happens. So making sure that you have those skill sets and you are able to deal with it.
Absolutely, and picking it up early. Obviously, if you notice the eye swelling immediately in theatre, you're there and you've got access to the medial wall. But once the patient's back in the recovery, you don't know how quickly you can get them back into the operating theatre, or if it's happening on the ward. So having all your juniors know how to do a lateral canthotomy is really important and site-saving for patients. So we try and make sure all our juniors go through the training on the cadaveric courses, so they've had a good go at doing it there. Obviously, it's very different in real life doing it on a cadaver. But once you've had the training, the practice, it gives you the confidence that you could deal with it in future.
Absolutely. I mean, we run the Resection Advanced Phase course, as you know, Catherine, and it's one of the key modules that we teach them about how to deal with these such complications. So I hope Dr. Jain is ready with the surgery. We really look forward to this live surgical demonstration now. So over to Nagpur if they're ready. Great, so we got an endoscopic view. Sounds like they're still setting up. So
the other thing that was interesting on the scan was the thick frontal beak we were looking at on that patient, which can mean you need to get quite a lot of drilling in order to get good access in there. So I think it's really important, say, looking at multi-planes at the frontal sinus. The frontal sinus axis is really important. I always make everybody look in the 3 planes, but sagittal view gives you a great insight into how wide that frontal recess is and how easy your axis is going to be, because it can be a really tricky point, I think, in surgery.
Absolutely. And Dr. Jain mentioned that we would use probably 70-degree endoscope to have any visualization of that area. So when you approach frontal sinus, what are the scopes that you use?
So my standard set just has a 0 and 30-degree scope on it. I will then take out the 45-degree, and if it's a difficult axis, I don't use a 70-degree on every case, I'll be honest. I do quite a lot with the 45, but I do have the 70-degree available, particularly when there's a large frontal beak, like in the case.
Hello.
Oh, it looks like we might be on.
Let's go back. Hello, Dr. Jain.
Hello, Dr. Rokade.
Hello.
Am I audible?
Hello. Yes, you are, and we are back to your endoscopic view now.
Okay,
so that's
you're
fantastic.
getting endoscopic picture?
Yes, we are. Yeah, we just had a chat about your CT demonstration, and we're ready to join the patient now.
Great. So this is, the primary picture which we have not prepared yet. And that is what I'm going to emphasize now. See, in endoscopic sinus surgery, as we discussed on CT scan, this is a surgery of landmarks which with very less margin of safety. To prevent complication, the thing which is required, most important, which is the bleeding. The surgical field. Better the surgical field, better will be identification of the landmark, and more are the chances of preventing complications. If your surgical field is poor with too much of ongoing bleeding, then the identification of the landmarks is difficult, and ultimately you're likely to land up in complications. So the most important factor, what we believe in preventing complications, is the surgical field. And you need to do a lot of things to optimize your surgical field to minimize the bleeding. Our preparation for this starts weeks before surgery. we need to reduce this inflammation and edema in the paranasal sinus mucosa and the nasal cavity mucosa, which is there because of this inflammatory disease. As I said, this is a pure inflammatory disease, and because of the ongoing inflammation, vasodilatation, edema, secondary infection, the chances of bleeding are more. So you have to start giving, for such eosinophilic disease, steroids to reduce the inflammation, oral steroid, a short course before surgery to minimize the inflammation, a short course of antibiotic also to minimize the secondary infection, to optimize the mucosa overall, to minimize the bleeding. Intraoperatively also, you need to do a lot of maneuvers to achieve the same, to minimize the bleeding. And from our side, we do a lot of maneuvers. See what I'm using. I'm using this marrow cell piece soaked in saline adrenaline, topical saline adrenaline, to apply on the mucosa. Gentle application on the mucosa everywhere. To apply adrenaline, diluted adrenaline on the mucosa to decongest the capillaries. This is our principal, way of preparation intraoperatively. This is pure, topical application. Topical application of this diluted adrenaline. Here we have diluted as 1:2. In elderly patient, we dilute even more. In young patient, we don't mind using even pure. Because we are not infiltrating, this is just topical. Say this, even the single application decongests the mucosa like anything. That's the beauty. We never ever, propagate infiltrating any adrenaline or anything decongestant in the nasal cavity. Because this is what we are dealing with is an inflammatory, pure benign disease. If your adrenaline happens to, enter into the systemic circulation, it can have hazardous effects, particularly in labile patient. You never know who is what. And there are complications reported because of the infiltration. So we always, advocate to avoid infiltration in nasal cavity for any region. And believe me, we will achieve the same surgical field what we achieve with the infiltration otherwise. This again we have, experienced in our thousands of cases. Secondly, what we use as a vehicle to, prepare is this marrow cell. What we do, we cut 2 marrow cell into different size, 8 to 10 pieces. We dip the marrow cell in the same solution, squeeze it, use in the nasal cavity, wherever we want, and bring it out, rinse in saline, squeeze, rinse in saline, squeeze, and dip in the same solution to use it again. So you can reuse those pieces throughout the surgery again and again. And at the end of the surgery, the same marrow cell pieces you can soak in steroid and pack into the ethmoidal cavities. The beauty of marrow cell is you can see it is absolutely atraumatic. It is so soft. Second is, it carries the adrenaline to everywhere you want to, even in the narrow areas. You can push in the narrow areas. The beauty is, it opens up the spaces. It opens up the spaces like anything. Like for example, see on the opposite side, because of the deviation, there is hardly any space. Let me use the adrenaline and see how it opens up the space. Not only nasal cavity, but all the narrow areas it opens up. Wherever you push it, it expands. The only thing to stay careful is not to push it hard, because our goal is to apply adrenaline on the surface, not to pack tightly. A tight pack is counterproductive. Now see, this single application of adrenaline on the opposite side has opened up the nasal cavity. See this? Brilliantly. So that's the beauty of marrow cell as a carrier to apply, this adrenaline everywhere. Not to pack tightly, otherwise it is counterproductive. It can lead to venous congestion, and that can invite more venous bleeding and overall poor surgical field. So be careful. Our goal is very clear, to apply adrenaline onto the surface, because the principal source of bleeding in this sinus surgery is capillary, not the arterial. See this capillary decongestion on the opposite side, and it opens up the space like anything. So this
Dr.
is how,
Satish, what is your surgical plan today? I mean, are you planning to perform any septoplasty and any? So what's the
Yes.
overall surgical plan?
So what I will do, my plan is to do full house fast on both sides. I will start on the right side, which is more roomy cavity. Once I finish right side, then I will do a septal correction, a limited correction of the nasal septum, and then do the full house fast on the opposite side. That is the plan for this case.
So there is a question from our delegates. That there's a question from our delegates. They want to know, if you went for a septal correction, will you be doing it externally? That means with the headlight septoplasty or endoscopically?
Endoscopic septoplasty.
Okay, thank you.
So I'll show a technique for the minimal, correction. The correction is, the aim of the correction is two-pronged. See this septal deviation may not be contributing itself to the nasal obstruction, or might be a little bit. So first goal, if it is contributing anywhere in the nasal obstruction, definitely it will clear out. The most important is, it will allow our topical solution post-operatively reaching everywhere. That is the most important role. So the goal of septal correction is two-pronged. See now what I have been doing for the last 10 minutes is this topical preparation. Another thing about the topical preparation is, you don't have to pack tightly and don't have to pack for long. You just apply adrenaline for 10-15 seconds and come out. The effect is going to be same if you apply for 2 minutes or you apply for 15 seconds. So there is no point in doing all these unnecessary things. Second thing what we advocate is, see the patient position. 15-degree head up, reverse Trendelenburg position to facilitate venous drainage from the head. That is very important. Third is BP. See, look at the monitor. We never ask our anesthesiologist for the hypotensive anesthesia. Look at the BP. The mean blood pressure is 115. And I'm fine with that. The most important thing, look at the up right corner, the heart rate, 61. That is what we want. And I'm thankful to our, anesthesiologist for giving me this heart rate 60. This will reduce the cardiac output to reduce the capillary bleeding. So what we want from our anesthesiologist to add on to the optimization of this field is to give us low cardiac output by means of giving us low heart rate. And that is what we love it. And this heart rate, see, in spite of using such adrenaline responses, it is stabilized at 61. See this stabilized at 61, 61, 62, 61, 62, and that is what we want. See, we haven't infiltrated at all. We haven't infiltrated at all, and you'll find ultimately the surgical field to be as good as what we want.
Satish sir,
Yes, please.
I'm from Nagpur here. What is the concentration of adrenaline?
Concentration in this particular patient I am using is 1:2.
I mean 2 ml of saline and 1 ml of adrenaline?
Yes.
Okay. And another concern is
This
whether
is variable depending upon the profile of the patient, age of the patient. We select. In young patient, I don't mind using even pure topical because we are not infiltrating.
yeah, and any role of beta blocker giving preoperatively 2 days prior to get the
This is
bradycardia.
all our anesthesiologist prerogative during pre-anesthetic checkup. If they give anything according to the patient profile, because our aims, we are very clear to them.
Okay, thank you.
I think we also seen a variable practice with the adrenaline point of view. I think it's very commonly used. Even the surgeons from yesterday, they use topical adrenaline. So 1 in 1,000, that's how you get the adrenaline. That's the neat adrenaline, pure adrenaline Dr. Satish is alluding to. Then 1 in 2, that will give you 1 in 5,000. And then 1 in 10,000 is also commonly used to be on a safer side.
See what I have
in
done,
the UK,
sir?
yeah. In the UK, you are quite lucky that we have a cocaine available as well, medical cocaine for topical vasoconstriction. So we use a combination of cocaine and adrenaline, also gives a brilliant feel. So interesting to see the variation in the practices.
Yes. But in any given situation, we always discourage or condemn giving infiltrations in the nasal cavity because it can enter the systemic circulation and have its own consequences. This is what the message I always give. And you stay pretty safe with the topical. With the same effect. See this, what I have given to the inferior turbinate, what I have done. Out fracturing. See this inferior meatus opened up. Without fracturing it, see the nasopharynx, the eustachian tube. For our colleagues, this is eustachian tube orifice, this is torus, behind that is fossa Rosenmuller leading far posterolaterally. This is your middle turbinate. See this middle turbinate, which is pushed because of this polyp. This is the polyp in the middle meatus. This is the first anterior part of the middle turbinate lying in the sagittal plane attached to the frontonasal process. Then this same first part of the turbinate going up and behind and attached to the cribriform plate, high up as I showed on CT scan at the junction of horizontal and lateral lamella. Then this is the second part of the turbinate, which is coursing medially from here. See this turning medially, forming the ground lamella to separate the anterior from the posterior group of cells. That is coronal, plays in the coronal plane. This is ground lamella. See, that is ground lamella lying in the coronal plane. And then this is the third part of the turbinate going in the axial plane behind all the way till nasopharynx. It inserts on the perpendicular plate of the palatine bone or even to the sphenoid in the roof of the nasopharynx. So this is all, this turbinate is very important. We need to respect this turbinate. What all this turbinate need is respect. And what we can do for that, just don't disturb this. Don't disturb this turbinate. Don't manipulate too much with the turbinate so that it remains medialized and the ethmoidal axis remain opened up. Then the further anatomy in the lateral wall, if you see, this is your inferior turbinate, below is the inferior meatus where the nasolacrimal duct opens. That is not our area of interest in this case. Then this anterior flat area and some prominences. See, this first prominence belongs to the nasolacrimal system. Behind that, this second prominence, see carefully, this belongs to the uncinate process. This is a vertical part going variably high up. Most likely it inserts laterally onto the lamina, but it can be somewhere in in unusual cases can insert on the turbinate or the skull base anywhere. You have to stay careful. And posteriorly, this horizontal portion, it goes variably behind, either to insert on the perpendicular plate of the palatine bone or merge or ends in the inferior turbinate somewhere. So this is uncinate, and how to identify even in the massive polyp situation when it is deformed. See this, best way. See what I am doing. only mobile structure in the entire lateral nasal wall is this uncinate. No other fixed structure, no other, regular structure is mobile. This prominence belongs to the nasolacrimal duct. Behind that is bulla going to be, which is obviously compressed because of the polyp. And this is your uncinate, which is a mobile structure. So now my first part of the surgery, it starts with a debridement of these polyps in the middle meatus. See what I'm using is a geomet shaver, micro debrider. And what for the junior colleagues, once they use the shaver, it has to be used under vision. See this, bring the shaver at the nasal cavity and follow with your telescope. Bring out under telescopic vision, introduce under telescopic vision. While cutting, keep all the cutting edges in view. See this. Never use blindly. Never use blindly. See this? I am just taking off all these polyp prolapse in the middle meatus. See this? Olive. See, this is your uncinate and this is your bulla ethmoidalis. Obviously, the bulla is, compressed because of the polyp mass. And if I show you, this is your ground lamella, see turning, and behind the bulla is the retrobular recess. Can you see? This is bulla.
Yes, we can.
Anterior to the bulla, between the uncinate and the bulla, is the hiatus semilunaris inferioris. This is hiatus semilunaris superioris between the bulla and the middle turbinate. And this hiatus leads laterally into a three-dimensional space here in fundibulum, into which laterally opens the maxillary sinus ostium. So, I told you in the beginning, this is the surgery of landmarks. At every movement, you have to discover the landmarks to progress further. If you are disoriented and lost the landmarks, you are likely to give complication. See the beauty of the marrow cell. After every step, you can use this soaking in adrenaline and applying to the same area to achieve the field. Look at the field. Look at the surgical field which I have not infiltrated. Every time you have to optimize your surgical field. Dr. Rokade,
Yes, Dr. Sati.
are you happy with the surgical field here?
Yes, brilliant. Yeah, it's a good decongestion. We have all
Only
the
topical.
landmarks in view.
Only topical. See this. If your landmarks are not visualized, you're likely to give complication. Single biggest reason to the complication is surgical field.
I
Now,
will re-emphasize to our viewers that how meticulous and diligent Dr. Satish is about getting the right field, right decongestion, and right visualization.
now see, the surgery starts, the endoscopic sinus surgery starts with uncinectomy. There are many ways, I remember the Professor Stemberger's initial teachings when the Messer Klinder and Stemberger devised this and propagated. They would use the sickle knife to remove this uncinate in toto from the lateral nasal wall till end. You can do that. But over the period of time, what we realize, I will show that. What we believe, this uncinate, upper part of the uncinate, is the closest structure to the orbit. If you are not careful, even during the first step of the surgery, uncinectomy, you can enter into the orbit accidentally, and then that will disappoint you, that will, ruin your temperament, and the entire thing is spoiled. So our policy now, is to use a reverse biting. See this reverse biting tool? Reverse biting forceps, open it, engage in the hiatus, turn it little down to stay away from the nasolacrimal system and bite through. See this? Engage again, advance further anteriorly, bite through. Engage again, advance anteriorly, bite through. Now see, I can come across the hard bone. I can feel the hard bone here. Beyond this, that is could be very close to nasolacrimal duct. So that is the point which makes me stop. See now, what I have uncovered is infundibulum. This step, what I have done, is called infundibulotomy. See this three-dimensional space I have opened. Inside is infundibulum. Can you see the infundibulum? This three-dimensional space is infundibulum. And what is there opening in the infundibulum? See the glimpse. That is the maxillary sinus opening. See that? How will I open up? See this. This is infundibulum. This is infundibulum, and here open the maxillary sinus ostium. So what I'll do? I will fracture the lower part of the uncinate. See this. I can fracture the lower part of the uncinate here. Open up the maxillary sinus. See this? You can remove with a shaver. See, this is lower part of the uncinate. I have fractured a bit. I can take this with a shaver, with a through biting, whatever. Can you see the interior of the maxillary sinus with this? Glimpse of the interior of the maxillary sinus. That is the maxillary sinus from inside. And this is the uncinate plate. See the horizontal uncinate plate. See this? Can you see very clear?
Yes, Dr. Sati.
And see now, I can widen this middle meatal antrostomy. This is my maxillary sinus. What I can see, a lot of secretions inside. Can you see? See now how big this middle meatal antrostomy can be. People have defined from type 1 to type 4, but it all depends upon the need. All depends upon the need, you know. In massive mucosal disease, yes, we give a mega middle meatal antrostomy. In a limited disease, you are not supposed to. This is my middle meatal antrostomy. Can you see very clear?
Yeah.
This is not a mega one, and I don't need that as well. The reason being, I don't see any massive disease inside the maxillary sinus. There is disease, minimal secretions, the mucosa looks not bad. See the secretions?
Mucin.
Looks like some fungal material as well.
Yeah.
See, fungal mucin, looks like fungal mucin. The mucosa is, see this, good, reversibly, you know, damaged kind of edematous mucosa. What all you see is this fungal mucin. And so I will wash thoroughly, clean that mucin thoroughly. See the middle meatal antrostomy?
Yeah. Yes.
Where?
All secretions cleaned off.
Yeah.
This is type 1 to me, type 1 sort of enterostomy. If I need a bigger one, as there been massive disease, I could remove this entire medial wall right till behind the posterior wall. Could remove this entire bone. This is part of the perpendicular plate of the palatine bone and flush it with the posterior wall, but not needed. Even more required in massive allergic fungal sinusitis, I can remove this part of the inferior turbinate and flush it with the floor. Type 3, or even do a medial metal and medial maxillectomy type 4, which is rarely needed for such kind of disease, inflammatory disease. That is more required for other indications, tumors and other things, dentigerous cysts, other lesions. So give me 70° at the same time to give you an inside view of the maxillary sinus. See with the 70°?
Yes, sir.
See, there is still a lot of secretions.
Yes, sir.
Hello?
Yes, sir.
Yes. So wash. So this requires more and more, flushing. See the secretions here, lodged here. Much better now.
Yes.
Still, we will, mop with the marrow cell.
So this
So that's-
finding, Dr. Satish, is going to change your medical management further from the
Pardon?
I-
This finding.
yeah, this
Yes.
finding. What is
Yes.
your medical management after finding
This is
this?
basically, allergic mucin. This is a variant of fungal sinusitis, allergic fungal sinusitis, though it is not very massive, but this requires long-term surveillance, long-term steroid irrigation, because this is allergic. This is
Okay.
pure type 1 hypersensitivity. This is not invasive fungus or anything warranting antifungal. So this requires more long-term, irrigations, more long-term surveillance to prevent the so-called recurrence. May require allergic testing and immunotherapy as well, if needed.
So do you send this for any microbiological
See what I am
assessment?
doing? I am removing trying to remove each and every bit of fungus, because this is allergic mucin containing fungus as an antigen. Here fungus acts as an antigen, which invites the eosinophilic reaction. This is pure antigen antibody reaction, and if this fungus is not removed, this can incite the reaction again. Now it is pretty clear. Can you see?
Yes.
In difficult, maxillary sinuses, when you need a more extensive, see it is dislodged, coming out because of the marrow cell mop. This is,
Sir, are you going to leave that upper part of uncinate, or
pardon?
the upper part of uncinate, vertical part of uncinate?
Upper part of?
Uncinate.
Yeah, we'll remove. Sometimes we use hydrodebrider to remove this, mucin. This is sometimes very, very, frustrating. Adherent. And we need a strong suction now. More and more irrigation, dislodging it. Yes. Now. So this is how you need to clear it more effectively. Sometimes it is more and more, this loss to the lateral recess of the maxillary sinus or far anterior, not able to access in spite of the curved instrument. Then I can come with another port from the sublabial route with my telescope from the nose and my debrider and suction from the anterior part to tackle that most inaccessible, which is not required in this case, but in other massive diseases in that region. See this, dislodge with the marrow cell mopping. What an interesting finding. And see, this marrow cell is so atraumatic to the mucosa. This is absolutely atraumatic to the mucosa. Fine. Now, this was with the 70 degree. Now, coming back with the 0 degree. Now, my next goal is to remove the upper part of the uncinate. See what I'm using. I told you behind this upper part of the uncinate, the closest structure is the orbit. I'm going behind this with my angle curate, going high up, and getting it fractured anteriorly. See this? Getting it fractured anteriorly, away from the critical structures behind. I'm getting it fractured anteriorly, and this is a very, very safe movement. That's the uncinate plate. And now you can shave it off. At this point, be careful. I will show you what I was saying. This is closest to the
Orbit.
lamina papracia, and at this step only during uncinectomy we define our lateral limit of the paranasal sinus corridor. That is lamina papracia. See, this is lamina papracia.
Yes.
That is lamina. Can you see?
Yes, sir.
Yeah.
And so at this point of time only, at the beginning of the surgery, we can define our lateral limit of the entire, paranasal sinus labyrinth. Now see what I have done. Remove this and uncovered some recess. Completely uncovering this. Can you see this?
Yes, sir.
Yeah.
This is your Agarnesi bone, Agarnesi cell. See, laterally this is lamina. This is your bulla ethmoidalis. See, this is your middle metal antrostomy. This is your lamina papracia laterally here. This is your bulla ethmoidalis attached to the lamina. High up, going high up. And this cell is uncovered. See this Agarnesi.
Yes.
And see this upper part of the uncinate forming the medial wall of the Agarnesi. See the beautiful anatomy here. I hope you are all oriented.
Yeah, yeah.
Yes.
It's quite clear.
Now, at this point of time, I will change to 70 degree. See this, the Agarnesi uncovered. See how the Agarnesi is lying anterior to the axilla as a prominence. See where the Agarnesi lie. This is axilla of the middle turbinate, and this Agarnesi is lying anterior to this as a bulge. This is what Agarnesi is, which is bounded medially by this uncinate process. This uncinate forms the medial wall of the Agarnesi. And then it turns laterally above the Agarnesi, behind the Agarnesi, to insert on the lamina papracia. making the frontal recess pathway lateral, medial to it. At this point of time now, back. I will change to 70 degree now. Let me, after this step, like after every step, back with the marrow cell. Optimize the field. See, at no point of time you're supposed to traumatize the lateral wall, medial wall, inviting the synechia. You have to bring in and out your endoscope under vision. Now with the 70 degree. This is my preferred telescope for many regions. This is a versatile telescope. See this now. 70 degree, this is your middle metal enterostomy. With 70 degrees, see your lamina papyracia all the way.
Yes, sir.
Are you able to appreciate?
Yes, sir.
This is your lamina papyracia. This one, this is the medial wall of the orbit. See this thin
Yes, sir.
bone. And this is your bulla, which is attached onto the lamina papyracia. And this is your Agar-Nagy cell. And this Agar-Nagy is like sitting on the mouth of the frontal drainage pathway. How can you see this? How can you remove this? Agar-Nagy is always attached to the anterior wall of the frontal pathway. How can you go? See this. This is your uncinate. See this uncinate? This is your turbinate. I mentioned all the time. When you use instrument in the frontal recess, always direct laterally. For all the cells which are attached to the anterior wall, the treatment is go behind and fracture them anteriorly. See this?
Yes.
Agar-Nagy fractured out, and this will open up the frontal recess. Now I'll tell you why I have taken the 70 degree for regions. See, I have fractured the Agar-Nagy. Why I have taken the frontal the 70 degree? Because I want to see high up and work for this under vision. We follow the technique of our beloved Dr. Dharamveer Sethi from Singapore, where he propagated intact bulla technique. Intact bulla technique means, see, my bulla is intact below. And before I remove the bulla, I will remove the, I will work for the frontal recess, frontal sinus work, and keep the bulla intact for the regions. Regions means this bulla goes up to insert on the skull base. And it inserts on the skull base up anterior to the anterior ethmoidal artery. That means as long as your bulla remains intact, your anterior ethmoidal artery is automatically protected. I showed you the course of the anterior ethmoidal artery coursing through the roof to the skull base far behind. And yet another, this bulla is a landmark to show you your anterior ethmoidal artery. Now see, why 70 degree? Because this frontal sinus surgery, as surgeons are frightened with complications, with giving complications. Number one, since it is close to the orbit, the orbital complications are not uncommon while you're working in the frontal sinus. See this frontal pathway, see this frontal pathway. Second is, this turbinate is a great, anatomy protecting or entry from the skull base into the skull base as long as we stay lateral to it. As long as we stay lateral to the turbinate, we are not going to enter the skull base. See the turbinate. The skull base is medial to it and above. Lamina is here. As long as we stay lateral to the lamina, we are safe. As long as we keep the bulla intact, we are safe from damaging the anterior ethmoidal artery. And see these three landmarks with 70 degree, you can see all of them in one view. Can you?
Yes, sir.
Yes.
Yes.
And that is the beauty of 70 degree. Why I'm using 70 degree here? Because I can see all my three limits which I am not going to violate to prevent complication. Limit number one, once again, that is achieved only with a 70 degree. See, I am working, I have to work in the frontal here. As long as I stay lateral to the turbinate, I am not going to damage the skull base and CSF leak. This is lamina. As long as I don't cross this limit, my orbit is protected. This is bulla. As long as I keep the bulla intact, my intraethmoidal artery is protected. So all these things, my 70 degree allows me to visualize in one picture, and that will help me reaching out my frontal sinus work without any issue. See this.
Yeah, very clear.
I hope it is very clear.
Yeah.
See, with 70 degree, everything is in under vision. Now, what I am trying to show you, these are polyps. I showed you one thing which I am going to, work all the way as my best frontal sinus landmark. I told you about the beak.
Yes.
Believe me, my frontal is waiting for me to enter. See how? You can see this axilla very clear.
Yes, sir.
Axilla, see what are the best landmarks which are easily accessible. So always use landmarks which are easily accessible. So axilla is one landmark one can easily see where this turbinate is attached to the lateral wall. See there?
Yeah.
Now inside the axilla, once you open the axilla and go with the frontal, go with the 70 degree, the next structure you see in the roof, see that? This is your beak above. See this? This is your beak.
Yes.
Can you see there?
Yeah, yeah. Now it's.
This is the thickest bone in this region, this beak. This is the beak. See? See this? This is how thick it is. Now, if I keep my lateral limit, medial limit in view and go along the beak, this will lead me nowhere but to frontal sinus. I am in the frontal sinus there up. See that?
Yeah.
Yes.
So the beak is my best guide. I'll tell you. In the simplest of way of entering into the frontal sinus. See this.
Yes.
See this. In 1 minute's time. See this. This is my beak. I will stay laterally and medially between my limits. Follow my beak. Follow my beak. See, this is my lateral limit. This is my medial limit. In between them, I will follow the beak, follow the beak, follow the beak. And I am in the frontal. That is my frontal sinus up. That is my frontal sinus up there. See carefully.
Yes.
It cannot be anything else in any given circumstance. See this? That is my frontal sinus up there. Can you see the frontal up?
Yeah, yeah.
Yes.
Very.
See, highway to the frontal sinus. See this? That is frontal.
Oh,
See
very
this?
nice.
Yes, sir. Very nice.
Simplest way. You cannot damage anything. The 70 degree allows you to see your all limits in one view. My medial limit here. My lateral limit here. Follow the beak in the middle and follow the beak and go there. That is frontal. See, this is your beak anteriorly, this one. Follow the beak where the beak ends is the frontal. See the frontal behind. So simple. Believe me, it's not that. You do it, experience it, follow the landmarks, use 70 degree, your frontal is all there, up in the middle of your limits. Believe me, out of all sinuses, the frontal is bound all around by the bone. If you follow the landmark, this is simplest to, identify and reach out. The reason being the thick bone all around. The only thing this requires is 70 degrees. So during cadaver dissection, we always, propagate everybody to get used to 70 degree, to get used to identifying landmarks with the 70 degree, to get used to instrumentation with using the 70 degree. See, that is your frontal sinus up. Very clear?
Yes.
Sir.
And see what is there up above, that is your beak. This is your turbinate. I told you the best treatment for the turbinate is respect. This is your lamina.
Lamina, yeah.
This
That
is
is-
your beak. And in under the beak, when you leave the beak, go behind the beak, that is your frontal sinus. Nothing else. That's it.
Marvelous, absolutely.
I hope it is very clear.
Yeah.
Yes, sir.
Yes, it is. Yes.
Let me clean the field.
So what is your further plan for frontal sinus, Dr. Keech? So it looks like, Catherine, you got a frozen picture.
I think I'm back on now. Ashok, can you hear me? Okay.
Yes, I can hear you.
But the screen for me is frozen. Are you still seeing
Yeah.
the frontal sinus? Ah, we're
Yes.
back in. That's better.
Yes, probably there's some connectivity challenge from Dr. Sati Jain Center.
Cool.
So I think,
I think-
so far, what do you think so far with the surgery?
Nice case, really clear demonstration of how to do a safe uncinectomy, making sure that you're protecting your lamina on the way through, a nice medial meatal antrostomy. Interesting to see the allergic fungal mucin. And I like the Mericel patties. I use those as well to clear it out. And my registrars know I use them like a mop, particularly if there's fungal sinusitis and it's really difficult to get around all the maxillary sinus. So I quite often use the Whovisor with one of those patties on and wipe around the maxillary sinus, or a
Absolutely.
curette with a patty to clear it out. So it was quite nice to see somebody else using that technique as well. So it was good to see it being cleared. And then going up and clearing the remainder of the uncinate and getting a great view into the frontal sinus at the end, protecting all the landmarks on the root and showing the real key and anatomical structures as we went through. So you had your middle turbinate, you weren't disturbing the attachment of it, opening the aga, which is quite a nice big aga to give you access on up into that frontal sinus, and clearing all the polyps on the way up. Interestingly, I usually send my polyp from each side for histopathology. We like to get an eosinophil count on the polyps if we can. So not that we are able to give biologics at the moment to patients unless they have asthma in the UK, but certainly in the future, we may have more tailored medications we can use. So having an underlying eosinophil count and knowing the type of inflammation the patient's got is quite useful. But yeah, nice case to see. It's good.
Yeah, absolutely. I mean, it's a good practice to get the histological assessment and better with the eosinophilic count if you are able to. And I agree with the technique of using the Mericel patties and dealing with all the mucin in the sinuses, making every effort. So what I appreciate is diligence and meticulousness in achieving the good decongestion, good access. And if there are any trainings, it's a fantastic place to see. And how to feel confident without fearing of these scare structures, as we say, the anterior artery, the skull base, the orbit. These are the three things when we are really worried about when we're doing the sinus surgery. So he gives a very good structured approach about protecting the structure so that the younger surgeons should feel more confident. If they know that get the lamina intact, they know they're not going to penetrate the skull base. They can see where their lamina patricia is, and they're not going to damage it. And intact bulla technique, thread technique, and that protects your anterior artery. You know you're safe on that count as well. So 3 great tips when approaching the frontal sinus.
Yeah, absolutely. And also really nice just to demonstrate to everybody the retrograde uncinectomy. I always do it and teach all my trainees to do a retrograde uncinectomy rather than the old style sickle knife anteriorly, to make sure that you're protecting the lamina all the way through, and you're not likely to go into the orbit straight away. So really nice methodical steps as we go through the case, which is brilliant to see.
Absolutely. It should be a gold standard now doing the retrograde uncinectomy.
Yeah.
Hello.
without a shadow of a doubt.
Hello.
Hello, Dr. Satish. Yeah.
Yeah, are
We're
you
back
getting
with you
the picture
again.
back?
Yes, sir. Yes.
Yes, we got the
There
picture
was
again.
some power interruption. We
Okay.
apologize
So-
for that, and we are back with
No
the.
worries.
So we
So
didn't.
that gives us an opportunity to re-emphasize the key things that you demonstrated today about performing the safe approach to the frontal sinus. So my question where we ended was, what is your further plan for this frontal? Are you happy with the opening that you have created, or are you going to widen it even
So
further?
our plan is to give the maximum possible opening to prevent restenosis. And at this point now, what I want to say, this is frontal sinus, and we have a huge supraorbital cell we saw on the CT scan.
Yes.
And what I'm doing now, see this is bulla below,
Yes,
and
sir.
there is a suprabular cell. Can you see the suprabular cell?
Yes.
Yes, sir.
So see now what I'm using, the tool I'm using is the reverse blade, the so-called adenoid blade. Can you see?
Yes.
This
Mhm.
becomes the front-facing blade with a 70-degree now. See now? The reverse blade, the so-called adenoid blade, becomes the front-facing blade. We can use it.
What is the angle on the blade, Dr. Satish?
This is adenoid blade. यार क्यों छेड़ते हो बीच में यार? Just a minute, sir. There was a
Yes, sir.
suction blockage.
No worries. Just checking on the angle of that adenoid blade.
Yeah. So that adenoid blade is actually a reverse facing blade, and we condemn it using for adenoidectomy because it's a rear facing blade and you actually don't see the cutting edges over there. So here with using with a 70-degree, it becomes a front facing blade, and you can actually work at the skull base with the 70-degree using this blade under vision. See the frontal sinus? So we call it as a skull base blade. We never recommend to use this blade for the adenoidectomy because there it is a rear facing blade. For microdebrided to be used safely, you are supposed to use it under vision. Now see, I can work at the skull base with this, with safety, because my cutting edges are under vision. Can you see?
Yes.
What I am removing is this supraorbital cell, suprabular cell.
So do you tackle with this cell before you tackle with the bulla?
Yes, bulla is still intact, which is my
That's interesting.
safeguard to the anterethmoidal artery. See, I am working at the frontal sinus. I am working at the supraorbital cell, yet I am not bothered about the anterethmoidal artery. See this frontal sinus. I am least bothered about the frontal ethmoidal artery yet because my bulla is covering it. I will show you once I remove the bulla how it was protecting my artery. God has given us such a fantastic landmark, and we are indebted to Dr. Sethi, Dr. Dharmveer Sethi from Singapore, for bringing this to our, appraisal and popularizing this. I am diehard fan of him for his technique, this intact bulla technique, which is really, So so useful.
It is interesting you mentioned about Dr. Sethi, and GRN has a very special relationship with him. So he was the first surgeon to perform live surgery for our first ever live surgical event. That was in 2013. So he broadcast all his frontal sinus surgical techniques from Singapore.
Yeah.
So, great surgeon, and really privileged to have you as our surgeon who inaugurated GRN.
It's superb. And we are lucky to be his friends, his students. See this frontal sinus, and this is the suprabular cell I have taken off. This is my skull base behind. See that?
Yeah.
See my bulla. This is my bulla, and see where the bulla is going to the skull base. See this bulla is going to the skull base. See this? See with the 70 degree, this is bulla. And this is going all the way to the skull base, and where it is attached to the skull base, the anterior ethmoidal artery is behind that. That is what the anatomy we are exploiting actually. Now, 60. To widen the frontal sinus to the maximum. Earlier people would calculate that 8 mm opening, 1 centimeter opening, this opening is adequate. You don't believe it is because every sinus anatomy is different. You can widen maximum possible to the limits. See my lateral limit is orbit. So I'm widening this till orbit. See the frontal sinus?
Yeah.
Everything under vision with 70 degree. So that I can give the maximum limit, lateral limit, lamina. See my medial limit, turbinate.
Yeah.
And see my inferior limit, the posterior limit
Bulla.
is this bulla. And that is what now I have opened this frontal to the maximum. I will still widen the bony partition between this and the supraorbital to give a more wider opening. See now, that is your frontal sinus. Adequate opening?
Absolutely.
That is your frontal sinus. Remove the suprabular cell. Again to reorient you. My limits which made me do this, this is medial limit, turbinate. This is lateral limit, orbit, and this is anterior limit, beak. See the beak, thick bone. See now how this thick bone ended behind into the frontal sinus. Can you see?
Wow. Yeah.
So when you see this thick bone, the beak, even if you are blind and going behind, following your medial and lateral limit and staying between them, you cannot go anywhere but in the
Frontal sinus.
frontal sinus. That is the beak. And see, in this beak region, there is no critical structure in the beak region. No critical. This is most anterior structure. That's why the draft techniques are very safe technique, because you work in the area where there is no critical structure running through. Only you have to be careful about the medially skull base, laterally orbit. And to guide, to prevent entering there, crossing your limit, there are landmarks which are under vision. See that? Frontal sinus again and again. I hope it is very clear to everybody.
Yes.
It is like a box. It is like a box. See my frontal sinus work, keeping the bulla intact. Yeah. See, everything done with landmarks in view. We have done medial meatal enterostomy. We have done frontal sinusotomy. We have removed the suprabular cell. What is to be done with 70 degree, we should understand. Now, the most important thing I am going to show you, why intact bulla. What bulla was doing for us so far. See this. See the frontal and see this bulla. See this bulla, I am elevating this bulla now. See this? See this bulla.
Yeah.
And see where it is going and where the artery is running. You will never forget in life. Why we are making noise of this intact bulla? Why it is useful? It's not that Dr. Sethi described, so it is useful. It is really useful. See this. See, this is bulla here.
Yeah. Yeah.
This is bulla, and this is attached here. Some fungus. See some fungus material?
Yeah.
This is the upper attachment of the bulla which I am dividing. See this breaking. That is the upper attachment of the bulla I am breaking. See a lot of this fungal material there, inspissated fungus, mucin. So the stronger. See the. Now I am working at the anti-ethmoidal roof. My limits are very clear. My turbinate all the time in view. See now carefully once I have removed this. That is your anti-ethmoidal roof. See this?
Yeah.
This is your anti-ethmoidal roof, and this is your vessel which is running behind. Can you see that?
Yeah. Yeah.
I will show you. Let me remove this bone first. Reverse. I'll make it very, very crystal clear for you all. See this, again my reverse blade to define. See this, this is skull base. This behind is the ethmoidal roof, this is frontal sinus. And see, this was the attachment of the bulla. And this is where the anterethmoidal artery is running. This oblique structure running is the anterethmoidal artery. Can you see this? Underneath my debrider, this one.
Yeah. Yeah.
Hello?
Yes.
Yeah. Yeah, we can
This
clearly
is your
see.
frontal sinus. See this?
Mhm.
Behind the frontal sinus, this is your supraorbital recess. See, far laterally going up.
Yeah.
And behind the supraorbital recess is your anterethmoidal artery. So clear.
It's so
This is your
weird.
frontal sinus.
Mhm.
This is your supraorbital recess. This is your ethmoidal artery. And this is part of the ethmoidal roof. I hope everything is very clear.
Yes, beautiful. So,
So,
very
Let
graphically
me
shown.
clear more. Let me remove this bulla. So there are variety of, see, this could be a bony, attachment of the part of the bulla here, thick bony attachment. So now let me remove the bulla completely.
hello.
Yeah. Right.
Sir, when we take the specimen for biopsy at the start of the procedure or in between when you feel?
Pardon?
Sir, when we take the specimen for biopsy?
The specimen
For biopsy.
from,
For histopathology.
so you take the polyp. If it is a polyp, the best,
Okay.
most representative is the polyp. Now, I'm taking off this bulla. See this? Rest of the bulla, the lower part, same movement, Safest one, go behind the bulla. This is retrobular recess and fracture anteriorly. See this? See this bulla? This is attached laterally to the lamina. Attached laterally to the lamina. This is bulla completely coming out. Now, since we have done the work above, I will change to 0 degree now. See this bulla which I have fractured out, it's now a garbage. I can remove it. And what is their structure behind this bulla? This is ground lamella. So now I can remove this bulla easily. See this? I can flush its attachment with the ground lamella. That's the ground lamella. Oh, lamina papyracea. This is lamina papyracea where the bulla was attached to. See very carefully. That is lamina papyracea where the bulla was attached to. So now we can see even with the 0 degree the roof of the ethmoid. I hope the picture is very clear for you. See the
That's really-
frontal with the 0 degree, frontal with 0 degree. See inside, that is beak, supraorbital recess. And this was the attachment of the bulla to the lamina papyracea which I have flushed. See, it is completely flushed. So all the remnants of the bulla are out. And what you see now in front of you is the ground lamella. Ground lamella is nothing but the second part of the middle turbinate lying in the coronal plane. Wash. So now my picture is very clear at this point of time. See the entire frontal sinus,
Hello, sorry, we seem to have some disconnection again from Jaipur. So we are back in the studio. So reminding our viewers that we have a whole day planned today of live sinus and skull base surgical procedures. Professor Hisham Saleh from Charing Cross Hospital in London will be performing live along with Dr. Satish Jain, who had started his first case endoscopic sinus surgery and has taken us through the few basic first techniques. So this might be an opportunity while we're waiting to join to visit our supporters, Medtronic and Carl Stolz. Without their support, such event is not really possible to make available. So can we play some short Medtronic and Carl Stolz informational video at this point?
क्या हुआ इधर क्या हुआ सीन नहीं झेल गया ट्रांसमिशन आ रहा है क्या मैं तो तैयार हूँ तो
check. Hello, check test. Hello, check, check. Hello, check. Hello, hello, check test. Hello, check. Hello, check 1 2 mic test. Hello, check. Hey, hey, check 1 2. Check, check, test. Hey, check test. Hello. Hello, hello, mic testing. Hello, 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 hello. Check test. Hey, hey, test. Check test. Hello. Hey, hey. Hello. Hello. Check. Hello. Hello. Check 1. Hey, hey. Hey, check test. Hey, hey. Hello. Check test. Hey, hey. Hello. Hello. Test.
Hello. 1 2 3 4. Hello. Check 1 2 3 4 mic testing. Hello.
Hello.
ठीक है?
Hello. Hello.
Hello.
Yes, auditorium.
Yes, sir. We can hear you.
Okay. Are you getting endoscopic picture?
No, sir.
No picture?
Now we are getting.
Yes. Hello, Dr. Rokade.
Hello, Dr. Satish. Yes,
Please,
we
sorry
just,
for the interruption again. Only light bulb. So,
it's fine. Are you ready to join?
now we are all
We'll,
set for the rest of the work. So, what I was trying to tell you is this. I am back with 0 degree now.
Yes, sir.
What we have done so far is middle meatal enterostomy. You can see complete uncinectomy. You see our limit, the lamina papyracia. The turbinate, we have removed the bulla. We have seen the open the frontal sinus, widen thoroughly. That's the frontal sinus, supraorbital recess, anti-ethmoidal artery. I hope everything is very clear.
Yes, sir. It's very clear.
Now my next work, see what structure you are seeing in front of you is the ground lamella. Why I'm saying again and again, all sinuses, what we have done so far, they drain anterior to the ground lamella. This is ground lamella. And now the group of sinuses which drain behind the ground lamella are left behind. So those are posterior ethmoid and sphenoid sinus. Those are very, very important sinuses, and you need to know the fact that majority of the life-threatening complications happen to occur in these posterior group of sinuses work. 100 years ago, the Mosher had described easiest way to kill a patient, anybody, is to do an ethmoidectomy. And he was referring to the posterior ethmoidectomy. The reason is very obvious, still holds true. The reason being, while doing posterior ethmoidectomy, if you are not careful, disoriented, and enter accidentally into the sphenoid without realizing it, one can damage carotid artery even. That can be fatal. So, the posterior group of sinus work, the posterior ethmoid and sphenoid, is very, very crucial for a sinus surgeon to understand and do in a systematic manner, safest manner, which I am going to share with you now. Now, this is all ground lamella. See very clear how the turbinate first part in the sagittal plane is turning into the second part, that is in the coronal plane. Is that clear?
Yes, sir.
Now, before going there, I want to develop a new landmark. See what I am doing at this orbital site. This medial orbital angle, inferior orbital angle, see this. I want to refer and develop a landmark over here. See the roof of maxilla?
Yes, sir.
Roof of maxilla, will use it as a reference. We call it as a maxillary line. You can call it anything. See this landmark. This is very, very important. Life-saving landmark, I tell you, which we always follow to protect all critical structures from behind get injured. Prevent them get injured. See this? The roof of the maxilla. This we call maxillary line, and I will enumerate again and again why it is so important for the posterior work. First of all, where to make an entry into the postoperative, at what level and why? You have a ground lamella, this big ground lamella, you can enter anywhere. Where to enter? Enter at the level of the maxillary line, means this line where the roof of the maxilla is. This line medially where the first part turns into second part. See this?
Yes, sir.
Can you see my entry into the ground lamella?
Yes.
This is my entry into the ground lamella. Just entry. See this? To enter into the postethmoids. Can you see? Now, my biggest concern is while doing postethmoidectomy, I may accidentally enter into the sphenoid sinus curve. That is my biggest fear. And many a times, certain anatomical distortions can make you do it unknowingly. Like if there is an onodi cell is what? One of the postethmoidal cell, this is postethmoidal cell, which grows above and behind the sphenoid sinus. What we are supposed to see behind the postethmoid should be sphenoid, but it's not like that. If one of the postethmoidal cell grows beyond the sphenoid, it can take you behind and above the sphenoid to injure the carotid artery or optic nerve easily, if you are disoriented, if you don't know this fact. So our concern is to prevent accidental entry into the sphenoid. So the technique we have developed, which I am going to show you straight. Technique we have developed is, we have to define our safe limit. We'll open the sphenoid sinus first and then accomplish the postethmoidectomy, staying anterior to the anterior sphenoidal wall, so that we accidentally don't enter into the sphenoid sinus. Let me tell you what I am trying to say. See, this is opening in the postethmoid. What I am trying to say, I don't intend to do postethmoidectomy at this point of time, because I don't know where my postethmoid ends behind where the sphenoid starts. What I'll do, I will take a medial turn. See this, what I'm doing. I'm going medially. Medially, look for some certain structure. See this. I'm not going behind. See what you see there?
Superior turbinate.
Superior turbinate. Can you see?
Yes, sir.
That's the superior turbinate. And medially, this is nasal septum. See that?
Yes, sir.
And between superior turbinate and nasal septum is what?
Sphenoid sinus.
The
We can see.
sphenoid ostium.
Yes.
See what I'm trying to say. What I'm trying to say, I don't intend to do post-ethmoidectomy at this point of time because I need to define some landmark to prevent my accidental entry into the sphenoid. This is a life-saving step. If you are disoriented, you can even damage the carotid artery and optic nerve. And it happens. It has happened in the past several times at many places. So this technique is designed to prevent almost certainly those complications. See what I have done? Entered into the ground lamella and took a medial route and went on to see my superior turbinate and
Sphenoid ostium.
nasal septum and
Yes.
in between them sphenoid ostium. See this. This sphenoid ostium, see this is important point to be noted. This sphenoid ostium, you need to see flush to the septum. I will show you. See, I am in this window, medially extended window between the see this, what I have opened up. See this? What you see
Yes.
there?
Very nicely seen sphenoid ostium between
Sphenoid
the.
ostium, one side decongested. See the
Yes.
landmark. This is your superior turbinate. This is your nasal septum. In between them, if you don't see the ostium, see this is my maxillary line. Can you see?
Yes.
Never ever go above the maxillary line to look for the ostium. That is life-saving, what I said. See, this is the level of the ostium. See the maxillary line.
Yes.
Always look at the level of the maxillary line or below for the sphenoid ostium. The reason being, this ostium is never at the level of the floor. This ostium is more close to the roof.
Yes.
If you try to look for the ostium above, you can enter into the cranial cavity and give complications. Got my point?
Hmm.
So, to follow this maxillary line and look for the ostium if you have not seen, close either at the level of the maxillary line or below it, not above it, never above it. Above it, you are likely to enter into the middle cranial fossa. See now, suction. Now, I will widen this ostium. See, I have not done the posterior ethmoidectomy yet because I want my posterior limit of the posterior ethmoidectomy to be seen first. See, flush to the septum. Always look for the sphenoid sinus. See, this is septum.
Yes.
Flush to the septum, not flush to the turbinate. You may be directed in a lateral cell. Always go
Medial.
flush to the septum. See, this is my sphenoid sinus. Can you see very clear?
Yes.
Now, I have an amazing guide for my posterior ethmoidectomy. See my limits of the posterior ethmoidectomy now. I will remove everything staying anterior to this ostium. See, this is my guide. If I stay anterior to the ostium and remove everything, my carotid artery and optic now cannot come. In any given anatomical abnormality, variation, the carotid artery and optic now cannot come anterior to this ostium. So now you are 100% safe if you follow that ostium as your landmark. So what we did, before doing post-ethmoidectomy, we developed a landmark, that is sphenoid ostium. The lateral limit is lamina. See, lateral limit of post-ethmoidectomy is lamina. I can debride everything safely without any fear of damaging anything. As long as I stay anterior to the sphenoid ostium, I am 100% safe. That's the point I wanted to emphasize. See, any cell can take you deeper. Never follow. Only follow the sphenoid sinus ostium. See now what I am doing? I am removing this lower third of the
Superior turbinate.
superior turbinate. See this? Flush the sphenoid sinus. Opening. This is my sphenoid sinus opening. Staying anterior to it, I can remove all these cells very clearly, very efficiently, and very, very safely. See this. See this? Postoperative cells. See, still my ostium opening is in front of me, and I can remove all these things, all these cells anterior to it. So safe. No fear of damaging anything now. See, my postoperative is being done in a very, very safe manner. Because I have my limit. I'm not going deeper than this anywhere. This is my sphenoid sinus opening. And I will not go in any given situation beyond this. See, finally, my postoperative is over.
Yes, sir. So can you show us posterior ethmoid artery here?
So there are many landmarks for the postoperative artery. I don't intend to see here at this point. I will show you the
Okay.
landmark.
Okay.
See this postoperative, this is postoperative skull base completely. See this is lamina papyracea all the way.
Yes.
That is your anterethmoidal artery,
Yes.
skull base
Yes.
all the way. And this is your sphenoid sinus.
Yes.
Now I will widen the sphenoid. See now I am in the safe region, medial side widening the sphenoid. According to the thickness of the bone, I can use a sphenoid punch. I can use microdebrider, I can use a drill, I can use Clearence punch according to the thickness of the bone and according to the how we are used to. See the Clearence. Very safe tool engaged at the anterior wall. See this? A thick bone I have taken. See this sphenoid sinus
Yes, sir.
being widened?
Yes.
According to the disease, according to the need, you can widen it, but don't try to widen it too imperially. It may damage the nasoseptal branch. Now, if the sphenoid is too big, you can get to see the prominences inside. See this? See the interior of the sphenoid?
Yes.
See the prominences? Not very prominent because it is not so big. See that? But this is the prominence of the cell, I can say. See this?
Yeah.
I can still widen these septations. See this? Until the lateral wall, if I want to. Let me show you how to. I can show you, though in this case it is not needed. See this, what I am trying to say. These. Sharp. Never use any instrument pulling anything. It has to be sharp. See this? Through biting. No pull at all.
It's a true cut.
Yes, through cut. So this is your sphenoid sinus from inside. And it is good, so you don't need to do anything. See this? Never ever curved. Never ever use any curved instrument inside the sphenoid sinus. Dr. Rokade, are you connected?
Yes, Dr. Satish.
See the sphenoid sinus from inside. The tip is not to use any sharp instrument inside the sphenoid. Once you open up the sinus, establish the ventilation and drainage, this inflammatory disease is likely to get back to normal. You don't need to do anything heroic, anything aggressive in the in the depth of the sphenoid sinus to damage anything. See this? This is full house fest. See this?
Perfect, sir.
What we did to the middle turbinate? Simple respect. Nothing. Don't do anything to middle turbinate much. It should be given respect to stay close to the septum, so my ethmoidal axis remains open. What's my point? So once you see, you put your 0-degree telescope in your office and you'll be able to see each and every sinus in front of you. See this? And now what you need to train your patient is reducing in correct position. We have certain position which we train our patient, which allows your topical solution to reach everywhere. This surgical state of the cavity decides whether your solution is going to reach freely to each and every sinus or not, because that is the single most important parameter for the success. The topical reaching effectively, the patient is bound to do well. That's it. See this? This is all about the full house sinus surgery on this side. This is all about. Any questions?
So thank you, Dr. Satish. That was absolute masterclass, especially for our trainee and young surgeons, about how to perform a safe sinus surgery. So all the basic techniques were covered, and giving, I hope those who have watched it will gain more confidence and will feel more empowered about dealing with this very complex area. So I think today we also have Professor Hisham Saleh. He's waiting to join us from Charing Cross Hospital. He's nearly ready. So if that's all right, we will catch up with his case now and then keep coming back to you at the key moments in surgery. So
Okay.
Thank you, Dr. Satish.
Thank you very much for your attention. Thank you so much.
Thank you, Dr.
Thank
Jane.
you.
That was a really lovely example. Really nicely done. Thank you very much.
Thank you, madam. Thank you so much.
Yeah, next side.
Now we move on to the other side.
Yes, sir, we are with you.
Yes, yes. Thank you. So,
So over to London now. So back to the studio. So that was fantastic, Catherine, wasn't it? So
Yeah, really
any
lovely
quick,
example.
any quick reflections on the case?
It was great to see just the stepwise methodical method of going through it, explaining all the anatomy and keeping the key anatomical structures in view all the way through. So it looked like a really straightforward when you kept everything in view, so you didn't get lost, you knew where you were and explained every point as you went through it. So very, very nice example for the trainees.
Absolutely.
see the multiple.
How
polyps on this
respectful he
side.
was to the turbinates and keeping all the landmarks in view. That was brilliant. So, Hisham, are you ready in Charing Cross? So, Professor Hisham Saleh, he's doesn't need any introduction. He's our rhinologist and a skull base surgeon from Charing Cross Hospital, and we'll be soon over to him. He's ready with his case. So, over to you, Hisham.
You're on? Right, good.
Yeah.
Good morning. Can you hear us?
Yeah,
Yes, we
very
can.
clearly.
A big
But
thank you, Hisham, for
very nice
joining
to
us
watch
and
the,
taking all these
surgery from
efforts.
Thank you, Ashok, for the introduction. So we have some 4 cases for you today, but just before I start, I just want to thank everybody who's been working with us hard for the preparations. Kath Rennie, my colleague, and my fellow Priscilla Palmer worked a lot to find the cases, and Kath lent us some cases as well. I want to thank our anesthetist, Mala Siva. I want to thank Matthias, who was our director from Stream Motions, Stores, and Medtronic helped a lot as well for the preparations. And then finally, and last but not least, the whole team here. We have Mina, we have Jenna, we have Rohit, we have Miles, and who else I'm forgetting? I think Mihala as well, yeah. So we have all the team here helping us today. We thank them all. So we're gonna show you the first case. So the first case is the medial maxillectomy. So this patient presented with a diagnosis of inverted papilloma. It's presented, as you can see in my slides, he is 58, with a history of about 12 months of bilateral nasal obstruction. It was more on the right than the left. And also hyposmia, but no nosebleed, no epistaxis, no visual changes. And the past medical history is prostatic cancer. And he had radiotherapy, but then he had prostatectomy. He had no nasal surgeries in the past. He never smoked. He didn't drink that much. He was not exposed to wood. We all asked all these questions because of cancer. An examination, there was some facial tenderness on the right side and the right nasal bridge. There was no numbness, no neurological symptoms. And when you looked in with the endoscopy in his nose, there was a large exophytic mass obstructing, and 70% of the nasal cavity, basically. So it was filling the nasal cavity almost. And that was biopsied in the clinic. And next slide. So there's a scan was done as well. And the scan, interesting, you can see that yellow arrow there, showed an area of exostosis, bone thickening there in the back, which is quite a common sign that you see with inverted papillomas. So that was suggested from the CT scan. We did an MRI as well, which I'll show you in the next slide. So the MRI sort of confirmed this as mostly inverted papilloma, but they have to exclude other pathologies. There's no invasion. There's nothing like to indicate malignancy, but you could have malignancy, and you see the report next one in the next slide. So what they said is a large enhancing right maxillary mass, which extends into the sinus ostium, as you can see from the scans, and middle meatus, with a big intranasal component, heterogeneous signal, internal stretch. You see all these things with inverted papilloma, by the way. Moderately avid enhancement. I don't want to read the whole thing, but the focal hyperestosis is a good thing. And finally, it said poor dentition. So they always comment on the dentition and suggest if there's anything needed to be treated. And they said you have to also consider non-aggressive sinonasal malignancy, but we have a biopsy anyway, and that was inverted papilloma. So we're going to do a medial maxillectomy in this patient. The patient sleep already. So I'm going to go on and scrub, and then I'll describe all what I'm doing during the session. So we'll see you in a couple of minutes. Thank you.
Thank you.
Thanks, Hesham.
The seal minutes.
We didn't see Mark.
Oh, I want to present this case.
So that's an interesting case. So really looking forward to. So yesterday we had some 3 cases of various presentations of inverted papilloma, and what we noticed there's so much variation between their presentations. The one case was a mix of papilloma and inflammatory polyps. So let's see what this case is like. So Prof. Castelnova demonstrated the pre-lacrimal approach very nicely, and papilloma was attached to the anterior wall. So how we approach the anterior wall and meticulously clear out the papilloma. And one of the key things that he said, he tries to, initially when he started, he used to strip off all the mucosa from the maxillary sinus. But now he's conservative and keeping the normal looking mucosa of the maxillary sinus, which in his opinion gave a better healing and outcome. And when he finished the pre-lacrimal approach, the turbinate was replaced, and it almost looked very unoperated nodes. So expect that the healing will be much quicker. So what is your practice, Catherine, about inverted papillomas, especially related to the maxillary sinus mucosa?
Yeah, so I do take the mucosa down. This case that Hesham's got is very nice because there's an area of hyperostosis, so that suggests the focal point that it's coming from. So you're directed into the area, you'll need to drill down afterwards. Unfortunately, not all the cases are like that. And this case is also quite nice. It's on the posterior wall, which is easily accessible. So you can do it through a medial maxillectomy approach without having to do a prelacrimal approach, because it's not coming off the anterior wall by the looks of the imaging. So I agree, for an anterior wall medial, for an anterior wall inverted papilloma, then yes, prelacrimal is quite nice. Even sometimes just doing a canine fossa puncture can be useful for getting something very anteriorly, but the majority of the time you can usually manage through either a medial maxillectomy or going prelacrimally. How about you, Ashok? What do you do for the anterior wall of the maxillary sinus?
Yes, I think trying to see the point of attachment is the key, and see how the rest of the maxillary sinus mucosa is. And depending on the point of attachment, you just plan your approach. So it could be often a large middle metal antrostomy. If you've got a good access and you're confident, you're clear that, so possibly if it is a posterior attachment, smaller papilloma. And then you proceed to megaantrostomy. Then if it is anterior wall, then you have options of performing prelacrimal approach. Then again, if the lacrimal ductile, how closely it is involved, then you might consider converting into a traditional endoscopic medial maxillectomy. And not to forget, you also have an option to approach it, transectomy.
Yeah.
So if the transectal approach is coming for creating access from the other nostril, and that can help with the angle endoscope and with the RAD 60 fibridus, you can reach there and deal with the pathology. So all options are there. So ideally should be ready to exercise any of these, so you get the papilloma safely. I tended to remove all the mucosa in case of papilloma, I must admit, but after watching Dr. Casnovo, probably I would try to be a little more conservative now and keep the normal little mucosa as far as possible. So yeah, so that's the beauty about, that's my learning point from yesterday's event.
It's nice when you get these cases as a primary case rather than as a revision. So if they've had surgery elsewhere and then they come back to you with a recurrent disease, and that's always much more difficult to deal with because you don't know exactly where it was originally coming from, and you're not sure how extensive original surgery would have been at clearing mucosa and things. And I find those much more challenging to deal with and follow them up more closely. How do you follow up your inverted papillomas, Ashok? When would you see them post-operatively, and what repeat imaging, or do you get repeat imaging later to look for recurrence or not?
I think the follow-up, of course, have two purposes. One is a immediate post-op follow-up, so you're monitoring the healing of the cavity. So those follow-ups are closer. So probably after the surgery, I'll see them 2 weeks, then another 4 to 6 weeks, depending on how the healing, then 3 months. But after that point, probably I would till they settle down. Initially, first year, I'll see them every 3 months to 4 months. And then afterwards, I'll see them every 6 months if the cavity is stable. And I tend to follow them up for 5 years. There's nothing hard and fast about it, but people have variable practice. Some of the surgeons talk to from the US, they follow these patients for life because there is an evidence that they cannot recur even after 18, 20 years. But I think within the NHS and as such, we need to take a pragmatic view. So for me, it is 5 years. Of course, if they are in the frontal, then I might take a little different approach. If they're not very accessible areas, I might follow them a little longer. And it's not only the clinic follow-up, the endoscopic follow-up. Sometimes you might have to consider imaging there as well. So the MRI can help for certain follow-ups.
So in your follow-up imaging wise, would it be MRI scans you would use as opposed to CT imaging for them?
Yes, sir, MRI. That's absolutely.
Yeah. No, we do the same. Yeah. And similarly, we follow up for 3 to 5 years if it's a primary we're doing, but if it's a recurrent case that we've inherited from somewhere else, we tend to follow them up a bit longer just because we weren't sure where the original disease was always. So we tend to
And
see
the
those. for a bit
challenges
longer.
come in a gray zones when the patient is asymptomatic, but you see a bit of inflammatory changes around the frontal recess, within the frontal, if you have previously excised papilloma. At that time, you really want to convince yourself that any further extensive surgical procedure like converting to a draft fee or something, is it really necessary? So this is where the MRI helps to sort of differentiate whether you're dealing with inflammatory or possibly recurrence.
Yeah. And when you talk to your patients, oh, sorry, Ashok. I was just going to say, when you talk to your patients with inverted papillomas, what do you say to them about the malignant potential for it? What kind of figures do you quote about malignant transformation, recurrence rates, and follow-up in terms of consenting for an inverted papilloma surgery?
Yeah, I would certainly tell them about the follow-up, and important to reassure them that although it is not a malignancy, it is a benign disease, because it's important for them to know that. And then also the conversion of them to malignancy is very low. That it is reported in the picture, but it's not very high.
It's looking like they're getting ready in London at the moment. I can see the endoscope is set up on Charing Cross. I think Hesham's just doing the white balancing, so I think we'll be going to join them in theatre very shortly.
Sure, and I got one more last question for you, Catherine.
Okay.
That if this patient come primarily to you as a unilateral opacification of the sinus, unilateral nasal mass, you're not sure what it is. So would you just do the biopsy first, ascertain the histological diagnosis? Is it an inflammatory polyp? Is it an intracorneal polyp? Or is it an inverted papilloma? Or will you prepare yourself in the first place to perform medial maxillectomy? How would you approach this?
I would biopsy it first, just because you're not sure exactly what you're dealing with. And it's always good to go in knowing, because it will change your surgical approach. Because sometimes we go, and this mass, as you can see, was very large. So the biopsy of it was actually just done under local anesthetic in clinic. So it didn't need a general anesthetic or anything for it. He had his CT scan and then had the biopsy done under local in clinic. We knew it wasn't a vascular mass at that stage. And then we could make a plan for a definitive procedure for him, rather than having to come back and do any revisions at another stage. And I think just if you know it's an inverted papilloma and what area you're going to have to drill down, it makes a difference. But equally, if it had come back as a sinonasal malignancy, you would want to know that, because you'd be thinking about your surgical margins in perhaps a different way than you would otherwise.
Okay, thank you. So let's check with Hesham how far they are. We're starting the procedure. We can't really wait. So over to Charing Cross. Hello, Hesham.
So if everybody can hear me, I'm in through the right nasal cavity. So if you could see the inferior terminate, the septum is here, and this is typical appearance where you see with inverted papillomas, with this papillomatous multi-prominences coming through the middle meatus. Here's the onset process there. Middle turbinate is thinned, probably with pressure, and this lesion is coming to the floor of the nose here, into the nasal cavity. So that looks like an inverted papilloma. Obviously, it has been biopsied, and that was, we were told, but we obviously send a lot more tissue. And if you look, it's expanding the maxillary sinus ostium here on that right side. So what I'm going to do first, I'm just going to take a couple of biopsies from that part of the nasal cavity. We always do that. Then I'm going to debulk it from the nasal cavity. And usually my step after that is to do a sphenopalatine artery ligation, because I want to decrease the bleeding, because we have to remove that inferior turbinate to gain access into that maxillary sinus completely. And if I don't do a sphenopalatine artery, it will bleed a lot. So I will start by biopsy. So let's have a Blakesley forceps, and then I will debride this. So a couple of biopsies from this. So I'll give you some tissue here. Mass right nasal cavity. So more biopsy. Then I'm going to use the debrider now to debulk this. So basically just for debulking and to improve my access toward the sphenopalatine artery to start with. And if you remember, I showed you on the scan that it seemed to be originating from the posterior part of the maxillary sinus, because that's where the maximum exostosis is. We have obviously a very nice anesthetic. You can see it's not bleeding like crazy at all, which is the control of the blood pressure that is helping that.
Hesham, what do you use to prepare the nose?
Prepare what?
Prepare the nose. What do you put in the nose preparation-wise?
So they have, before we start, they have a spray, which is a mix of lignocaine and adrenaline, ephedrine. That's in an anesthetic room. And then I use topical adrenaline 1 in 1,000 on patties, which I will show you. And I put them just before I start. See that septal spur here was in my way, which I will probably do something about later on. So just continue to debulk. Now, obviously, we can see the bulla here. It was extended into the nasopharynx, as you can see here. So he was completely blocked by the time he presented to us. So now it's been debulked. So I will use the infiltration. We're just going to open the bulla here to create some space and to see if there's anything abnormal in this area. That looks healthy. And as we saw on the scan, but I always tend to do this just to make sure there's nothing else like extension of that tumor there, but there's nothing here. So what we'll do next is we will prepare for the sphenopalatine artery ligation, just to clean this area first. Let's have Patty first for a second. So this is the mirror cell patties, or the dressing that we use with the topical adrenaline, which are very useful between procedure. You can use it every now and then to dry things. And it's got 1 in 1,000 epinephrine adrenaline. So I'm going to inject in this area here to find the sphenopalatine artery. You can see the attachment of the middle turbinate just there. So usually, if we lift the flap in this area here, we should be able to find the artery. So let's have the infiltration. Oh, you don't have a dental syringe? That's probably not going to reach. Yeah. So I have a syringe which is a bit of a short needle. Let's try it. If it doesn't reach, we'll have to use a dental syringe. That may not reach. It's barely reaching, actually. I'm pushing through. Maybe we'll be okay. So I'm injecting. Basically, injection helps obviously decrease the bleeding, but also help you to lift the flap. If I have a FREER, I'm going to show you actually there's so much pressure from that inverted papilloma pushing into that medial sinus wall. I feel it quite soft here. So so the medial meatus is here where the tumor is coming. There. And this is the rest of the sinus wall. See how soft it is and is bulging through with that tumor. Can I have a Blixley? Just removing that piece of bone here. Now let's have the FREOPS. So the standard way of doing the sphenopalatine is to find the hard bone, which is basically the palatine bone, just beyond that fontanelle area of the maxillary sinus here, just below the attachment of the middle turbinate, and lift the flap and find the artery. So let's do this. I'm palpating. Everything is soft until roughly about here. So most of it is quite soft. So let's just lift it quite posterior here, because obviously, probably two factors. Is because the papilloma is probably thin the wall, it's possible, or he just naturally has a thin wall. So we'll try to lift the mucosa off here, like this, to try to see if we can find the artery. And I can see something already tenting here. Let's have a suction. Some people like to use the suction freer in this area. So we'll lift a bit more. Let's have the freeze again. So I'll just extend my flap a little bit more inferiorly here. Suction.
Hello,
So here,
Hisham.
see it, yeah, you can see it there, yeah, coming through that. This is the sphenopalatine artery here. This is the sphenopalatine foramen there. So just coming through here, there's like a couple of branches there. So I'm going to use the diathermy to diathermy this. The bleeding is from the flap. But I think it's really important to do this prior to doing the maxillectomy, because it makes a big difference to the bleeding, intraoperative bleeding. So I'm just using my bipolar diathermy here, just to diathermy this artery. Just go a little bit deeper here, and we'll diathermy it. Then I'll probably cut it as well. So I'm just diatherming into the flap as well here, a little bit, and into the artery now. There. So you can see that the sphenopalatine foramen just behind the blades of this diathermy. I may just simply remove this spur, which often you can just cut straight into it. So if you see there now, into that foramen here, I'll just clean my scope and show you again. Yeah, see the artery there? Probably need a bit more diathermy. Let's do a bit more. I think that'll be okay now. So next, I will do my next part, which is basically removing that turbinate. I tend to remove the whole of the inferior turbinate so I can reach the floor of the sinus. So let's have a FREERS. So I medialize it. Somebody will ask me, what about the nasolacrimal duct? If you look actually internally here, you're probably seeing that right up here, the nasolacrimal duct will be draining. Because it will cut flush into the nasolacrimal ducts, it stays open, and you can check it at the end of the procedure as well. So I prefer to do a complete medial maxillectomy, not the prelacrimal approach, because I want to access the whole floor of the sinus. So I'm going to remove this inferior turbinate now. So I need the Sternberger scissors, please, turning to the left. And somebody can ask me as well, do you get empty nose syndrome? Interestingly, despite your extensive surgery here, I've not seen that happening. So I'm going to cut this flush. So we can basically get access, complete access from the front to the back into the maxillary sinus. And for this, I'm using the curved scissor that curves to the left side. And as soon as we remove this, you'll see how much access we can get into the sinus. If I was doing this without doing the SPA ligation, would have been a lot more bleeding than this. Okay, it's almost off. You have to remember, the inverted papillomas, they are benign, but they can be associated with malignancy. That's why we tend to do this radical surgery. And you don't want them to recur because the recurrence will be high. Let's have a Blakeslee. If you don't remove it completely, if you don't access the whole of the maxillary sinus cavity, you could be in trouble. So here is that inferior turbinate. So that will send away to be checked as well. And the rest of it, I will debride just to make sure there's nothing left in there, just to clear that cavity completely. So just the posterior part is a little bit left here. You can clear that. Yeah, we'll send it to histology as inferior turbinate. So that stump will also remove. Now we started to see more into that cavity. I am now just gently debriding the uncinect here. I'm going to start opening into that sinus completely. So now removing more of that sinus wall. Now let's have a seeker. Let's have a ball seeker. See that? A lot of yellowish color in this tumor here. So I'm just going to point things to you. If you see, this is the wall of the sinus here. It's very soft, pushed by the tumor. Here is the tumor itself. And this is uncinect there, which is also being medialized a little bit by the tumor. And this is all within the cavity of the sinus now. So we'll debride the tumor a bit more, and we will then remove more of that medial sinus wall. Now let's have a 45 Blakeslee. This is more of the inferior sinus wall, as you can see. Let's try to remove some of that tumor a bit more for histology. So that's now tumor from the sinus. Interesting yellow color in it. Yeah. Let's check this. Whole tumor. It almost looks like orbital fat. You make you worry, but it is not. Check the eye, obviously. Nothing happened when you're pulling that, but this is, sometimes you see with these inverted papilloma, that yellow coloration. Blakesley again. See some bone. So here's a big part of the tumor, which tries to excise a lot of it. So we'll just take this out. All the bulk, we're just going to send it away for histology. Just to confirm, because doing this, you should get a lot of biopsies from this tumor, because you look for atypia, you look for any unusual dysplasias and so on, or focal malignancies, because you never know. Sometimes it would be something like this in association with an inverted papilloma. So that's why I'd like to actually send as much of that tumor for histology as we can get. Well, let's have the suction now. Let's actually check it first. Yeah, so we still have some of it here. So let's get some more out. Let's have Blakesley again. Okay. So let's now debride a bit more and get a bit more access here. And then soon I'll be changing to a curved endoscope so we can look inside. So I'm getting into the floor of the sinus a little bit more now. Just removing this rest of the medial wall down here. The bone usually thin until you reach just about a millimeter or two before the floor of the nose itself. I will need 45 soon, not yet, yeah. The specimen is maxillary sinus. So let's, now I'm looking directly into that posterior part where we're thinking that exostosis was on the scan, so which is very likely to be the source of the tumor. So we're looking straight into the posterior wall of the sinus here.
Hisham, it doesn't look like very friable tumor, is it? Is it more of a fibrous component to it?
Fibrous, yeah, it is quite fibrous.
What's your feeling?
Yeah, they are like that often. So, and sometimes because they're so fibrous, the debrider wouldn't actually cut them. But it is working now. So I'm clearing more and more. So I'm gonna change into my angle scope now. If we get the 45-degree scope, but let's put some patties in for a second. Suction. So I like putting the patties on and off between procedures, between changes, scopes, and so on, decrease the blood, but sometimes very useful to also wash with a warm saline. It's okay. So we're gonna change the scope now. Have a 45. So I complete, so what I do is, as you see, I do step by step. I clear the tumor from the maxillary sinus, expose the floor completely. That's why I go down to the floor and expose the anterior wall. So I'm gonna remove the rest of the maxillary medial sinus wall completely. So I can see everywhere, because the bits that you can miss, the part of these tumors that you can miss are the ones on the floor and the anterior wall. These are the most reasons for recurrence, usually these areas. If they're not cleared, you get recurrences. Let's change into curved sucker, the maxillary sinus sucker as well. So we're going to look laterally now into the sinus. So I'm looking inside now. So you can see the rest of that tumor here. Still quite a lot of it inside. Let's have a full visor. So I'm going to pull some more of it to send more for histology with the rest of it. Okay, more tumor. And let's have a Blake's D45. Interesting yellow coloration of all that tumor. Yeah, we'll just put it with the same one. It's all maxillary sinus. It doesn't look malignant to me, to be honest, but you never know, because sometimes you get surprised. But as we remember, the biopsy from the clinic was benign inverted papilloma anyway. But we published a series of 69 patients about 5 years ago, and 6 of them were reported initially inverted papilloma, but they had malignancy. So that's why we are aggressive with these tumors. So I am, again, debulking, removing everything, but this is just the beginning, because after we remove everything, we have to expose, look everywhere, and then drill into the periosteum itself as well. So not just removing the tumor like this. So in a minute, I'm gonna remove more of the anterior wall and more of the floor. We have to be careful this area because intraorbital nerve will be here, so just leave it for now. Okay, so can I have a back biter? So I'm going to remove a bit more of the anterior wall. So basically, I'll use a back biter to remove all this thin bone, really, until I reach the anterior wall. Okay, here you go. Just stick them and I'll use it again. Now, if I'm pressing here on the lacrimal sac, so this is the opening of the lacrimal duct here. Can I have a seeker, bull seeker? I'll just show you something here, because this is what we're going to keep flush. So there is the lacrimal duct opening. And as long as you make sure this is open at the end of the procedure, you'll be okay. Yeah, so here, it's cut flush here. So just make sure it's open, and then you'll be okay with avoiding epiphora. So let's have the back biter again.
So Nishant, can I ask you, how do you decide about whether you want to preserve the mesolacrimal duct or
if the papilloma is if the papilloma is very small, is not extensive, is not filling the sinus, and I can see exactly where it's coming from, I preserve. But so for many years doing this, before the pre-lacrimal approach was described, in many cases, I've had one epiphora actually. And the reason is, I think, because I do check the nasolacrimal duct in the end and make sure it's open. So it's not common to have epiphora despite cutting through the lacrimal duct like this. So that's why I feel more comfortable having an extensive approach to see the floor completely and to see everything and anterior wall. So that's why I do pre-lacrimal approach only if it was a limited papilloma, basically. Okay. So there's a bit of thick mucus we've seen here as well, or probably infective. Let's see this green stuff here. So maybe that will be sent to microbiology. So let's get that for microbiology then. Let's have a Blakesley, 45. So maybe that like Pseudomonas almost looks like that to me, that green pus. And remember the patient complained of green discharge as well. So we'll get some of this out. Yeah, get the green stuff to the micro. It's mixed with the, let's give you that tumor first. It's quite soft now, this bit's here. So just get it out. Let's have a straight Blakesley. That's a nice one. So a big lump.
So this is from micro,
Yeah. So now let's have a suction. So clearly there's infection on top of everything else, which is not unusual. Now I'm gonna check again and look. So if you see, we can see the floor here, but I'm gonna lower it down, further down so I can see further into the floor. Can I have the freers? We'll need a DC arbor. I will drill down here to get to the floor. So I just lift this mucosa off from the floor of the nose itself. Just medialize. Actually, the floor is so thin, I may not need to drill it. Can I have a Blakesley, just a straight? Looks so thin to me. So just remove this bits here. Suction. Yeah, it's very thin. So let's have this. The brother may be able just to get it out with this. Or just to debride some of that mucosa so I can expose a bit more. Yeah, now let's have a drill. Yeah, I do need it. And clearly there's a bit of thick bone. So I can rotate my scope like this. I can look in the floor. And I can rotate and look in the roof. Now it's the infraorbital nerve, just like a 12 o'clock here. It's not very prominent, but we'll have a look at it again. Let's have the longer sucker for the, like the frontal sinus sucker, the curve sucker. You see the bone here? This is what I'm going to drill. This one? No. Speed. So this is a small 2.9 millimeter burr, just to drill a little bit here. Slightly of that, just to have a complete exposure. Actually, the bone is really thin. And I suspect it's because that inverted papilloma was pushing into it. section. Let's connect to the bladder again, actually. This bone is so thin. And we probably, at some stage, we will need the finesse 40 degree.
40 degree finesse.
Hisham,
Yeah,
we are
change.
joined by Dr. Sunil from Ahmedabad. He has a question for you. What is the meaning of medial ligation of sphenopalatine artery in this case? Would you like to take that? Yeah, thank you, Dr. Sunil.
Sorry, I didn't get the question.
What is the meaning of medial ligation of sphenopalatine artery in this case?
What? To decrease the bleeding. Otherwise, it will bleed a lot because there's branches into the turbinates. So basically, when you start and by removing the turbinates, it will bleed very heavily if you haven't done the sphenopalatine artery ligation. So it's decrease the bleeding, interrupt the bleeding. I mean, you can see there's still bleeding here. But if we didn't do the sphenopalatine artery, it would be much more bleeding than this.
Okay. And Dr. Abdul Fatah, he's joined us from Tripoli, Libya. He has a question that, have you noticed any marked hypertrophy of the maxillary mucosa on CT after medial maxillectomy? Is it significant?
Guys, what the question? I didn't hear as well, sorry.
So have you noticed any marked hypertrophy of maxillary mucosa on CT after? Yeah, so they're asking about the postoperative medial maxillectomy cavity.
Yeah, after, you get hypertrophy, you can have the backbite. Hypertrophy of the mucosa initially, but then it settles down, thins down. And often you get some osteitis as well after this surgery. So you get osteitis with basically thickening and narrowing of the cavity. The cavity gets smaller.
Okay. Thank you. Yeah, thank you, Dr. Abdul Fatah. You joined us from Tripoli, Libya.
So I'm removing some of the part of the floor as well. So expose this.
Dr. Sunil also wants to know that.
Now look, this is the anterior wall of the sinus, so you can see it.
Okay.
So I am on the anterior wall of the sinus as well now.
Okay.
So let's have a debrider.
So Dr. Sunil also has the further question. He's logged in from Ahmedabad. He wants to know that why have you not chosen a Denker's approach? So i.e., what is your indication for going for Denker's?
I didn't get this one again, sorry.
Now he wants to know that why did you choose this approach, medial maxillectomy, and not the Denker's?
Sorry, Ashok, I didn't get it. The debrider is very loud.
Okay, sorry. We'll get you at the. We'll let you carry on with the surgery, and we'll take the question later.
Okay. And can you take it out and connect the finesse bar? So I'm showing you here that I have a complete exposure of the cavity. Is on infraorbital nerve. Looks safe. This is where the tumor came from. This is the exostosis that we saw on the scan. Look, this area here. See the prominence here. This is it. So that probably was the source of the tumor. We'll drill it later on. But I want to make sure that my final exposure is clear. It's a bit of pigmentation here. So I can see the floor completely and the anterior wall now. I just want to make sure I drill this a bit down. So I'm on the floor itself. And then I have complete exposure. Then I'll start removing that mucosa. And then I will start drilling onto the bone. So can I have the drill? So now this is the 40-degree drill burr, which is what we call a finesse burr, which is used for the frontal sinus, but I find it very useful to drill into this area. So just to drill here. So just, I want to be on the level of the floor of the sinus, of the nose. make sure the irrigation is working. It seems to be a bit slow. So I'm just getting myself into the level of the floor of the nose. Then I can't drill anymore after that. Just to make sure that I have maximum exposure. So let's have a look now. See, the floor of the nose is here. So on the level of the floor of the nose. And this is inside my cavity. So I can see everything now. If I rotate my scope, so I'm looking directly on the posterior wall here, where the blood is, because obviously the patient is lying on the back, so you can see that. This is the floor of the sinus. If I go like with the scope, I can rotate around. Let me just clean it, and I can show you all the angles. So I have complete exposure, so I can see every little part of that cavity. Like this, I'm looking into the cavity all the way onto the floor anteriorly. You can even look below the medial wall here, and I can look at the anterior wall. All this is anterior wall there. So I'm going to clear the rest of the tumor, and then after that, see the bit of tumor superiorly there, and then I am going to remove the mucosa. So now we need to change to the debrider, the curved 40-degree debrider. And could we have some warm saline? So I'm going to irrigate this, because irrigation, obviously, number one, warm saline will decrease the bleeding. And number two, I'll wash all these thickened mucus and pus and all that, wash it away. We'll clean this part a little bit. I have not opened here because I am right in the frontal wall, in the anterior wall here anyway. So I don't need to cut into the nasal lacrimal duct any more than this. We know that very likely it was coming from here. So that is the area that we have to tackle. So this is now a curved debrider, which I'm going to use. Oh, let's wash first, yeah. So I've got some irrigation. Can I have a suction as well? The irrigation is going to be very useful. So this is warm saline. It's good. And let's have a bit more. See, if you see what happens actually, immediately you see less bleeding. Why does warm saline work? What's the explanation? It's supposed to be a vasodilator. Why would it actually stop the bleeding? Because it stimulates coagulation cascade, basically. This is what happens. So it stimulates the coagulation. Warm temperature does that. But also there's a theory it probably causes a bit of edema in the mucosa and compresses the vessels. So you see what happened here? So it has decreased the bleeding. So now let's have that curved debrider. So we'll clear more of that tissue. So I'm just clearing everything now. I'm removing the mucosa around the cavity of the sinus. You see, all this mucosa comes off. So you have to do this. And that is the area where the tumor was coming from. So we are gently removing the mucosa. And you really have to do this. If you don't do this, it could be microscopic tumor within this mucosa that would just recur. I'm very gentle here. I'm near the infraorbital nerve, so I'm not putting any pressure. I'm just basically taking mucosa off. All these patients have to be warned about the infraorbital nerve numbness. Obviously, you try to avoid it, but in some patients, this tumor will be either involving it or just causing pressure on it. So, but you don't want to damage it by your surgery unless the tumor is in there. So it's just getting the mucosa off everywhere.
Shall we just discuss about how much mucosa do you remove in this situation? I mean, we also had this discussion with Prof. Paulo Castro yesterday. So what is your view on that?
I still didn't get your question. I don't know if the voice is clear. Where is Priscilla? She needs to tell me the question.
You want me to repeat it, or somebody got it in theater?
Sorry, Ashok, we can't hear. Maybe we should change our system a bit.
Okay.
Hesham, are you wearing the headset?
He is. I think the volume's coming from behind him and he can't
Yeah,
hear.
where the hear.
Just repeat it again and I'll listen.
So how much of a sinus mucosa do you remove? We had this discussion with Prof. Castro as well yesterday. So what is your strategy for that?
Can't. I'm really sorry. How?
Okay.
We
We'll
can't.
type the question. We'll type the question in the box.
Perfect. Okay. Sorry, guys. I don't know why I can't hear. Now, let's have a look around. So I'm looking around everywhere. So I still have some on the floor here. And let's look at the roof as well. Yeah, mucosa on the roof here. And the floor. So let's work on the floor a little bit. So we'll also need the 60-degree debrider soon. I remove all the mucosa. Yeah, I don't preserve any mucosa in the sinus, especially where the area I suspect the tumor was coming from. So I remove everything. I'm just here, just removing the rest of the bulla, basically, just to create drainage. So you can see, I mean, this mucosa looks normal. So you don't have to remove all of it. But I tend to remove as much as I can to prevent recurrence, because you never know, it could be multifocal, these tumors sometimes. Although in the great majority, the area they're coming from is the bit that you have to remove. And we could luckily see, because you don't always see that on the scans, the area of exostosis or hyperostosis is where the tumor was coming from. Let's unblock the bridle, or maybe we could be ready for the 60-degree. So you can see now, this is just bare bone, all this in the posterior wall here. And this is got a bit of mucosa on it. I'm going to drill it with a drill soon after I remove the rest of the mucosa. Now I changed my debrider into 60 degrees so I can reach further. Just a little bit on the roof here. Do we have a 70-degree scope as well? Often I use the 70 degree to look more anterior, and to look on the floor sometimes it helps. So I am actually on the anterior wall here. This mucosa here. For the papillomas that are coming in the anterior wall, they're the hardest to remove completely and to see everything. So these are the only ones that there is an indication, very rarely really, is to do a canine approach, like the old-fashioned hardware lock, so you could reach that. But to be honest, I've only had to do that once to reach into the anterior wall. So most of the time you can still reach by your complete dissection like this. I am on the floor now. Sometimes rotating the scope like this, you could see more. So I'm moving the mucosa on the floor. And if you see what I do here, I rotate the scope so you can look directly onto the floor. Looks healthy, but I'm just going to drill a bit here, or debride a bit here. You can also see the medial wall of the sinus and the mucosa there. Now this looks normal. There's no debrider designed to reach this angle, but frontal sinus correct, please. I use the frontal sinus correct in this area here, the one with the most curve, and usually you can reach, you can just basically dissect this mucosa out like this. And when I've done that, I can just remove it. Sever the debrider. Okay, so now I'm going to wash it again. There's a bit of blood. Can I have the hue before wash? Have the hue visor for a second. So just remove that part of mucosa anteriorly here. Then I'm going to wash it. I think I removed the majority of the mucosa I want to remove. And next thing will be for me to drill into the hyperostosis and drill the rest, then done. So we are getting toward the end of the procedure, but the most important thing is not to forget to drill onto the periosteum. Sometimes suction is very useful to dissect as well. It just removes that little bits of mucosa that's a bit stuck. You can do that. Let's have the wash. Just wash it a little bit here. Take this mucosa out first. So let's wash it now. And then we can connect the finesse burr. And I will need the 70-degree scope and also the 70-degree bill. Burr, the one, and the burr.
70 degrees burr.
You can see the cavity now, bare bone everywhere. Bare mucosa here, we can remove. Can I have a look? Just bring them here. Let's have this one. So now I want to drill this hyperostosis area. Yeah, that's it. So that's very likely where the tumor came from. So I want to get it flat. So let's do that. I'm going to see if this is working. I just want to check 1 second. There we go. Suction for a second. So have a close look. This is a thickening, which is unusual, which was shown in the scan. It's a bit vascular as well. And I will drill it down. It's got an artery behind it. We'll diatherm it probably soon, but let's just drill into it gently first. I'm not on full speed because I don't want to go through the posterior wall of the sinus. Have a suction again. Maybe I'll have the diathermy actually. Yeah, let's have the bipolar. You can see why this is a source of a tumor. Yeah, should be about 10 minutes, I think, or 15. So we'll just diathermy this quickly here. Yeah. Postoperative care. A lot of washing, sinus rinse, strong painkillers. This surgery is painful because of the drilling into the bone. So strong analgesia and a lot of sinus rinse. I tend to give them antibiotics as well, just to make sure they don't get infection after all this exposure of bone and so on. And that's it. Everything else like normal sinus surgery. See, I planted it. I'm gonna do a little bit more here. So drill again. Suction. I think this step is essential, this here, because that is likely to be the source of a tumor. And if you leave it, you may have some microscopic recurrences. So I just want to flatten this. Yeah. Yeah.
Do you pack the cavity?
Yeah.
What's the post-op care regime?
Yeah, we pack. I'll show you. I will pack it with nasal pour. The post-operative regime is a lot of nasal, a lot of washing, a lot of irrigation is essential, and the patient may need to irrigate for about 6 months because they get dryness and crusting for a very long time. Strong analgesia because there's a lot of pain in this surgery, and Short course of antibiotics just as a protective measure from infections. That's it. Nothing else special. And these patients still go home same day. That's an arterial bleeding here, which will diaphragm in a minute. Let's have a patty first. So I have drilled that bone now. That's the hyperostosis where the tumor was coming from. And that probably was the arterial supply of the tumor, that bleeding here. So let's press on that, then we'll diaphragm it again. So, yeah, I'll take it in a second. So the final step after this is drilling into the periosteum around the area of the tumor mainly. So just a very gentle thinning of the periosteum to prevent any recurrences. Section. No, in a minute. Yeah, let's just have the. So obviously the bleeding is in the bone, so it will. We can't diaphragm it. We'll stop with the packing anyway. But let's try to diaphragm it again. So this is my third
Thank you, Hisham. That is great. And you see there how we are drilling over the site of attachment and securing the hemostasis. Then we'll be using nasopore to pack the cavity.
Yeah, just for the
and thank you for and also thank you for updating on your postoperative care and surveillance. So probably if that is all right with you, we'll make a visit to Dr. Satish Jain in Jaipur, India, and see how we're progressing with the second case. Thank you. So what is the next case over at Charing Cross?
Our next case is going to be in intracoronal polyp. Can we decrease?
Okay, great. So that will be fantastic.
Decrease the irrigation.
We'll see a different approach to maxillary sinus as the pathology is different. So thank you. So back to the studio and let's check with Dr. Satish Jain for his next case.
So I'll be just 5 minutes basically. So I'm going to pour the.
Hello, welcome back to our GRN studio in Winchester. So those who have joined us a little late, I have with me my colleague Catherine Rennie. So Kath is a consultant rhinology skull base surgeon from Imperial College Healthcare Trust, Charing Cross Hospital. So thank you, Kath, for joining us, and I hope you're enjoying the surgeries. We've had 2 brilliant cases so far, haven't we? You're muted, Kath, probably. Kath, you're muted. Can't hear you.
Sorry, can you hear me now?
Yes, we can hear you.
Sorry. Yeah, no, they've been really nice cases. The chronic rhinal sinusitis with the allergic fungal mucin and the polyps that we saw, and then the inverted papilloma. So really nice to see that as well. So a good example of a medial maxillectomy, and nice to see that area of hypostosis with even the blood supply coming through the bony area to supply that tumor. So really interesting. What have we got next coming up in Jaipur?
I think it is sounds like another case of chronic rhinosinusitis with nasal polyposis with a different type of presentation, probably. So let's check with Nagpur whether they are ready, and then take it from there. So so far we got 4 hours of live surgeries, and many more to come. So I think there are 2 more cases coming from Dr. Satish Jain, and a few more again with Hisham from Charing Cross. So okay, we are with Dr. Satish Jain again. So Dr. Satish, can you hear us?
I think you might be muted at the moment. to
Can
wait
we-
and see if we get in touch.
We'll check with Dr. Jain whether they're ready to join us. So, Kat, talking about Hisham's next case, the antrochoanal polyp. So essentially, again, it's a maxillary sinus pathology. So what do you think his approach is going to be like?
I think for something like an antrochoanal polyp, he'll be less aggressive than he's been for the inverted papilloma, because obviously there's no malignant potential there, although they can recur. And I think he'll hurt more. I would try and get it out through a large maxillary antrostomy if I could. And obviously, even with the antrochoanal polyp, you want to get rid of that point of attachment for them to prevent it recurring again in the future. But I imagine the patient had a similar presentation. So, presenting, seeing a GP a number of times or a family practitioner a lot of times with a blocked nose and trying nasal sprays without anybody having looked in the nose yet. And then obviously, as soon as somebody looks in, we can identify the pathology straight away. So quite a lot of these patients have tried a number of things before they even end up with ENT, unfortunately.
Okay, and how do you try and mitigate any possible recurrence? What's your surgical plan for that? Have you seen many AC polyps recurring?
I've only seen one that's... Oh, I think we're back in. Hello?
Hello?
Hello? We're connecting to Nagpur. Hello, Dr. Satish.
Yes, sir.
Can you hear us?
Can you hear
We're
me,
back
sir?
with you.
We're
Yes.
back with you.
Hello,
we're
yes,
back
yes.
with you. Yeah.
So,
Me and Catherine both are back with you, and we are connected again, and look forward to this. Already looks like a very interesting case on a scan.
sir.
Yes.
So the last case, you had seen only one side. After that, on the other side, we did a limited septoplasty and a full ulcers as well.
Thank you.
This is the new one. Next case, again, as a middle-aged male patient having bilateral massive polyposis, massive inflammatory profile, pure eosinophilic disease, and I'll take you to the positive findings of the scans quickly. We have discussed the scans in detail in the last case.
Yes.
So in this case, if I go from anterior to posterior, see, you can see so anteriorly, the entire nasal cavity is blocked by polyps.
Yes, sir.
See the opacity far anteriorly blocking the entire nasal space, particularly on the left side. And now on the right side, see, the nasal space is completely blocked by the polyposis. You can imagine the inflammatory profile of the patient. Bilateral full frontal sinus opacification, left bigger than the right one. See frontal beak. Now the beak is going. This is the frontal drainage pathway. Not like previous one, not a big supraorbital recess. The right side is very narrow, small supraorbital recess. And then as we go behind the cribriform plate, see this complete whiteout picture. Bilateral pen opacification. See the septum, if you see, septum looks in the midline because of the polyps on either side. The turbinates are all compressed, looks compressed. See this turbinate looks compressed. This happens mostly in massive polyposis because of the compression. The normal structures get compressed, turbinate, bulla, all these things get compressed. This is your cribriform plate. As you go behind, now is the beaking of the orbit. See this beaking? This is anterethmoidal artery leaving. This is superior oblique, this is medial rectus. And the artery leaving the space towards the cribriform. And immediately after that is the postethmoid starts. Pen opacification. You cannot discriminate even the bony structures, even in this bone window, because it's so completely compressed with the polyposis. Post-ethmoidal cells, little bigger cells. You can see these bigger cells going behind. See, this is the level of the sphenopalatine foramen. This is infraorbital fissure, inferiorbital fissure, the orbital apex, opacification of bilateral sphenoid sinuses. So this is basically, you can say, pansinusitis. Massive disease, and once again will be requiring a full house FAS only. This is soft tissue window I was talking about in the last case. See now the difference between that and see the bone window and soft tissue is. The soft tissues, look at the brain, look at the orbit, intraorbital structures. The soft tissues are prominent everywhere. See, even the outside muscles, pterygoid muscle. Let me keep both the windows together. See this. See, in this bone window setting, only the bones are prominent, and the rest of the soft tissues are not very, I would say, in terms of discrimination, not very useful. Here, the bones are not defined, but the soft tissues are very, very, defined. You can discriminate. See, even in the brain, the discrimination in soft tissue as compared to the opposite side. Intraorbital structures. See the muscles, orbit, muscles of the mastication, structures surrounding the paranasal sinuses. The soft tissues are more prominent, and ideally we should have both in bone and soft tissue window settings once we order a CT scan. So this case is straightforward, bilateral massive polyposis requiring a full house FAS. Anything you want to discuss before we start? In a couple of minutes we are going to start with the endoscopic picture. Anybody? Dr. Rokade?
Hello.
Yes.
Good afternoon, sir. This is Dr. Ram Heda.
Yes, sir. How are you?
Yes, sir. Fine. Just wanted to ask one thing. When do you advise CT? After giving a course of steroid or directly?
Yes. So that's an important question. Whether you advise upfront CT scan or after the course of medication. See, this should be very clear to everyone. In CRS, or basically CRS is diagnosed basically on the clinical ground. And the diagnosis is, further, confirmed on the basis of endoscopy and then CT scan. So CT scan is not a primary thing to diagnose, CRS. CRS, when diagnosed on clinical grounds, should be offered medical treatment. If you have slightest doubt on the diagnosis, or if there are unusual symptoms, or if patient is not responding to the adequate medical management, or turning to complications, those are the times. And most importantly, when all medical treatment fails and surgery comes to the question, or surgery is the answer, then we should get a CT scan done. Now, the proponents of upfront CT scans are there and they have their logic. If you have a doubt of a fungal disease, there is no point in giving unnecessary medical management. The cost of medical management and the time and money ruined is not justified. So in those situations, upfront CT scan is useful. So it all depends upon the patient's profile, diagnosis. Even if we get upfront CT scan and it responds to medical management, there is no harm in it. But if it doesn't respond to and need a surgery, you don't need to repeat CT scan because the anatomy is never going to change. So if you have done an upfront CT scan and later on after a long time, if you want the patient wants a surgery or need to be operated, you don't need to repeat a CT scan because CT's role is mainly to give you anatomical details.
Yes, sir.
Anything else?
It's probably
No,
provided to know what was your preoperative medical preparation for this patient. Was it any different than your previous patient, or was it the same?
See, this patient requires a course of oral steroid, saline wash, steroids, and of course the immune assessment. We always follow all these CRS patients for immune assessment. Up to 10% of such patients have some or other deficiency in the immune system, which is responsible for the virulent course of the disease. Such polyposis patients should be thoroughly asked for the aspirin sensitivity as well. If they are sensitive to aspirin, however number of times you operate is not going to cure the patient, because the fault is lying in the arachnoid acid metabolism pathway, where the patient is hypersensitive to COX-1 inhibitors, leading to more and more leukotrienes secreted, which are driving the inflammation. So in that situation, even if you operate, okay, the surgery is required, you can give access to the topical, but still the inflammatory load is so much in those patients. Unless you don't desensitize with the aspirin, the surgery is rarely going to work alone. And those patients will require repeated surgeries, biologics, and more extensive treatment. So assessment of the patient should be, on a close watch, to keep an eye on the immune system, to keep an eye on aspirin sensitivity. See, CRS polyposis looks one disease, but it's not one disease. There are a number of endotypes defined now. Endotype means number of variety of CRS having different underlying pathophysiological process going on, which ultimately require a different treatment lineup, different post-operative course, different prognosis, and everything different altogether. Like for example, AERD is a different endotype. AFRS, I mentioned about it in the last case, allergic fungal rhinosinusitis is a different endotype. It requires steroid as a mainstay of treatment, and this is one of the endotype which requires even long-term oral steroid post-surgery. So this is a pure type 1 hypersensitivity reaction. CCAD, central compartment atopic, is a different endotype, which is basically a complication of untreated allergic rhinitis. That requires a sinus surgery followed by allergic testing immunotherapy. Cystic fibrosis is a different endotype, which is prevalent in children. And for me, any child, young child with bilateral nasal polyposis should be considered cystic fibrosis until proved otherwise, and must get a sweat chloride test to confirm it. So you have to be suspicious about it. So there are variety of endotypes of CRS, and every endotype has a different underlying pathophysiological process which need to be corrected, need to be addressed accordingly to get optimized outcome. All patients cannot be treated on the same line. So as you asked, assessment is the most important part of the overall management, and patient profile, immune profile, everything, allergy profile must be thoroughly assessed.
Thank you. So what is your surgical plan for this case? Is it any different than the last?
Bilateral full house mess.
Yes.
Massive, I would say, mega enterostomies in this case to deliver more steroid inside, as a more profile, more inflammatory, severe inflammatory profile of this patient demands more, vigorous topical steroid using in the post-op. So
thank you. And this might be a good time to ask you about the frontal sinus. Given the extensive involvement of the frontal sinus, do you consider primary Lothrop at any stage? Or what is your sort of place of Lothrop in the management of such cases?
Very important question. I tell you, primary Lothrops means patient who is unoperated and having CRS, not operated earlier. I would still do a Lothrops in primary setting. In the first surgery, if the patient has a AERD. AERD patients in first setting head on, we do Lothrops to give maximum opening for the highest topical douching, highest topical steroid douching. Out of all these endotypes I mentioned, AERD is one which is at the extreme of the spectrum, having highest inflammatory profile. So these are the patients, if diagnosed on the primary setting, I would go ahead with a Lothrop in the first go to prevent the need of, going for it again. And post surgery, after a couple of weeks, we'll schedule decent.
Thank you.
So we go ahead with the surgical course, we can continue discussion. Any questions from the audience or anything, please share with us.
No, so you can start with the case.
Okay.
That's going to be an interesting case, looking at the extent of the disease.
Yeah, completely blocked. Polyps throughout both nasal cavities with no nasal airway at all there. So the patient should have a huge relief after this surgery, finally able to breathe again through their nose. Do you use any aspirin desensitization in your AERD patients, Ashok, or?
Yeah, I do some difficult patients. You end up having quite a few of them. I do refer for aspirin desensitization. But the challenge is with the waiting lists and other thing key is what Dr. Sati said about timing. So the timing should be perfectly matched with the surgery. So it requires a good coordination between your respiratory medicine, allergy colleagues who offer the desensitization service.
And do you have good compliance of your patients with it and good results with aspirin desensitization, or?
That's the challenge with it. So you really rely on patient compliance, and they really need to persist even after desensitization, because if they miss the dose even for say 72 hours or so, you have to start the whole process all over again. So it is a challenge.
Yeah, no, it takes a great commitment from the patients to be involved and on board with doing it.
Absolutely, yeah.
And I think
Charing Cross.
Yeah, similar to you. And I think we get patients complain of gastrointestinal side effects or worried about GI bleeds and things like that. So there's quite a lot of patients reluctant to take a high dose of aspirin every day. I know Professor London Glennis-Scadding used to use the nasal lysine aspirin challenge and use it topically, and they used to get fantastic results of that. But at Charing Cross, we only have the oral aspirin desensitization available to us. So, and it's our immunology team that run that for us.
Okay.
All right, looks like we're beginning to get an endoscopic view. So there's a nice big polyp. So we'll go over to Nagpur.
I think while they're setting up, maybe it's a good time to catch up with our supporters. It's a very brief informational video, and by the time they prepare and get started. So,
Okay.
So we do that with some videos. The minute they're not ready, we'll go back to them. Can I ask studio to play some videos? I think they're busy trying to establish a connection with Nagpur. So while they're setting up the videos.
So I was going to ask, so is your pre-op regime for CRS with polyps similar to Dr. Jane, Ashok? Do you use preoperative oral steroids or topical steroids? And do you give antibiotics preoperatively? Because that was something that I don't generally do unless there's an obvious infection. So I'd be interested what your approach is as well.
I mean, like a case like this, for example, I would certainly give a week of steroid. This patient would have previously treated with regular saline nasal pushes, then wetness on nasal drops, along with the course of oral prednisolone. And then I would give them 2 weeks of preoperative course of the doxycycline or clarithromycin, depending on the medical condition. I prefer the doxycycline.
Hello.
Yes, sir.
We're connected
Hello.
again.
Hello.
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 Hi there.
Hello.
Can you hear us? Yeah.
Yes. So are you getting endoscopic picture?
Yes, sir.
Yes.
And you can imagine the disease.
Yeah. Huge polyps.
Yeah, we can imagine the suffering patient that we have. The suffering of the patient we can understand.
Yes. So full nasal blockage, eosinophilia, massive polyposis. Just typical, like last case, the topical preparation, no infiltration. Apply gently adrenaline on the surface. And see the beauty of marrow cell, absolutely adramatic.
Is it 1 in 1,000, sir?
Pardon?
1 in 1,000 adrenaline?
Huh?
Adrenaline concentration that has been used.
1:2, 1:2.
1:2.
See now, after the first application, decongestion. See, I can see the axilla now.
Yes.
See, the nose has opened up. See the polyp. See the axilla.
Yes, sir. Yes, sir.
And polyp medial to the middle turbinate as well. This is a very important findings to notice because polyp medial to the middle turbinate are responsible for olfactory loss as well. they destabilize the turbinate, middle turbinate very often when having disease on either side. And most of the time, such patient requires a sort of partial turbinectomy to handle the destabilized turbinate so that the irrigation can be thoroughly given a way to olfactory recess. See the opposite side as well. Massive polyposis. So interesting case.
Hello.
Yes, sir.
Sir, you commented about cystic fibrosis.
Yes.
So can you put more light on that? And because in Indian scenario, we
It's
not that common.
Yeah.
But any pediatric patient coming with bilateral full house disease.
Like the youngest child I have operated is 2-year-old.
Okay.
2-year-old child with bilateral polyposis. And you know that disease, this is basically because of the failure in mucociliary clearance, because of the viscid secretions. The issue is those polyps are not eosinophilic. In cystic fibrosis, those are purely neutrophilic polyps.
Okay.
Steroids have no role. What all required is a topical antibiotics to control the infection, to prevent lung failure and lung transplantation, need of lung transplantation. Because that contributes to the lower airway infection, lung infection. So those patients require a wide openings, bilateral medial maxillectomies, bilateral turbinectomies, a sort of gravitational drainage into the nasal cavity, and then topical antibiotics to control the infection. You can introduce high dose topical antibiotics without any side effects. And in cystic fibrosis, typically the infection is Pseudomonas. Pseudomonas infection is predominant in cystic fibrosis. So that's a different endotype altogether. Neutrophilic, Pseudomonas, gravitational drainage, medial maxillectomies, turbinectomies. Cystic fibrosis patients have a lifespan, definite lifespan. That is a definite mortality ultimately with the, lung failure.
What investigation you run, sir, for diagnosis?
Sweat chloride, and then genetic testing.
Genetic testing.
Nowadays, a lot of genetic, CFTR gene modifiers are in market. Cost is a limiting factor, but they work and improve the, mucociliary clearance. Mucolites have a big role.
Special mention of these 6 figures.
See this topical
Yes,
decongestion.
5351 6998.
Now see the picture after decongestion. You saw the initial picture.
7838 P04 P064.
See the turbinate coming in picture. Middle turbinate. Oh,
Yes, we can see that. Thank you.
Oh, compress.
We haven't talked about this. So that is idea about this.
See the amount of polyps medial to the middle turbinate. I told you, and that destabilizes the middle turbinate. See this?
Yes.
These are the candidates to me which are cases or ideal candidates for partial turbinectomy. These patients often present with olfactory loss. See this everted uncinate process. This is everted uncinate. Completely distorted middle meatus. Can you see?
Yes, sir.
This is bulla ethmoidalis. See this? How distorted it is. Massive polyposis. See the amount of polyposis medial to the middle turbinate. Ultimate condition of the middle turbinate is, see how floppy it is. So this is after luminal clearance. Bulla, uncinate, middle turbinate, everything deformed. Everything deformed because of the polyp. So in massive polyp, you must be prepared to deal with, anticipate such issues. They are not uncommon.
Sir, can you tell us what precautions should be taken while using debrider in such distorted anatomy?
While using,
Debrider?
keep the cutting edges under view and keep the surrounding landmarks under view. Not blindly.
Right.
See, the picture is good. See the axilla, all polyps removed from everywhere. Same thing is to be done on the opposite side. Such patients, somebody asked me about upfront CT scan.
Yes, sir.
Such patient with massive polyposis coming to me, I would never wait for the medical treatment to be effective. Such are the cases which require direct CT scan. Such are direct surgical candidates. This massive polyposis is never going to subside with any medical treatment.
Right, sir.
So we need to know this practical fact, in spite of being a medical disease, now the inflammatory profile is so big that removal of the inflammatory load is necessary for that medical treatment, that is topical medication, to be effective. See the turbinate? Piece of floppy turbinate. This is distorted uncinate. Turbinate is here. So I told you even before starting, these are the cases for partial turbinate resection. See the polyp medial to the middle turbinate?
Yes, sir.
Once you see polyp medial to the middle turbinate, you are going to destabilize the turbinate definitely. Massive disease. See, turbinate is very small, compressed medially, and this is all distorted uncinate. Distorted uncinate, distorted bulla. See the interior of the bulla. So you have to be careful not to get disoriented. This is what I have done so far. It's just luminal clearance. Pure luminal clearance.
Dr. Satish, there are some questions from the audience, if it is okay to ask at this stage.
Hello?
Hello. There are some questions from our delegates, if it is
Yeah.
okay to ask you at this stage.
Yeah, please.
Yeah, Dr. Hetham from CEL, he wants to ask which tests you ask for invasive fungal sinusitis. Which tests do you ask for invasive fungal sinusitis?
The invasive fungal sinusitis are of two types. The chronic invasive, that is mostly aspergillosis, and acute fulminant, we all know that is mucormycosis. Both are different disease. Obviously, invasive fungus is a pure medical disease, but they have certain role of surgery as well. Invasive fungus means antifungal. Chronic invasive is aspergillosis, and that is mostly diagnosed on the radiological grounds. Almost always can be diagnosed on the radiological basis, which requires histopathological confirmation of fungal invasion of mucosa. So, like for example, if you ask about the non-invasive fungus AFRS, for example, this is because of the antigen antibody reaction, and you will find a lot of fungus with antigenic material and eosinophilic material around it, blocking the sinuses, expanding the sinuses, expansile bony erosions. That's it. In invasive fungus, chronic invasive, you will find involvement of the sinus with minimal intrasinus disease, with bone erosion at one place and maximal extrasinus disease. Bone erosion at one place and in continuity extrasinus disease with no expansile erosion of the sinus. It is truly invasion of the fungus leading to bone erosion. And in those cases, obviously, like for aspergillosis chronic invasive, voriconazole is the drug of choice and treatment is medical only. But what all role of the surgery is to establish a histopathological diagnosis of confirmation of the fungal invasion of the mucosa. So you need surgery for the biopsy. You need surgery for if the sinus is in any situation blocked for its ventilation and drainage, you can open up. There is no need of removing the fungal mass as such. Once you establish a chronic invasive fungal sinusitis diagnosis, voriconazole will take care of entire mass. In acute fulminant, the role of MRI is amazing, game changing. Treatment of choice, like I said, for invasive fungus is antifungal, and for acute fulminant, it is liposomal amphotericin B. But acute fulminant has a predilection of involvement of vessels and block them and give vascular necrosis. So, if the antifungal is not reaching there to the necrotic area, there is no fun in giving antifungal. So what we do? Advise MRI, see the enhancing area after gadolinium contrast. Wherever the gadolinium is reaching, no need to remove that. Your antifungal will reach. Wherever there is lack of enhancement, gadolinium is not reaching, immediately debride that for the antifungal to be effective to the enhancing areas. So MRI guides you for the surgical as well as medical treatment. MRI diagnosis by means of non-enhancing lesions. MRI will guide the extent of surgery also. It's not that all enhancing area need to be removed and unnecessarily giving morbidity. Only non-enhancing need to be removed. Enhancing will be taken care of by
Sir, we have lost the endoscopic picture.
You have lost?
Yeah, now we are on.
Yeah. I just back. See now the picture after luminal clearance?
Yes, sir.
Yes.
On the right side?
Yes, sir.
I hope Dr. Rokade, that answers your question.
Yes, thank you. There was a question for Dr. Hetham from CEL, but I hope you got his answer. Thank you. So we're
Hello, one
very briefly.
four-wheeler MH6998318 to be removed from the parking area.
See,
FA.
this is the distorted uncinate process, what I told you. Can you see?
Yes, sir.
This is pure distorted uncinate process. And you should be able to pick it. Otherwise, one may get confused with a middle turbinate or anything. This is pure distorted uncinate process.
Dr. Satish, we're going to take a very brief break to the other center to know about the case, and we'll come back straight away to you again.
Okay.
Thank you. Sorry. So, could we join London very briefly?
Now, see this. After the uncinate plate partially excised, this is uncinate, this is hiatus seminaris. Can you see?
Yes, sir.
And this is your bulla ethmoidalis. This
Yes,
is
sir.
hiatus. This is infundibulum. And now our anatomy is becoming clearer. See this? This is your maxillary sinus. The chronically inflamed mucosa. Here I am biased to give a little bigger opening, looking at the need of the topical steroids in the post-op, looking at the disease profile, what patient requires more vigorous.
Can you hear us now?
Yes, Isham, we can hear you. Okay, so can you go over to London, please, for okay, thank you.
Thanks, Ashok. So this is our second case. It says case 4, but this is the second case. I just want to thank Mark Ferguson, that's his patient. This patient, I'll show you the slide now, presented, he's 45 or 46 years old, presented with left side nasal obstruction more than the right side, and rhinorrhea, sometimes green, sometimes infected, no epistaxis, no pain, no change of the sense of smell. On examination, there was very clear appearance of a large polyp which is extended into the nasopharynx, and most probably that would be an antiquinal. And when we did the CT scan, that really almost confirms this. I'll show you in a minute. Low density lobulated polyp measuring at least 5 by 2 centimeters. It's arising from the left maxillary sinus and protruding into through the large accessory ostium, which is always the case in these polyps. They always come through an accessory ostium and they extend it into the nasopharynx, and you will see it in the scan in a minute. And some mucosal thickening into the sinus itself, you always see with this. So if I show you the next slide, which will show the scan, you could see the coronal section on the left and the axial on the right. The axial is the best one to show this. In the coronal, you see this thickening in the bottom of the sinus with some opening, and you can't see the rest of the polyp. But it's really nice to look at the axial scan because it shows that nasopharyngeal extension of the antroquinal polyp coming through the accessory ostium into the nasopharynx. And this is really almost diagnostic. Obviously, you always have to exclude other things. In the majority of cases, it is correct diagnosis just from that CT scan. So what I'll do is we're going to do the surgery in a minute. We'll excise that polyp completely, and I'll explain what I'm doing it. So I'll go and scrub, and I will leave you with the other operation for now. Thank you very much.
Thank you. Thank you.
Great, thank you.
Okay, cool.
Sorry.
Over to Nagpur, please. Dr. Satish, we joined you back.
I think they're muted at the moment. We might need to turn the sound back on the feed.
I'm sure you are oriented.
Yes, sir.
See this? I'm taking red putty, the bulla is there down. And I'm reaching. First of all, defining the level of lamina. See, this is lamina.
Yes, sir.
Can you see the level of lamina?
Yes, sir.
This is axilla, which I am opening more and more. This is all axilla and the frontal sinus above. Now I'll change to 70 degree. So we'll finish in the next 10 minutes quickly. See now the middle meatal enterostomy?
Yes, sir.
Clear?
Clear.
This is, we opened up the axilla above. Now I'm changing to 70 degree. See this now. See now the same landmark. Can you see the beak? Hello?
Yes,
Yes,
sir.
sir. Yes, sir.
The key is define the axilla. This is axilla. This is axilla here. This is your beak. This is your medial limit. This is the lateral limit. This is lamina. And if I follow the beak,
Are you still with RAD 40, sir?
pardon?
Are you still with RAD 40 blade?
No, this is not red 40. This is red 120 now. See, I am putting underneath the beak to show you the frontal. This side we all know the frontal sinus is not big. We have seen on CT scan.
Yes, sir.
Remember?
Yes, sir.
6998 गाड़ी किसकी है? 6998.
That is my frontal sinus on this side. See that?
Yes, sir.
The small frontal sinus, we all know the opposite side is relatively bigger. See, under the beak. See, that is the frontal sinus. So this was a small frontal sinus. And the beak is so prominent. See, the beak is so prominent. This is your frontal sinus. That is your frontal sinus. See that?
Yes, sir.
This is beak. I'll clean off this and show you. See, this is beak. And just behind the beak, between my medial and lateral limit. That is my frontal. That there. Data. See what we have done. Just for the beak. See this prominent beak and the frontal up there. See?
Yes, sir.
Frontal recess. And something. Reverse. This reverse. Complete.
Can I have the forceps, the
The skull base being flush.
okay.
Flush.
Yes. Are we on?
Hello.
Yes.
Hear them. Can we hear them?
Yes, I can.
Can I show you is it the polyp now? So let's look at the left side. Remember he complains of bilateral obstruction. So going here is a middle turbinate. When I lift, you see this polyp coming through that is very large ostium. That's not the natural ostium because the natural ostium is more anterior. Here's the uncinate. The natural ostium should be a bit here. So it's coming just from there and going backwards toward the nasopharynx here, filling it. If you come out and you go to the right side, you will see it filling the nasopharynx here as well. So that's why it's blocked bilaterally. So that extension of the polyp is very large, going all filling that nasopharynx. That's why the patient presented with bilateral obstruction. So what we'll do is you have to remove the polyp and the mucosa that caused it. If you just remove that polyp and that's it, it will recur immediately. It will recur very quickly. So that's a narrow stalk that comes through the accessory ostium here. So I'll start by removing that part, and then we're going to enlarge this accessory ostium connected to the natural ostium, and then we'll remove that mucosa. The great majority of these polyps come from the posterior wall of the sinus. And you will see that there's a minority that comes from the floor and really rarely come anteriorly. So we'll try to grab this narrow part of the polyp and take it out. So let's see if we can do that. You can get this part here and just gently tear it off. See if we can bring it out. Part of it. Sometimes they're so big, like they're so stuck in the back, and we have to debride them. But I'm going to have a go with this again to see if we can get out. I think it's possibly too big to actually take out completely in one piece. So let's have a look again. Okay, well, it's coming. Here's a nice piece. Now let's look at the rest of it. Now, the interesting thing about the antrochoanal polyps, they're most commonly affecting males. The histology is different from the standard polyp. They're more fibrous. So they're not that natural inflammatory like the polyps that you see in patients with RG inflammatory conditions and so on. So they are different pathology. They're more a form of like a fibrous cyst that comes from the maxillary sinus mucosa. They're very rarely something called the sphenocoenal polyps, which originate in the sphenoid. They are extremely rare, but they have the same histology. I'm going to use a debrider. This is quite thick to remove from the nasopharynx. So I'm going to debride that part first. Yeah, nasal polyp. So I'll give you more. I will debride that part. So see how big it is in that nasopharynx. You can see why the patient is completely blocked. And I'm almost like creating a cavity inside that lump, really. So we publish a series of antrochoanal polyps in adults. So a lot of the time they'll present in children or adolescents. And so actually for them to present in adults, it's a bit rarer because the symptoms will start earlier because they would have been there for years. If they left them for a long time, they present in adult age. That's why you don't find a lot of published series in antrochoanal polyps in adults. So we published a series maybe about 7 to 8 years ago, and at the time it was the largest in the world. Interestingly, I was a bit surprised with it. And we showed that they always, or great majority, will appear from the mucosa in the posterior sinus wall. And all of them came through an accessory ostium. Now, interestingly, I'm going to look at it on the other side and also debride it. And you see with the debrider, because it's quite fibrous, it doesn't easily just debride it completely. They are very different histology from the standard polyp as just mentioned. So creating a smaller piece of tissue that we'll be able to remove. I remember on one occasion, one of these polyps was so large, we had to remove it through the mouth, actually. So this is coming out. Let's have a Blakesley. And we send all this as well. Looking again onto the left side suction. That seems a bit more loose. Let's have a Blakeslee. So here is that big part of the polyp. So now we concentrate on the maxillary sinus. Let's have a let's have the Freer first. I'm probably going to change into 30 or 45 degrees so I can show you inside. Yeah, well, let's change our scope. So if you see there, here is the rest of the polyp coming through. So what I'm going to do now, I'm going to do uncinectomy, and I am going to enlarge the natural ostium, and then I'll remove the root of the polyp. So can I have the seeker first, and then we'll change the scope. It's always better to look, yeah. That's perfect. Yeah, I'll need a let's have a 45 actually. So I'll medialize. I like to medialize the uncinates like this. It's safer when you remove them. And I tend to use a debrider to remove the uncinate process. When you medialize them, it's safe. You know you're not on the lateral wall. You're not affecting the orbit. So you can remove them like this with the debrider. So I'll do that now. So that is the uncinectomy. We'll start seeing into the cavity of the maxillary sinus. Okay, can I have the backbiter? No, free as first, sorry. Yeah, backbiter. Face is a little tight, but we're here. We'll try from severely. Okay, let's do it again. Let's just have the free again. Yeah, backbiter again. So we just remove that rest of the uncinate. And then anteriorly. And the debrider. Now you can see accessory, natural. I'm going to connect them. Maybe so I can show you better. I'm going to now change my scope into the 45 degrees. So let's change the scope. And can we have also the curved sucker? Yeah, change the scope first, and then you can have that. Thank you very much. So this is a 45 scope. We'll just adjust it. Let's have a curved sucker as well. Yeah, this one, perfect. See the natural ostium here and the accessory ostium here. And this is the bridge between them. So we enlarge this, we're going to enlarge a bit more. See where the polyp is coming from? You can see it inside the sinus. So I need to enlarge a little bit more anterior and superiorly here. So I can see the whole of the mucosa. I just have the debrider, and then I'll remove it. It's really essential to do this, otherwise it will just recur. So now let's try to connect this. I will soon need a curved debrider. Actually, yeah, let's have a curved debrider. Before that, I'll have a straight Blakeslee or a chomper if you have one. So I'm connecting the two ostia. So now you can see that I have a larger opening. This is blocked a little bit. Yeah, let's have the curved one. Great. So now I change to a curved debrider. Just enlarging that antrostomy to the maximum size so you can see. This is still in the nose. This is the part that's still in the nose, so we can take it out. There. And I'll take part of that mucosa with it from the posterior part of the maxillary sinus ostium. Now we can see it's all three here. So we just take this part off as well, because this is part of the disease mucosa and it's attached here. So let's see where it's attached now. Let's have a seeker. Adjust the image first. We'll have a look at it and see. We can actually see where it's coming from. Let's have a frontal sinus seeker. It's a bit longer. It seemed to me that coming from that posterior wall here, posterior inferior maybe. Let's have a palpation. So basically, it's coming more lateral. Look, so that's where it's coming from. Just there. It's slightly more lateral of the posterior wall. So we can debride that and follow it. So before that, let's take a small biopsy from it. So let's have a Blakeslee 45. No, maybe a U-visor forceps. So I use an angle forceps so you can reach this area. Just take a biopsy basically. So small biopsy, just take it there. I'm going to debride it more and then indicate you a little bit. And then let's have a debrider. So we'll debride this part now. And I will also need a 60-degree debrider. Let's have the view visor again. Uh, 60-degree debrider, yeah. Yeah. So this forceps is very useful. You can take more of it, like so. Yes. there's anything. Right. So we're changing the debrider to one with more angle. You can have a backbiter as well.
So Hisham, what's the plan now? You continue to debride that root of the polyp and then
remove
that is it?
the mucosa where it came from.
Yeah.
Backbiter.
Yeah, but you're happy with the size of your antrostomy, correct?
And then that's it. Then it's done basically. So it's main thing about this surgery is to remove that root basically, because if you don't do that, it will come back. Yeah. I'm just enlarging my antrostomy slightly anteriorly, so I can reach it a bit better.
Well, that's an excellent demonstration for that particular clinical situation. So I think if that's all right, Dr. Satish is just finishing his one side, so just visit him and then get back at right time. Okay, so shall we go over to London? Sorry, to Nagpur, please.
Okay, let's now have the new visor.
Hello, Dr. Satish. Can you hear us, Dr. Satish? Hello, Nagpur, can you hear us? Have Dr. Satish Jain again on screen. Just finished the right side, now dealing with the left nasal polyps. We're trying to connect the audio, but developing his antrostomy. Looks like they're debrided some polyps, done uncinectomy, and making wide middle metal antrostomy. Can you hear us, Dr. Satish? We're back with you.
Yes, sir. Yes, sir. So we have finished on the other side.
Okay. I would like to see the menu in the right hand.
You can see the picture. The final picture after the long stress. See the frontal above, model artery, skull base, got the onodi with optic nerve in it. That is sphenoid sinus.
Wow.
And see, this is after the partial turbinate, not chopping. Yes. Got it? That's the final picture.
I note that in this case, you have amputated the middle turbinate partially. So, what was your factor that decided?
See My deciding factor to resect it was the polyp medial to the middle turbinate, either side of the middle turbinate, and the biggest region. And this always do. The moment we see polyp from both sides, is our planned approach. Because it makes the turbinate floppy and it prevents the solution if you keep it reaching the minuses. This is the planned strategy in those situations.
Thank you.
Now see this side. Okay. For the frontal sign, I'm still with a 0 degree. Just to define lamina papyracea for you. This is lamina. See the lamina papyracea.
Yes.
All the way. This is all lamina. That is lamina. This is your turbinate. See this? See the turbinate?
Yes, very nicely.
Yeah.
This is middle turbinate. This is lamina. The same story. I will take 70 and will enter in frontal in no time. The frontal is in front of us only. I will show you. Give me 70. See, right up is the frontal sinus. You just have to define your medial and lateral limit. See your medial limit, lateral limit. Can you see both?
Yes.
Yes.
Simple. Everybody watching can do this. Frontal sinus this way. Believe me, it's the simplest way of addressing the frontal sinus. First, as well as surface. See, this is lamina papyracea. This is your beak. Now see where. This is your beak. This was axilla. This is your beak. This is your turbinate. And now this is your. And see above is the frontal. Can you see? Here from it. This is frontal. This turbinate. Immediately behind the turbinate has to be. Oh, sorry. Beak. Where the beak ends. What I showed you on CT scan. See this frontal sinus? I haven't done anything great. Follow the beak. See this beak? This is axilla. Behind the axilla is the beak. Once you come to the beak, follow your, define your medial and lateral limit, stay in between and go there. It has to be fun. Great.
Very nice. Nicely open.
Like the way? That's the frontal sinus. Always, the 4 sinuses I have shown you, 2000, this anatomy will never change. See the frontal. You can open the frontal in the beginning without doing ethmoidectomy. That's the beauty of this technique. Now see to the reverse. My same steps again and again. Reverse. This is supraorbital recess. This and just above the supraorbital recess, just behind the supraorbital recess is what? Entered model artery. Can you see?
Yep, that's a nice view.
Whenever you see the supraorbital recess, the caudal limit is anterior model artery. Behind. This is supraorbital reset, that is frontal sinus, behind that is supraorbital, and behind the supraorbital is anterior. See that?
Yep, very nice view.
It is always the same. Now, once you see the anterior artery, the anterior cavity ends. Now, once this ends, we can switch to 0 degree after this. See this. Let's see the maxillary sinus. Let's see the frontal sinus, anterior artery, anterior root, orbit, turbinate, and now I'm switching to 0 degree. The rest of the lower work, the clear work, and then now to the 0 degree. Once again, you can see the model artery, skull base.
Yeah.
This is your for the maxilla here.
Yes.
Now I am entering into the ground level. At this level, at the level of roof of maxilla. Take a medial turn. Medial turn and find out the superior turbinate. This is superior turbinate. This is septum. Going between the superior turbinate and septum. This is my sphenoid sinus. See my level of the maxillary line. Just below the maxillary line is the sphenoid ostium. Can you see?
Yes, sir.
See this. And now remove everything. Staying anterior to the sphenoid sinus, you can remove everything. All these separations must go. Just stay anterior to the sphenoid sinus ostium. Remove all these separations. That's it. If this is sphenoid sinus, staying anterior to it, flushing the skull base. To the anterior model artery, the model skull base here, following in the sphenoid sinus. All these separations flush the lamina papyracea.
This is part of the turbinate which I told you. And resection. Complete Ethmoidectomy. Now this is the sphenoid sinus which we have to widen. Widen superiorly, laterally, medially. Give them the sphenoid. Little bit more widening. Nice sphenoid sinus. Adequate. That's the first turbinate. The axilla is left behind. I quickly finished off one by one the frontal sinus above, frontal sinus above, this is ethmoidal artery, this is remnant of the turbinate, this is remnant which we cut.
It's a really nice big open cavity now. The medication should reach in. What do you put? Do you pack the nose at all at the end of the procedure, or what post-operative debridements or instructions do you give?
Hello?
Hello, can you hear me?
Yes, yes, please.
So do you use any packing at the end of the surgery?
Yeah. We use the same marrow cell, soak them in the steroid solution and pack in the ethmoidal cavity.
And how long do you leave those packs in for?
For 48 hours maximum.
Okay.
See now what we have achieved. Since the turbinates were floppy, massive disease on either side, we have achieved a wide mega middle meatal enterostomy, mega sinus enterostomies, including frontal sinus, skull base completely flushed, turbinate partially resected. You can do surveillance in your outpatient department. You can thoroughly irrigate with a steroid after turbinate removal, ensuring that it reaches everywhere. This was the goal of sinus surgery in this case.
A very excellent demonstration of clearing all the sinuses in a difficult polyps case with lots and lots of polyps. A really nice demonstration of the anatomy. Thank you.
Thank you very much for your attention, for your inputs.
So what is the follow-up protocol of these patients with CRS
We
in your
remove the
setup?
pack after 48 hours.
Okay.
And then start steroid irrigation. Thoroughly teaching the patient particular position, line and back, the most prominent, otherwise the prayer position. And then obviously for some broad spectrum antibiotic or something initially. And then irrigation. You can call patient after 10-15 days for debridement of any crusting, secretions, any bone piece, soft tissue which is left in the cavity or whatever to promote healing, basically.
So what is the rate of recurrence in your setup with this, even
With
after
such
doing a
cases,
good, yeah.
After this kind of case done, with complete immune profiling, need of aspirin desensitization, immunological treatment, never. Only thing with counsel or patient, never counsel that you will be operated and you will be all right. This is the biggest joke. Surgery starts or enables the medical treatment to be effective. You have to counsel them. If you don't operate, you have to be on steroids, nothing else, and that even may not be effective. Once you operate, you make the topical treatment effective so that the systemic side effects can be avoided. Since your disease is medical, allergy, immunity, whatever disorder, you will require most likely long-term irrigation according to the profile. That you have to see what the profile is. But one thing should be very clear, the treatment begins with the surgery, so that from systemic to topical treatment can be switched over. That's the goal. Like cardiologists explain that you need a stent, but after that you need a regular lifetime antiplatelet to keep it patent. But to keep it good, whatever work you do, prevent recurrence, to prevent relapses, prevent disease progression, you need a regular medical treatment. With the surgery, the advantage is the medical treatment will be switched from systemic to topical. That's how you have to counsel. And all patients should be assessed with such polyposis for complete immune profiling, allergy profiling, and all the issues which can affect the sinonasal immunity.
Okay, sir. Thank you. It was a wonderful demonstration.
Thank you for your attention once again. I think the thyroid case has already started. So we are switching over to the thyroid.
Thank you,
Thank
Dr.
you very much.
Okay, so we are
Now
back
will
in the
we,
studio again.
after a nice, excellent demonstration by Jain sir.
That was a very nice demonstration of the sinus surgery, Ashok, for a tricky case with lots of polyps. Really nice clearance of the whole of the skull base from front to back. Good demonstration of the anatomy throughout, and just shows how useful using the debrider so much is as well in surgery. We'd be lost without debriders now.
Yeah, absolutely. I mean, just look at the starting point and look at the finish point. There's massive difference. And the good is our debrider, demonstrating safe technique, so various angles, even that adenoid debrider. So
yeah, that was a new one to me. I haven't
Yeah.
used that one. I think I'm going to be asking for it next.
Yeah, absolutely. But for our trainees, and well, so you need to know that there is a supraorbital cell there before you perforate with that debrider. So reading your scan and knowing your anatomy is the key. It works in his hand. So I would exercise a bit of caution, good practice, supervised training, and then advance to that stage when you do that type of surgery. But yeah, excellent. This was quite new to me as well. Fantastic. and very minimal use of cold steel. And it's a very specific stages of surgery, like when he's widening the sphenoid a bit and taking a little bar of bone. So very minimal cold steel, and the rest of it is all very nicely managed with various debriders.
Yeah, good to see all the different angles and to use them as well. So yeah, I'm certainly, it's good to see all the different angles of the debriders in use and where they're useful and how to use them effectively in progressing your surgery. So it was really nice to demonstrate that.
Yeah, absolutely. Not sure whether my manager is going to be happy having those many debriders used in the surgery. Yeah. So
I think Medtronic will be very happy.
Absolutely. And cold steel. How much cold steel do you use in your sinus surgery?
I use more than Dr. Jane. I open my sphenoid ostium with a sphenoid mushroom punch and widen it with that still. But certainly removing polyps, and I will use my backbiter to do my uncinectomy, but then take the remnant off with a micro debrider. And enlarging the ostium, I might use the backbiter to bring it anteriorly, but clear the edges with the micro debrider. I'm happy doing anterior posterior ethmoids with the micro debrider as well. But when I'm taking the septations down in the frontal sinus, I probably use a little bit more cold steel there. But I do like the 40-degree debrider and the 60 if there are polyps in the frontal sinus or even polyps out laterally in the maxillary sinus, because it can be quite difficult to reach those areas. And even with the cold steel instruments, I find the debriders on the polyps are excellent because it kind of suctions the tissue in and moves it out of your way. Obviously, you want to see the mouth of the debrider at all times and make sure you know where you are anatomically and you're avoiding the lamina all the way through.
Very true. And again, emphasizing the point that this is for a very high volume, very experienced surgeon. So we always have a trainees with us, and often it's also important to have these safer techniques adopted first, and then move over. Once you get those skills, be more confident using debriders more and more. So I tend to use my cold steel, mix it with the debrider. So the GR ESS, then 2 millimeter furrow biting Clearence punch is my go-to. So I like to feel the cell partitions, break them gently, feel the skull base, feel the lamina with my GR and get the feel of things. And when the all these partitions and the soft tissue is loosened, pick it up with the debrider or your 2 millimeter forward biting Clearence. So these are variation of techniques. I think what works for you. But certainly, after watching him, micro debrider is a great thing to clear the polyps.
Yeah.
So I think with that, it's probably a good idea to take a break. I think he's on a non-rhinology case at the moment, Dr. Jain. And Hisham is preparing for his next case. I believe it is going to be Lothrop. Correct, Kathy?
Yeah, they're planning to do the Lothrop yet, and they've sent their patients, so hopefully it shouldn't be too long. So we'll take a short break and we should be ready.
Yeah, good. So can we play some videos from Medtronic and Karl Storz? They are supporters of this program, and they heavily invest into education, supporting the platform like this. Without their support, it's not possible. So we'll just watch some informational videos from them in the break and be back in 10 minutes.
Yeah.
Yeah. Thank you. Thank you.
Great. Thank you very much. Thank you.
We know the world we live in changes drastically, faster than ever before. We are aware of the threat of the environmental crisis as well as the social inflection. Priorities and consumer values change radically. We have reacted. We have initiated major changes already, with many more ahead. Not to survive, but to keep our business ahead in this disruptive world. We have pulled the switch to green power. We have already significantly reduced our global carbon footprint, and we will continue to do so. With energy targets clearly defined, our monitoring systems perfectly control and enhance our energy targets. The integrated water cycle concept of our new production and logistics site in Neuhausen will save about 10 million liters of water every year. Enough to cover the consumption of a city with a population of 78,000 for one whole year. We are planning well ahead for a sustainable future. Our new site in Neuhausen will be as close to carbon neutral as can be. Reusing excess production process heat, modern waste disposal management, PV systems for generating renewable electricity, recirculated wastewater, and an optimized transport system add up to the best resource management possible. Let's shape a sustainable future together.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
We know the world we live in changes drastically, faster than ever before. We are aware of the threat of the environmental crisis as well as the social inflection. Priorities and consumer values change radically. We have reacted. We have initiated major changes already, with many more ahead. Not to survive, but to keep our business ahead in this disruptive world. We have pulled the switch to green power. We have already significantly reduced our global carbon footprint. And we will continue to do so. With energy targets clearly defined, our monitoring systems perfectly control and enhance our energy targets. The integrated water cycle concept of our new production and logistics site in Neuhausen will save about 10 million liters of water every year. Enough to cover the consumption of a city with a population of 78,000 for one whole year. We are planning well ahead for a sustainable future. Our new site in Neuhausen will be as close to carbon neutral as can be. Reusing excess production process heat, modern waste disposal management, PV systems for generating renewable electricity, recirculated wastewater, and an optimized transport system add up to the best resource management possible. Let's shape a sustainable future together.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise. We're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
You're on mute. Hi, and welcome back to everybody. Good to see everybody again. I hope you had a good break, and I think we're looking forward to Professor Sala's next case, where he's planning a modified Lothrop procedure. And I don't know if he's ready yet in theatre, and hopefully you'll be able to tell us a bit about the case.
Yes, really, what a fascinating day we had so far. Fantastic surgeries. So we're entering into the second half of the second day of GRACE Live 2023. And this is the one surgery, modified endoscopic allograft, that we missed on it so far. We nearly got to it. Professor Janki Ram yesterday was about to perform the prop, but then the pathology was found to be limited and was not required. So really looking forward to this case. So I think this event and GRN as such is an initiative of like-minded rhinologists who have developed this platform with the mission to foster online professional development in rhinology and also in skull-based surgery. So it's a non-profit organization, and I'm proud to say that so far all of its initiatives together, more than 50,000 surgeons from 130 countries have benefited from it. So, which is good that so many of our colleagues find this platform useful for their own education, and in turn, it brings benefits to their patients and their outcomes. So that's the whole idea of GRN.
It really is a fantastic resource, and all credit to you, Ashok, for putting it together, and the amount of organization that it takes behind the scenes as well, getting everything up and running. So I'm really impressed at how well it all comes off on the day, because with different connections in different countries and so many potential errors that could happen, and yet we seem to me be able to produce great quality content for everybody to watch around the world. It's really amazing that we get to do this every year, and there's some great content from previous years we can go back and look at that's still saved. So that's fantastic.
Yeah, thank you, Kathy, for all the kind words, but it is not just me. It's the whole huge team behind it, people who work behind the scenes and make this possible. This is not one-man job, absolutely not. And our scientific committee members, they are absolutely supportive right from day one. They want to expand this platform and add some more and more useful events to it. So, for example, recently we had our research event where they committed fully to the chronological research in December. That was very well received, and all the leading research clinicians and the scientists contributed to it. That was quite fascinating. So that event was well received. Then also we had further initiatives about book review in rhinology. So our first book review session, we reviewed 3 books, one on the frontal sinus surgery, the other was a skull-based surgery, and another book was about endoscopic repair of septal perforations. So all that was received very well. Following that, we did an event on excellence, Center of Excellence around the world. So that is another initiative that GRN has undertaken, that taking our delegates to visit these centers of excellence. So that's quite a happening time, and more such ideas and more events will be coming in. And of course, this is our signature event, the live surgery. It started with the collaboration with the Lion Foundation, which did similar events in otology. And then we developed from their experience, and they were quite supportive as well. So this is the 6th live surgical event, and always been very well received. So yeah, it's good. And all the team, other fellows, the trainees, then all the hosts who contribute to it, like yourself, Louise, you, Zara, Claire, you have been always been a very much part of this, and more people coming and joining hands to support this platform further.
I really love watching the live surgery, because on YouTube you get plenty of opportunity to see well-edited videos, but it doesn't really give you an indication of exactly what's happening. So seeing something live gives you that extra insight into, you know, how somebody moves from step to step, rather than just seeing the highlights of the case that have been edited very neatly for you to watch, and you actually see everything everybody does right from beginning to end. And I think that's hugely useful, particularly as a trainee, just seeing, you know, how people's economy of movement, what they're doing throughout the procedure, and how they work with the team around them is something that you don't necessarily pick up straight away. So that's really good to see here, and it doesn't come across on an edited video in the same way. So I think that's really great about watching today.
Yeah, absolutely. And you get the perspective from different regions, from different surgeons. They are all stalwarts, very experienced, high volume surgeons. I mean, you can see how we get benefits from that.
Absolutely. And you pick up different techniques from different people and get different ideas about how to tackle problems. So it's really interesting to see different approaches from around the world at different problems. And, you know, where people use image guidance, where they wouldn't use image guidance, and the case mix people are doing and the different approaches to them is really interesting. So I think it's a great learning platform for everybody.
Yes, and some of the colleagues, because of the time zone constraints, because of the work commitments, other social commitments, are not able to join on live on these occasions. But we have made it, we will be making this available online on our globalrhinology.org website. So if you become a member of GRN Academy, it is a free membership, but that gives you an access of all our past events, and we have edited into user-friendly formats with the different topics set up as a courses. There will be some assessments going on further with CPD, CME credit points. So you can get all those benefits by becoming free members, and you'll also get updates. Also subscribe to our YouTube channel where all these videos will be available.
Yeah, as I said, it's an amazing resource, Ashok, and I think it will only go from strength to strength as more content gets added to the site. I know that I was in double clinic yesterday, so I missed out on some of the cases. So I certainly will be tuning back in to have a look, because I missed out on Castelnuovo and Zara Patel, and I'd quite like to have a look and see what they've been up to. Having visited them both in their hospitals, it's great to see them presenting on the site as well. So that's brilliant.
Thank you. And I think let's see what's happening in London, and if they're ready for us to join. Hisham?
I think they've just got an issue switching back on. So there'll be 2 minutes is what he said to me. So hopefully we'll get to hear more about that Lothrop patient. I understand it's a patient who's had multiple previous surgeries. So be interesting to see the approach.
Yeah.
And interesting when people choose to do a Lothrop. Do you do it at a primary case, or is it on a revision, or how many revisions do you do? Or is it just based on sinus anatomy that you choose your modified Lothrop approach? I know that in some countries there's more and more people doing, particularly for the AERD patients, Lothrop at the primary surgery, but not everywhere. And there's huge variations in the rates of modified Lothrop surgery around the world. So it'd be interesting to get different people's takes on when they would do it and what their indications for a modified Lothrop are. I know certainly over time, and even from the beginning of my training to now, the number of cases we're doing has vastly increased, but then the surgical instruments have got better for the frontal sinus. We've got better angled drills. We've got better debriders now. It's much more accessible than it used to be. So the procedure has become much safer over time. So Ashok, how about you? When do you consider a modified Lothrop in CRS?
Yes, I mean, other indications is quite clear cut. If they need it, they need it. But I think CRS is the gray zone in certain cases, and that's difficult often with the decision making. It's not only the clinical aspect of it, but it's the logistics of it. The whole, especially to NHS and our situations, the waiting list, then the amount of time, theater availability, everything plays a role. And of course, the patient wishes that when we explain the details of the surgery, what is involved, not many are really keen for it unless it is absolutely necessary. So I think if primarily ARD, yes, definitely will consider primary low crop for them. But from the practice is as a first surgery, offer a good standard clearance with full house space with frontal mini prefines. So just the washing the frontals out plus the planters out and see how they progress. And then as a revision surgery, we tend to offer them the low crop.
Excellent. No, that's a similar approach I think we would use as well. But I know that certainly worldwide figures do vary very differently on the percentage of cases that end up going for frontal sinus drill outs. So it'd be interesting to hear different people's approaches to it.
Yeah, absolutely. So why not we get that slide on the screen, and Catherine, you can talk about the case if you know about it.
Sure, I'm happy to introduce the patient. So it is somebody with SAMPTAs, so AERD patient, so a patient who has got CRS with polyposis. She's a 39-year-old lady, and at 39, she's already had 5 different endoscopic sinus surgeries, not all done here. The most recent and the last one was done in 2018. At that time, she had a septal perforation, so she actually had to have a rotation flap on that septum to close the perforation, which I believe is closed now, but we'll see. But interestingly for her, she is one of the patients who's now on biologic treatment. So she is on dupilumab, and in spite of dupilumab, which we keep hearing is this cure-all and may have us out of a job as sinus surgeons, her polyps have actually recurred and she is needing further surgery in spite of using dupilumab. She suffers from congestion, facial pressure, nasal discharge, and anosmia. She's using betnazole drops, so those are probably the strongest drops we have available in the UK to use. Oh, can you hear me?
No, we're just testing. It's not...
Hesham, I'm just introducing the case. Can you hear me? I think they're doing their timeout in theatre at the moment. Sorry, they're talking over me slightly. I hope you can still hear me. But on examination, this patient has significant polyposis and obviously the ongoing clinical findings. And having had 5 surgeries already, the area that's been recurring is her frontal sinus.
19th September 1983.
I'll just mute the operating theatre so that they can do their timeout in peace and quiet without my voice over them. Okay. So it should be an interesting case to see, and I think it's interesting from the point of view of biologic treatments. Hopefully they won't be putting us all out of a job yet. In the UK, we're still limited, and our only patients that do get the biologic treatments are those with concurrent asthma. And usually the dupilumab is 2nd or 3rd line in the UK, where they tend to use MIPO or omalizumab 1st line, and then move on to dupi later down the line. I know we often talk to we have a biologic MDT that we do jointly with the Royal Brompton Hospital for the severe asthmatics, and particularly for the patients with really bad nasal polyps. We try and push our colleagues in the asthma services to prescribe MIPO or dupi rather than the benralizumab, because the data so far is suggestive that they are a better impact on polyp load than maybe benralizumab does. But it's great to see a case where biologic has failed, but she's obviously had some relief from it because the previous operation was 2018. So that's quite a big gap compared to her previous surgeries where she's reoccurred very quickly from one to the other. And also it prevents the problems of patients being on long-term oral steroids, where we know we don't want to give more than 3 courses a year at the moment because patients are getting are at risk of corticosteroid side effects as a result of having more than 3 courses of oral steroids. And that data comes from the asthma literature. Have you got any experience with biologics, Ashok, and polyps recurring after the use of biologics?
Well, we don't have, as you know, we don't have any approval for the biologics for the polyps. So the patients with asthma, we refer them to the respiratory units, and then according to their criteria, they choose the patient. But I can't say that we have many patients on the biologics as it.
Yeah,
It is
I think we're
very new thing
yeah.
that started. Yeah, they're constrained.
I think we've been lucky with having the connection with the Royal Brompton, where we've been able to get some patients through their MDT, and they've been involved in some of the trials. But certainly within the NHS, the government healthcare system, they're still cost prohibitive and they are hugely expensive. And our sinus surgery is too cheap in comparison. So we either need to make our surgery more expensive or the drug much cheaper for it to be possible on the NHS for patients to have access to biologics.
Yes, that's right. It'll be interesting to see how things unfold over coming times.
Okay, I'm getting a message saying I think they're about ready to go in the operating theatre. So I'll see if we can switch over to them.
Case, the third case. Start again. Can you hear me?
Yes, we can hear you.
Yes,
I've
we
given a
can.
little bit of an introduction, Hesham, so I might have already said some of what you're going through. Apologies.
No, I was just saying hello. So we have the third case now. I'll show you the slide. Let's put the slide to show you the history of this patient. So this patient has Samples triad, chronic sinusitis, nasal polyps, and asthma. 39-year-old. She already had 5 previous operations. Last one is the 2018. I heard you talking about the biologics. She's been on biologics, but the biologics help her asthma, but not the polyps. And this is a specific one for polyps, the Papilloma, which is again is IL-14, and it is supposed to be helping with the polyps. Just to show them an example that biologics are not the magic for every case still. So she has not responded to various biologics, and currently she's Papilloma. The polyps are large. She's got facial pressure. She's got frontal headache, and she's got obstruction in the frontal ethmoidal recess with polyps also in the ethmoids. And she's also on betnazole drops because that's the only thing that was effective for her. So when we examined her, she had grade 2 polyps in both sides, and she has some septal deviation. But interestingly, she had septal perforation before that we repaired. So I don't want to do too much to that septum. Let's show you the scan now with the next slide. So you can see the scans, the axial, the coronal, and the sagittal here. We don't show the axial. We show the parasagittal here to show the space, anteroposterior space in the frontal sinus, which is nicely wide. So we should be able to get a nice open Lothrop here. We'll do Lothrop because we want to open these sinuses and we want to improve the drainage and we allow the medical treatment to reach into the frontal sinus, which causes her a lot of problems. So we're going to improve, we can remove all these polyps and then do a Lothrop. And I will, in the end, put a Propel stent, which will secrete steroids for about a month, which is very useful in a patient like this who had multiple surgeries to try to actually improve the drainage in the Lothrop and prevent any inflammatory changes during the first healing period, in the first 4 weeks or so. So we'll go ahead with the case. I'll go on scrub, and then we'll see you during the case. Thank you very much.
Great. Thank you very much, Hesham.
Thank you.
So interesting to use the Propel stent in the frontal sinus there to give you a long-term steroid slow release to hopefully keep that Lothrop cavity open for longer. I've tried them in a few of the frontal sinuses and I found them quite useful, but again, they're expensive stents, and people as alternatives in the past have used fashion silastic stents in order to keep that frontal drainage pathway open, and using mucosal flaps locally can be quite helpful at trying to keep that frontal from closing down once you've drilled it out completely. Ashok, what techniques do you do to try and keep that big frontal recess wide open?
I think I try to develop the local flaps. I think very important if you have vascularized flaps. They tend to reduce the narrowing of the frontal ostium. Then also, in addition, you can also, in certain areas, use a pre-mucosal grafts, making sure that the mucosal site is laid in correctly. So the combination of flaps and the grafts. So that's my technique. I don't necessarily pack it with anything. Certainly, I don't have any experience with focal stent, which I have heard about it, I've seen it, but due to its cost and relatively they are new, so I haven't really tried anything. No experience of that. So have you tried them?
Yeah, so I've used a couple of Propel stents now for frontal sinus. I tend to use them in revision cases rather than primary, just because of the cost issues within the NHS. So first time round, I don't get access to it. Whereas if they're having revision surgery, we want to do everything we can to try and keep that frontal sinus as open as possible, especially where there's been new osteoneogenesis and things like that happening, and maybe lots of the mucosa is involved in disease, so the mucosal flaps aren't as good as you perhaps want them to be. I know that Shaz Ahmed uses sometimes nasopores soaked in betanazole to put in the cavity after surgery. I haven't tried that, but he finds that quite useful for slow release of betanazole after surgery. And as we were hearing from Dr. Jane earlier, he uses Maricel patties soaked in steroid for 4 days in the nose after all of his sinus surgery. So that's an interesting, similar thing. Rather than using a Propel stent, something like that could also give you that local steroid immediately after the surgery. The Propel is quite nice because it can hold your mucosal flaps in place and it sits in the frontal sinus opening really nicely. We've looked at a few cases we've done at Imperial, and I think we're about to start a trial with them shortly. So it'll be interesting to see what the outcome is from the trial for it. But certainly the revision cases we've done with it, they have had some really nice results.
Good. And how long do you tend to leave in it?
Oh, sorry, Ashok, I didn't quite catch that then.
How long do you tend to leave the Propel stents?
The Propel stent reabsorbs. So when we see them back for debridements in clinic, you can still see them at their 2 weeks. At the 4 weeks, you're beginning to see that it's broken down, but there's still bits of it left. And then at the 3 months, the stent is reabsorbed. So you definitely see them there in the beginning. You can often see some mucus on the stent, but they sit quite nicely in position. And the shape of them, particularly the contour, is almost funnel shape, which kind of holds a graft in place quite nicely. And if you've got a very big frontal sinus opening, the Propel works quite nicely. There's also a mini one if you're just doing a unilateral frontal sinus. So there are a few different options with them. I think they have 3 different types: the contour, the mini, and the standard. So and as I say, you don't have to take them out, which is quite nice about them. They dissolve over time, and they slowly release mometazone, which is obviously what we use in our Nasonex spray, and really nice to help the mucosa heal and prevent that edema that you can get there.
Yeah, so I think we try and all these measures to try and keep the neofrontal ostium patent and as widely patent as it can be.
Yeah.
However,
and I don't want to,
it does have a, sorry.
I don't want to sound
Yeah,
like a salesperson for Medtronic. I want to let everybody know I'm not paid by them, and I have no investment in the company at all.
Absolutely, same disclaimer from me. So,
yeah.
But the point I was making that whatever we do, all these measures are supportive measures. But there is still a tendency for the neofrontal ostium to narrow down. So naturally, it narrows down by a third in a year's time. So it is absolutely vital to make your first low-throat cavity with the ideal shape, with going from skin to skin laterally. Then anterior posterior diameter opening is important, drilling all that frontal plate, making it really thin so you see it flat. So there should not be any ridges along that side. Then drilling it down further to your skull base, right up to the skull base, right up to the first olfactory neuron, making sure you have dealt with the interfrontal cell correctly, then reducing the interfrontal septum right to its very end as much as possible. The shape of the cavity, and also not to forget the T, when the posterior septal window that you create, the shape of that septal window. So all these things matter.
Absolutely, Ashok. These measures, then the propels and things, they won't make up for poor surgery, and it's really important that you get the as good a diameter to that lothrop cavity as you can at the first surgery and when you first open it up, because no amount of local steroid is going to keep it open on its own. It has to have been a good surgical procedure at first. But I think they're back on in London, so I will hand over to Professor Sala. He looks like he's just decongesting the nose with those Maricel patties.
So I'm just prepping the nose. It looks horrible here, very inflamed. So I'm putting the topical adrenaline. It's very congested and it's very tight. So I'll just put it here and wait for a few minutes.
As you all can notice, all these patties have a string attached to it, and we would not be allowed to use free patties in the nose from a safety point of view in our departments. All have to have that radio tracer and also the strings attached. So I'll count it before and after. This is just a safe surgical practice.
So Hesham, can I ask, has this patient just prior to surgery had any oral steroids as a preoperative prior to surgery? And do you tend to use that? Or do you give any antibiotics preoperatively? Or do you just give them postoperatively?
Yeah, we didn't get any preoperatively, but intraoperatively, yes. Antibiotics. But no steroids, given steroids. Just dexamethasone intraoperatively, yeah, not preoperatively.
Right.
This looks very inflamed, you can see, and it's very tight as well. So we're just gonna have a look around. Have the suction. So you can see the polyps here. So you see how the whole mucosa of the nasal cavity is inflamed, not just the sinuses, even the septal mucosa there. This is antrostomy, the middle meatus antrostomy here. This is within the ethmoid cavity, which is already open. There's polyps here. And the septal perforation that was repaired looks intact here, but it's quite tight anteriorly on this side, also on the other side. I didn't want to try to do septoplasty because of the history of the perforation. We'll try to bypass this if we can. Let's have a Freya to have a look at this side. This bulge here, we'll probably have to do something about. So we'll just try to see beyond it first. So again, here you can see the roof of the ethmoids and the polyps there. So we may be able to just bypass this because we're going to create the window here anyway. So I'm going to have a look with the navigation because we're using navigation here. I don't know if this is showing in your screen or not. So I can't even see if there's a middle turbinate here. So it doesn't seem that she has a middle turbinate, but I am putting my navigation into the frontal smaller recess here. If you could see just there, next to the septum, there's no landmark at all. There's nothing here. There's no turbinate. So the frontal smaller recess seems to be here. And this is the right side, the left side, sorry. And I'll go on the right side.
Yeah, we're seeing it on the navigation screen now, Hesham. So we're just getting a view of that.
I am in the other side here. So we can just see we're just in the ethmoids here. If I go, because of the tight septum, it's a bit difficult to show you, but here, again, I'm on these polyps here, but there's no middle turbinate. So that is like toward the frontal ethmoidal recess there. There's no middle turbinate. So I'm gonna have to start by removing all these polyps first. Then I plan a lolophrum after that. So let's have a straight debrider. What's the speed on? Oh. No, we need to be on. We need to change that. Can somebody put it in a straight shot? Should be on a straight M5. We're just adjusting our debrider. No, not stylus. That's it. Let's put it a bit slower, 3000. That's it. Right, so now we're gonna clean these polyps to start. So I can see what seemed to be a remnant of the superior turbinate here, maybe, but the anatomy is completely gone, basically. So we'll just try to gently remove these polyps here. And luckily we have a navigation here. It will be very useful in a case like this because you can see there, so sphenoid is here. These are like some of the posterior ethmoid cells in the back, just below the skull base, which is just there. It's just here. So we just gently clean this. Nina, can we connect the frontal sinus sucker? Here is the skull base. You can see it up here. So you can see that the dissection is not reached the skull base previously, so we'll remove these a little bit more. Okay, let's now have a navigation. I'm going to show you. So posteriorly here, I could see the skull base. Yeah, so I've reached this. So I'm coming forward now. That's the safest way to do this. She also has some osteitis, so the bone will be a bit thick when you try to remove him. Let's have a navigation again. So we'll just find out where we are. I can see something that looks like an agar, nasy, or into the frontal sinus here. So we have to link all this. So that seems to be the remnant of the middle turbinate. It's just there now. We can see it now. Okay, so that's here. We check that with the navigation probe. Seems to be about right. So frontal sinus coming that way in this area. Suction. So here it is. So we found the frontal sinus just there by following the landmarks, which what we have left, which is this tiny bit of turbinate here. And this here, as I said, it's an agonese that is half open there. I mean, I appreciate that anatomy is completely destroyed, but you could see the shape of here. So lateral nasal wall, turbinate, what's left of it. So I'm just going to drill a bit or debride a little bit of this mucosa to create a bit more exposure.
So Hesham, do you use navigation on all your revision cases? Do you use it on any primary or Lothrop? When would you get the navigation out?
All the Lothrop, I always use navigation. And in fact, when I started doing Lothrops many years ago, I wouldn't have been able to do it if I didn't have a navigation. And at the time, nobody in the UK was doing Lothrop endoscopically. So with the help of navigation, I was able to do them. And especially with cases like this, with revisions, obviously, but even, I mean, obviously, most Lothrops will have some surgery before anyway. But any case of revision, I'd like to use navigations as well. I mean, you see this like here, because of the destroyed anatomy, you are very near the orbit and very near everything else. If you don't have a navigation, it's a bit more risky. So we're checking all the time with the orbit and everything. So I'm going to debride a bit more of this. This is just, again, on the lateral nasal wall, but it seems to be a remnant of the uncinate here, there. This is a remnant of the uncinate here. Let's have a 45-degree Blixley.
You mentioned about your Lothrops, you're doing it for many years now, and for one of the first surgeons to do it in the UK. So reflecting on your journey, what things have changed since you started?
Okay, the brother.
Hesham?
Yeah?
Sorry, I'm not sure you heard the question.
No, I haven't.
Sorry. So since you started doing Lothrops many years ago, as one of the first surgeons in the UK, what things have changed?
Well, not a lot, to be honest. Just availability of more of the curved instruments, probably. Because I did the first Lothrop maybe in 2002, and I had a navigation then. So the techniques changed slightly because you put flaps nowadays. So we didn't put flaps in the past, although sometimes I don't use the flaps anyway. And you have more of the curved debriders and so on. But otherwise, nothing much, to be honest.
The technology and definitely this fast bursts and all that. Recently.
So mainly it's with the equipment. The techniques are with the equipment. Yeah, see the orbit is so thin here. So if I'm pressing on the orbit, you see this is very thin, how it's moving here. So let's have a suction. So this is the frontal sinus. So the main thing is that we have this. And I think I cleaned enough now, all the way from the skull base posteriorly to the front. So let's leave it here now and go on the other side for a bit and then come back. So let's have some patties. It's okay. Yes. So I'll leave this to dry out a bit and then come back after we clear the other side. So let's have the freers. I'm just going to push the septum out of the way. So you can see this is the side that is really tight. We'll try to bypass that septal deviation because beyond that point is okay. Posteriorly here. And it's actually bony, it's not cartilaginous, it's quite hard. This side seems to be a bit less inflamed somehow.
Yeah, it's really narrow access on that side. You can see with that deviation.
So let's clear this now. So I've got the polyps here. Not much in this side, not like the other side. So we'll just clear them out. So we'll do the same. We'll try to find the skull base and just clear everything from back to front. Again, here is the very, very narrow sphenoid. She's got a lot of osteitis. Actually, let me show you on the scan. Can I have the navigation? You'll see the bones of this sphenoid. This is a sphenoid sinus. You look at that, how thickened they are. Can we show that image here?
Yeah, we've got it, Hashem. We can see on screen. We've got you split side by side, the endoscopic and the navigation picture.
See how thickened they are. So the sphenoid sinus is very small. Suction. Let's see. Okay, so let's try to use the navigation to see where the frontal sinus is in this side. Suction again, sorry.
So Hashem, a lot of people use the middle turbinate as part of their landmarks for creating their Lothrop cavity and where to do their septectomy and things. Without middle turbinates, what do you do and what would you use as your marks for where you make your Lothrop opening?
Yeah, the only way is to use the navigation here because we have nothing. So I'll use the navigation to find my landmarks. So here I'm in the skull base. So I'm going to go a bit anterior now to see it should be, where we're expected to be, which somewhere here. So it's roughly there. So I just have to mark it with this navigation system. That's the only way to confine it. So what I'll do is I'm just going to keep clearing until we find some access to the frontal sinus, which is about there. And then I'll start opening things. So let's have the brighter. I may, if this septum keeps getting in my way, I may just have to start work on it in a minute, but let's just try to clear a bit more. So I can find the skull base just there. Here it is. So I'll just clear these polyps on the skull base. And try to come more anteriorly here. My maxillary sinus, again, the maxillary sinus is always a good landmark, is always nice because it's not going to go anywhere. So it's always nice to look at it. So at least you can tell where the floor of the orbit is. So our frontal sinus should be in this area, which we still can't see anything, as you can see, and there's no turbinate whatsoever. The other side, we found something, some remnant of the turbinate, but here nothing. So I think what I'm going to do, because I can't find it, it's a bit tight here. I'm going to have to try to remove that part of the septum because it's going to be part of the window anyway. So let's have a look at it. Let's have the navigation to try to mark where we're going to open that septum. So navigation is very useful because you can find where the floor of the sinus is. So if you put it up, try to find where the posterior part, which is roughly there, you can actually mark this bit on the septum. So I'm going to try to create like a little cut with this into the septum. see how tight it is, guys? That it's not easy to put the scope with the navigation in the same area, but it's just there. So I'm creating a small cut onto the septum with the probe of navigation, right? Roughly where I want it to be. And I'm going to create a window here. Let's have the frieze first. And the suction. Try to get mucosa, a bit of mucosa from this area here. Let's have the straight suckers actually to use first. And the navigation probe again. Okay, let's see. Yeah, navigation is playing a little bit, so well, let's just create the window anyway. Let's have a knife.
Nisha, what's your plan for frontal? Are you planning to establish both the frontal recesses and then go lateral to medial?
I'm gonna probably go from the left side to this side because the left side I managed to find it, but here it's very tight because of the septum, and there's no landmark at all here. So I'll try from the other side. Let's have a frieze. So just lifting them because of flap here. Okay, let's now have scissors if you got them. No, the Stamberger. So I'll just take this because if I can, see if I can use it later on or not. Blakesley. No, it's straight, but it doesn't matter. So here's a piece of mucosa. Just keep that one for us. And frieze. So this part of the septum is interestingly bony. It's supposed to be cartilage, but it's very tight. Remember, she had multiple surgeons. She had a repair of a perforation of the septum. So it's quite hard. Let's have a navigation again. Yeah, so I'm pointing at the frontal sinus just about here. So we know roughly where it is, but we really need to to find it from the other side. I'm going to remove a bit more of that mucosa here and try to remove some of that bone. Let's have the debrider. So I'm just enlarging the window really because I need quite a big window because of that septal deviation. Let's have the freers. It is very bony, actually. And I'm going to look on the other side now because I've removed the mucosa. I just want to make it equivalent on the other side. Let's have a tele forceps just to get it back out. So here we have a turbinate, which is in a way is good, like a part of the turbinate. So normally you landmark this part of the turbinate. Let's have a suction just to show you again here. Normally landmark is you go beyond. Here's that what's left of the turbinate, just there. Let's have a freers to show you. So normally landmark is, see what's left of the turbinate is here. Normally you just go beyond that turbinate and you create a window from about 4 millimeter, 5 millimeter beyond the attachment of the turbinate all the way anterior for about 2 centimeters and down to back. So we'll try to do this here. We'll mark it and try to do it as well. Let's have the navigation again.
Hashem, here you're using the inside out, so you're starting with a frontal recess and widen it up. Do you ever use the kind of outside in where you start drilling on the frontal beak? And what would be, why would you want to use one technique over the other?
I use this from inside, like from find a frontal recess and go when it's very complicated like this one. The ones that you have like a nicer anatomy, I just go to the floor. It's much quicker from the frontal beak itself, from the middle. After you create the window, the first thing you do the window, and then I go straight for the better anatomy. But this one is quite tight, and there's no landmark. So I'm now marking the window on this side. You can see I'm just putting my navigation right up here where the posterior part of the frontal sinus is, then going down, and then you follow that anteriorly here. So knife. So we'll clear this. So I'll try to get some mucosa from here. And normally the level of the flap goes at the like lower border of the turbinate, but also we don't have it, so I'm just estimating it here. Real? So try to get this mucosa out. It's quite scarred because she had surgery with flaps for repair of perforations, where it tears a little bit. But still, we have a bit of mucosa, which is not bad. So here it is. Let's have the scissors. And Blake stick, straight Blake stick. Okay, sorry, it's still there. Oh, let's have the scissors again, sorry. This is a nice piece, this one. It's better. No, can I have a straighter one? Or to the left? This is a nicer piece than the other side. Okay. So a nice piece to keep. So now let's see if we can create the window by removing the cartilage or the bone, or that bone really. So see that exposure here. Frontal sinus is here somewhere, and that should lead us to the other side that we created as well. We could check it again with the navigation. Can I have the navigation probe? So the posterior extension is just there, just where the floor of the sinus or the posterior wall of the sinus, and here, and then opens there. So let's have the FREERS. Maybe I will remove this. Actually, the brother for a second. So now let's try to remove this part of the window, the bony. It's actually bone, which is unusual in a young person like this. Usually it's just cartilage, but it's completely calcified. So we're probably gonna have to drill it. Let's have a chomper. This is very hard. So remember here, we are just under the nasal bone. So you're not at the risk of causing fracture into the skull base because you're very anterior here, but you still have to be careful. So it's best to cut it than pull it basically. So I'm using a forward cutter. Here you go. You can see how it's just bone here. Okay, good. Let's have a Blakesley. So you start seeing the window now. It's always good to do that window early because then you can see where you are and you get access to the other side, because without this window it's impossible. Yeah, this is really the most important step if you're lost. You have to open the window first. So I'm just looking from the other side, just seeing my window. It's there. So it is connecting. So just remove all the hard tissue, the bony tissue. And when it's complete, when you can see both middle turbinate, which we don't have, but we'll do something else, then you know you've opened a nice window that's sufficient for you to work from both sides. So we can start, we're looking at the other side, but we still can't see where the frontal recess is, but we will see in a minute. We'll have to enlarge a bit more. So let's have a backbiter. Now this perforation is quite high and it's quite posterior. See, you can't see it when you look straight in the nose. You have to look up. So it's away from the air current. So it doesn't tend to crust or cause problems with the airway. So it is okay. It's just bony here. Okay, let's give you that again. So a bit more to remove. Let's have it again. See, it's all bony there. Here it is. And suction. Just trim a bit of mucosa just to get a bit more space from that window. So I've removed a lot of the bone now. So just don't stop making the window until you make sure it's big enough. So you just have to keep checking it until you know that you could see everything. I can start seeing both sides, as you can see there. So just clear all this. Until you reach right up in the floor of the sinus, which is about here. So it's still a bit of cartilage to remove here. So if we start looking, we can actually see from both sides now. It's something that looks more useful for us. Let's just remove this bit of cartilage here. Let's have the Blakesley, straight Blakesley. And the septum now is going out of our way a little bit. So let's keep this bit just in case. So this seems to be a bit cartilage here. It's a bit better. Or is it bone? I think it's still bone. Yeah. So this is our window coming nicely. I think it's almost there. We will clean everything in a minute and show you a bit more, but let's just get all the bits out. Let's have the debrider. Just to clear everything, because all the area that you want to clear is where you're going to create that drilling. I mean, you could almost see where the lothrope is going to be. You're going to start in the frontal ethmoid recess like this, drill this, which is the floor of the sinus, and then join it to the other side. So you see how everything is very inflamed here and not very friendly. The polypoid here, but we're probably not going to remove a lot in this area. So I think it's almost enough. Okay, so let's have a look with the navigation now. So we're looking at frontal sinus in this side, here, and that's the beak. This is the beak here. There. If we put the navigation in the middle here, that's like the floor of the sinus and then to sinus septum. So we want to drill that way, forward like this, and then like this, and then like this, connect to find this one. And this one is here as well. So we sort of found it as well. But obviously you see how horribly inflamed and bloody and everything. It's not the usual nice one that you want to do, but we're doing it for you. Can I have the back biter? So I'm removing a little bit of that cartilage in the bottom because you don't like to have a lot of exposed cartilage. So, and I say again, without navigation it will be harder. Navigation is very useful to confirm where you are, just to find out and confirm where you are. So just remove this piece of cartilage so we don't have exposed cartilage anymore. And that makes your window big enough. A window that is not big enough will lead to closure or stenosis of the lothrop, and will cross and will annoy you so much. Will be on your way. Okay, let's have an irrigation now. Can I just have a 45 Blakesley for a second? Just to remove this bit here.
Hisham, if that is all right, Dr. Satish is just explaining about his case, so we'll briefly visit him and come back by the time we prepare for that.
No?
Ashok, we're just going to go to India for their case introduction, then we'll come back and join you.
Okay, Doc.
Thanks.
Are we off?
Yeah, shall we connect to Nagpur, please?
Horrible case.
Yeah, you're still on, Hisham.
Where is Priscilla? This is horrible.
We can still hear you, Hesham.
Yeah, we're almost there anyway. We're gonna finish.
Okay, studio, can you connect to Nagpur, please? Hello, Dr. Satish.
So what I'm going to show is, for the sake of demonstration here, we'll remove this and we'll be using pre-lacrimal approach to marsupialize this region.
Okay.
Okay?
Yeah.
Pre-lacrimal means our access would be anterior to the lacrimal system without damaging it. There are two approaches. One is the modified denture.
Yeah. Yeah.
Dr. Satish, we're back joining you for the case review. So, would you mind just briefly reviewing the case for us?
Hello.
Yes, yes, Satish. Can we switch off Devan's mic, please?
By showing you what we were discussing is one is modified dentures, in which we remove the entire medial wall, cut the nasolacrimal duct shaft, and marsupialize the entire maxillary sinus into nasal cavity. Or making that. And that gives you opportunity for the lifetime surveillance as well.
Yes.
Here, this kind of a cyst, if you really want to marsupialize, what we can do is pre-lacrimal approach. Pre-lacrimal is open the anterolateral wall anterior to the lacrimal system.
Yes.
The flap,
Yeah.
marsupialize,
Yeah.
and then close it, suture.
Okay.
Mucosal surface. So, close it, it doesn't leave an open cavity. Doesn't give any opportunity to the benign thing. Doesn't need any surveillance after a full marsupialization, even after this particular situation. We'll be doing pre-lacrimal access for this. We'll remove this anthroponal polyp and lacrimal access for this.
Okay. Can you have access to the inferior meatus in this case?
Access to the meatus can be done. That is a narrow access, number one.
Okay.
And if you try to enlarge it, end up damaging the nasolacrimal.
Okay.
There will be more anterolateral, more wider approach, and we close it. We don't want inferior meatal approach gives a drainage for the future, which we don't need here.
Yeah.
Choose marsupialization of the cyst. Doesn't need any future follow-up activity.
Okay.
Show you.
Sure.
Well, probably are struggling to connect to Nagpur. So shall I get back to studio briefly? Okay, I think what I gathered from the CT that this is a unilateral disease. In the left side, you can see probably there is a large anteconal polyp with some cyst. So they were discussing about modified Denker's approach. But for plan for this case is a pre-lacrimal approach to deal with it. So while they're connecting and starting, we can get back to Hisham for his low top and catch up with it. So over to London again. We'll keep an eye on when they start surgery. We may join them briefly. Thank you.
Of the threat of the environmental crisis as well as the social inflection. Priorities and consumer values change radically. We have reacted. We have initiated major changes already, with many more ahead. Not to survive, but to keep our business ahead in this disruptive world. We have pulled the switch to green power. We have already significantly reduced our global carbon footprint. And we will continue to do so. With energy targets clearly defined, our monitoring systems perfectly control and enhance our...
They're back.
Funny. I think it's not accurate.
Okay,
Hisham, we're back to
Hesham,
you.
we're back with you. We can see what you're doing now. We were just in Jaipur and they're about to do a pre-lacrimal approach for maxillary sinus. So they were showing us their scans, but we're now back with the modified Lothrop.
Function.
So it looks like you've got the frontal sinus ostium there. Is that right?
Yeah. So So I'm here. I'm looking now on the left frontal recess. A bit larger. So what I'm going to go forward.
Yeah.
Until the intersinus septum, which will be about here, and then I'm going to go to the right frontal sinus to join them together. So looking here underneath, you have a suction frontal sinus. So I put the suction.
Have you got the frontal recess on the right side yet, or you're just going to go to it through the left from the left?
Yeah, but it's not as well defined. So it's not as well defined as the left side. Sorry. So it's just there, it's a bit tight here. So because of this, I'm just going to start on the left. It will be easier to do.
And Hesham, just out of interest, what angle scope are you using at the moment? You still on a 0? Or have you switched to a 30 or 45?
I'll switch to a 45 soon, but not yet.
Okay.
Let's have an approach. I'm going to show you if we can see the navigation. So here, it's not very accurate now. I should be pointing to the frontal beak about there. Let's test it. Stopped working for some reason. No, it's not working anymore. Now look, it's a bit off. But off now. So we need to readjust. Let's have the... So I'm going to open further. So now I'm using both nostrils. So my scope is in the right nostril and my debrider is in the left one. So I can basically open things a bit further here. Let's have a Blakesley 45 degrees. Section. Debrider. Seems to be a cell. And I have a frontal sinus seeker. And suction. Okay, let's have a Blakesley 45.
Not uncommon entities Still not under.
So I've enlarged the frontal sinus from right inside now. Maybe I can now change the 45, so I can show you the cavity. I'm gonna change to 45 degrees. I can show you inside the frontal sinus. And then I'll start drilling. Oops. White balance. Right, so let's have suction now. You don't have the other frontal sinus sucker that goes like, the light goes from the side. It'd be easier in the scope. I mean. Yeah, the scope. So look at the frontal sinus inside, yeah? Look at all this polypoid tissue here. So in a minute now, I'm gonna start drilling. So in a minute, I'm gonna change into my Midas drill, which is a faster drill. So just remove that polypoid tissue here.
Is that the 40-degree debrider there or 60?
Yeah. So here we are. This is the cavity of the frontal sinus. This is right up there. And you can almost see that we not very far from the anterior wall. So let's have the Midas. So I'm going to use the drill. The faster drill, the Midas drill. We need to change it there.
And what sort of burr do you use on the drill, Hashem? Do you use a diamond or a cutting, and what size? Cutting.
Okay. 4 millimeter cutting.
Okay.
4 millimeter cutting. Okay.
That's it. Yeah, perfect. Let's have the suction. So this is a very fast drill, so you have to be very careful with it. So don't start with the maximum speed. And the problem with these, you don't have suction, but they have irrigation. So let's see if the irrigation is working. Oh, yeah.
For the trainees who are watching, I would suggest if you're in the initial stages, use a diamond because it's a little bit of a margin of error for that. Cutting is okay for experienced surgeons like Hisham. But do use cutting if you got enough wide space. But for a narrow recess like this, for surgeons in initial stages, diamond will be a better drill. You agree, Hisham?
Okay. So this is a very fast drill, so you have to be careful. So actually it's too much irrigation here, so let's just decrease it a bit. So see, I'm not going full speed. I'm just gauging my speed first, just drilling forward. And if you see what I'm doing, I have my scope in the right nostril and the drill in the left. And then we can swap again. This is bringing my opening forward. So I'm drilling the frontal beak now. And I have my suction in the other nostril. I just leave it there. Nobody's holding it. Because otherwise it's too much irrigation anyway. So now I'm putting both of them on one side.
See how carefully is working just on the beak and avoiding any contact with the posterior wall.
Just the frontal beak.
You're feeling the reach and flattening it down. Just like you drill the master ventrum.
So here we are. So we're already opening widely in the frontal sinus. We need to drill here laterally so we get to the subcutaneous tissue or the skin, like PJ1 will say. So this area here laterally. So I'm going to get this. So you need the widest possible lost rope or opening. So just clearing this soft tissue from it. And I'm not pressing full speed. With this full speed, the drill will just go too quickly for you. So if you're not sure, use a diamond burr. I like using the cutting burr. I can control the speed like a car. Just press a little bit and you don't go full speed. So we started to see more into the frontal sinus. And when you see the frontal wall, then you know you reached your level. I can see it already. Look at that. So it means we can go toward the right side in a minute, but I'm going to just drill laterally first. That bone on the lateral wall there, I need to thin it a bit more here, a little bit here. And if you think about where this bone is, it's just underneath the nasal bone. So if I put your navigation, this, I don't know if it's accurate enough, but okay, so it's just roughly there. Yeah, maybe it's okay now. Or is this not moving? No, look at it. So it's not accurate. It needs to be registered. So maybe we'll just re-register it. Let's do it. We're just doing a navigation again so I can show you. Okay.
So that's the infrared navigation you're using there, Hesham, is it, with the surface matching rather than it being magnetic one?
That's right. Yeah, I always use surface marking. It's quicker. The electromagnetic may be a bit accurate, but it's had a lot of wires and cables and takes a long time to register. So I've always preferred that. Check landmark. Can I check? Is good? Yeah, it's good now. So we'll now have a look with the navigation to show you.
I guess it shows that you can't just rely on navigation. You have to keep checking all the time.
And that's if I didn't know where I was, I said, oh yeah, here we are, and go for it. But obviously, I knew it was. So if I go where that bone I wanted to drill, just about here. So see where it's pointing. It's inside the frontal sinus, but also, I'm just going to put it from the other side to show you better. So here is the navigator. So that's the bone I want to drill here laterally. It should be under the nasal bones. Yeah, see the nasal bone is just underneath it. That's where it is, although it's not moving. So that's where we're drilling. It's a bit lateral, but that's gonna give. Let's try again. Yeah, let's try inside. Still not perfectly accurate. So, but we know where we are. So let's have the drill. So we'll go and drill a bit more here. Can I have some more anti-fog, please? Anti-fog. And let's check if we've reached the skin yet. Not yet. So I'm pushing the skin from outside to see if it's moving, but not yet. So always move with a drill. Don't put it in one point and just drill because it will just create a deep. Now we've reached the skin. I could see it here. When I'm pushing, it's a little bit of movement. It's not very obvious yet, so we'll do a bit more. Why do I do this? Why do I have to reach the skin of the subcutaneous tissue? Then you know there's no bone there to grow back. That's the idea. And then also it indicates that there's no more you could drill. Yeah, it's quite thick, so we're doing it gently just to make sure we're not doing too much. Okay, more. In the scope. So we have a big opening here. I'm just going to show you the other side, then we'll jump back to this. So let's see if we're going to go to the other side now. So we know that the other side is just going to be somewhere here, somewhere there. The other frontal sinus is just here. So we could just go from here and drill again and back there, forward like this, and then joint them, or you can go from left to right. Let's have the navigation probe for a second. So we show you this. This is the frontal sinus on the right side. Yeah. Not accurate, but it is. Let's have the curette. So we could just bring this bone a bit forward here. Let's have the Blakesley 45. And suction. So it's a bit tighter in this side, the frontal sinus, but the bone is not very thick. So you can just remove it a little bit like this. So let's have again the 45 Blakesley. So we're already seeing into the frontal sinus, already starting to make that shape of a Lothrop procedure, which is connecting these two sinuses together, basically. So it feels a bit tight. If you look at the scan, there was actually like another bar there, or another like wall. Let me have a navigation, I'll show you. So maybe that's what I'm hitting here. Somewhere there, but I'm gonna come that side now. I'm gonna drill this way to here. So if I'm putting this, this is the thick bone of the middle septum, or the sinus septum here. I'm gonna go through it. Let's have the suction, so all the secretion will be sucked out. I'm trying to shake the blood out, but sometimes it doesn't come out. Sometimes I use the sheath, which is the endoscope. Sometimes I only use it actually for Lothrobes. I don't use it for anything else. But we haven't used it today, so because with Lothrob you're working from below, so you're actually underneath the drill. So that's why you get a lot of things, blood and so on, that comes in yours, affect your endoscope. So we can start seeing more and more on the other side now. So I lift my sucker there, just staying there. Yeah, so one day they'll be invented one of these fast drills with suction as well. If you saw the scan as well, they are the left side, the sinus is bigger. So can we see the intersinus septum? So let's have a look inside now. So we just below it here, look, that's it. So we'll continue drilling. I'm just going to point it here. We put this here. So I'm in the intersinus septum. See exactly where I am now. Okay. So I'll see the right sinus is much smaller than the left one. So let's open that now. Continue with the drill. So that's where endoscope would have been useful here, but we're okay. No, I can't put it on now, doesn't it? Just this bit when I'm below the drill anyway. Suction. So thin bone here, so I'm just going to remove a bit more. Let's have the Blakesley, so 45. I'm trying to see if I'm close to the right side, I can connect them easier from the right to left, or just continue as I am. Suction again.
Kath said you could try some of the electronic birds. They have suction.
Okay, well,
But
I was
it's only
thinking.
like only 30 K though.
No, I'm gonna have to connect it here.
Yes.
Yeah, soon we'll use the, after I do this bit, we'll use the finesse guard. So I'm almost there now. Because this bone, see how thick is this? Use the other ones, will take forever. Yeah, so that's good. We're almost there. So suction. So soon when I reach the other one, because this bone is so thick, I could use the other drills. This is the right side. I could use the other drills, which is a bit slower, but because the bone is so thick, I prefer to use this faster drill. When I completely open this, then I'll refine things with the finesse burr, which is the one that connects to the normal debrider and has suction in it. Here we are. So now we've got connection. Will it have suction? So see that other septum here. The sinus had two septums, this one and this one. You can see that in the scan. So obviously we'll bring this down as well soon, but this is the intersinus septum. This is another septum into the frontal sinus. So let's drill that one, finish it first. Okay, so let's get ready with the finesse because now I'm opening it. So now I have a big opening, but I need to enlarge it more. So let me show you first, and then we'll change burrs now. So let's
So for some of the people just tuning in, can you just go through where your landmarks are now and show people the posterior table, anterior table, and lateral walls so they can see what's going on?
Okay, great. So this is through my septal window now.
Yeah.
Here is the left frontal sinus. This is the posterior wall of the frontal sinus. And this is the roof, and the anterior wall is here. And this is the intersinus, or what's left of it. And this is the right frontal sinus here. It has a laminated wall here, another wall there, just like a small one here, there. So that's the rest of the cavity of the frontal sinus on the right side. And this is the posterior wall here. And anterior wall is just, we can't see it yet. So I'm going to remove this, and it will be into the frontal sinus. This here, part of the posterior wall, which we're going to drill down, because we want to reach the anterior, the most anterior olfactory nerve, which is going to be here. Yeah. This is, and the nerve. See there? That's coming through a small cavity here. This one there.
Yeah, so that's nice.
So we could drill this bit, this bit as well. So I'm going to drill this bit more first on the right side, open it further. Yeah. And then we'll change into the other drill now. Is it? No, it's not changing. You have to spray. Somebody has to press this. We'll just change the drills now. No, it should be 12 or 30,000. We need a drill. So I'll press from here. Yeah, put up, put 30. Perfect. So we've got the drill now. So this is the curved one. So this is 40 degrees. This one obviously just connects to the normal debrider, so it has suction in it. And like I said, I could drill a little bit here as well. Can we decrease the irrigation a little bit? No, down. Yeah. Maybe a bit more section. So you can see now, this is nicely open in the left. We need to open the right side a bit more. We'll just continue with it. So if you look from here, let's have a drill. So again, my camera is still on the left, on the right nostril, sorry, and my drill is on the left side. You always have to be careful when you drill this. I'm not pulling on full speed. Remember, I said the first olfactory nerve is just there. So we're just anterior to it. And that's again the intersinus septum. We'll drill it a little bit more. And I showed you earlier, there's like a lamella here. Gently take that off as well. So the idea is to create a very large stoma, basically, as large as possible. And then we're going to reach the skin subcutaneously, both sides. I'm going to now put my scope in the left nostril so I can drill more onto that right side, so I can see a little bit more into it. See how smaller the right sinus compared to the left one? Because the intersinus septum is toward the right side. You can see the intersinus septum, you can see where the right sinus is. So we need to drill a bit more here, so let's have a drill. Getting there nicely now. So we're almost opened the whole thing, but not yet. You need to get the maximum opening. Suction. So every now and then we check. So I need to drill a bit more here. Okay, drill. So I'm now putting my drill into the right nostril. This is unusual. Don't always have to do that. While my endoscope is in the left nostril. Just to drill anteriorly. So the whole purpose, as I said earlier again, just creating the largest possible hole. So let's check this. Should I smile? Excellent. See, now we almost have symmetricals, but remember, obviously, the size of the sinus itself is asymmetric anyway.
Hesham, do you notice a difference between the previous 12K drills and the new 30Ks that you're using for the finesse?
Definitely, much better. The finesse obviously is much slower, but it's good. It's comparing to the 4K drills that we used to have. This is much faster, double the speed, more than double the speed. So it's a lot faster. So it is much more quick, really. Can I have the Blakesley? I'm going to remove that bit of mucosa here for 45. Yeah, it's a lot faster. Take this.
Hisham, that was a great cavity. So in the meantime, can we just check on Nagpur whether they're doing a modified Denkers? So we just catch up with them and be back.
So let's have the drill again.
Hesham, we're just switching to India, okay? So we'll be back with you in a minute.
Next 10 minutes or so.
Thanks.
Hello, Dr. Satish. So we were back to you. So can you just take us through the case that you just completed? Looks like they are nearly finishing that with the modified Denkers.
Yeah, it looks like they're just closing the flap
Thank
again.
you so much, Satish Jain,
Thank you,
sir.
Satish.
Was
A wonderful demonstration throughout the day.
Sir, thank you for your time, your attention.
So
And obviously, thanks for
Dr.
involving
Satish.
me for this.
It's always
prestigious
pleasure
event.
to have you in Nagpur. And we'll meet personally at the banquet now. So thank you very much.
Thank you.
Thank you, sir.
Say
May I
this one stitch. Put one more.
May I request Nandu sir to please step forward to felicitate our moderators, Dr. R.B. Deshmukh sir. So President Eva is coming to you to felicitate you.
I think, sorry, we probably missed the case. They're just about finishing.
After an
So
exhaustive
we'll join back to
session.
London, please. Thank you.
Thank you so much, sir. Dr. V.P. Nikhar.
There we are. We can hear you now. That's a really nice wide opening there.
Everything. Now we got the big space here. So that intersinus septum that was here, I lowered it as well. The other one there. So that's all. This is the right frontal sinus now. It's all open. I think that's my limit for posteriorly as well.
Yeah.
It's
So
very asymmetrical, much bigger on the left than the right, those frontal sinuses, aren't they?
just a little bit of cleaning here, and then I am gonna put the mucosal flaps, and then I'm gonna cover them with the propel. Let's have the 45 Blakesley. Piece of bone here. Here on. Here. Okay. So here we go now. So this is the cavity. Let's wash it. Before that, I'm just gonna trim this bone. You can't leave bone exposed like this. So can I have the chomper? Just trim that piece of bone. Okay, let's have some irrigation now. And suction in the nose. Another one. Oops. It's blocked, I think. Yeah, it's a bit blocked. Okay now. Okay, so let's have a look. Just clean it first. I will probably need your suction again, that one you have. So I just cleaned it, wash it out completely, make sure there's no bits swimming around. All looks fine, take them out, all these little bits of bone, cartilage, whatever. All the bone is covered. Get some blood clots here, just clean them out. All the bone dust, you don't want it to be there, obviously, because it will get infected and cause you problems. So we try to put some mucosa on the exposed bone now. So this bits of mucosa, I'll try to put them here. So let's have the mucosa. So that big piece of mucosa that I had with the Blakesley 45. And we'll try to put it in the anterior wall. And then I need the propel to open the propel. So we'll go like that. Put this here and then try to move it around. So let's have the freers. So if it doesn't stick, then don't do it, because otherwise you block your, because it's quite edematous actually. So we'll try to cover this. The surface is that one, like this. Cover that bone here. Now, can I have the frontal sinus curette? So we'll push it like this. Like that. So you're depending on surface tension here that will keep it stuck to the bone there. It is obviously thick, but we'll see. Maybe we can squeeze it in a bit. Yeah, that's not bad. Like this, we're going to try to open it with the propel as well. Let's have the seeker. Let's have the seeker. The small one, yeah. And then see if we adjust a little bit more. It's very, very thick mucosa, which is in a way good, but also bad because it can narrow things for you. You don't want that. But really, the mucosa, if you manage to get like grafts like this, it will decrease your osteitis and you get less of narrowing from the bone. So let's see if we can stick this like this. Yeah, so it's a free mucosal graft. Oops. That's okay. Let's have the free. So it's sitting like this. I'm going to push it up, hopefully with the propel. We'll see. Seeker again. The propel obviously will decrease the edema because decrease steroid. So let's have it. So here is the propel. This is the introducer. Put it there and just opens up. So let's see if it can just go. So I don't have a propel contour. So this is not the specific frontal sinus one. So we'll just use this one anyway. Just put it there where that graft is. See what happens. Push it right up and stays there, and we'll hopefully keep our graft stuck. It does that. So we can push it a bit. Can I have the seeker? It's good. I think it's working. It's holding it in place. Can we have a picture? Yeah, so it's holding our graft in place. Thank you very much. So it should be okay. Yeah, this graft will obviously shrink. This will keep secreting steroid mometasone for a month. So we'll decrease the edema, hopefully decrease the osteitis and swelling and everything else. So that's it, done.
That looks great. Thank you very much, Hesham. They got a tricky case lined up for you today.
So luckily we managed now, so I think it's okay. Thank you
It
very
looks
much.
really good. No, excellent. Thank you. That looks really nice. Nice to see the propel in action.
Yeah, it's great. Well, one more case to go.
Good.
Yeah. Yeah, that was great. I mean, I'm surprised you chose that for a demonstration. It was not an easy case to do, but we managed it very well. I think that establishing the frontal recesses, then creating the access. I think initially the challenge was having that access due to the septal deviation, not knowing where things are. But once he created that septal window, for that navigation was a little bit helpful. But again, you can see at times the navigation is not the most reliable. So you really need to know your landmarks and know your anatomy well. So once that septal window was created, we managed to get some access. What helped also is the left stump of the left middle turbinate. So that helped the left access. And then once that left recess was established, he used it to advantage to transfer it to the other side. So interesting case. And again, staying anteriorly, making space for your drill, and then finding your landmark laterally to the skin, and then making space and going to the other side. So that was the key. So what do you think, Catherine?
Absolutely. I mean, it was edematous mucosa, tricky access to get in, no real landmarks there. So it was really good to have the navigation, but you do need to know the anatomy in spite of having navigation there, and just taking your time to find your way around and look for any sign of the anatomy that you can. So that stump of the middle turbinate, as you say, it was great to find that. And it was interesting to see the asymmetry in the frontal sinus there. It was really dominant on the left side, a much smaller access on the right side with a small sinus there and a really thick intersinus septum. But it does make you wonder in these cases where the revision surgery is so difficult because there's so few landmarks. Should we be looking in Sampters patients or people with difficult polyposis at maybe doing a Lothrop earlier? I mean, this patient had had 5 surgeries prior to this. Would it have been an easier operation for the surgeon earlier on? Probably. But would we be doing unnecessary Lothrops if we did more patients early? I don't know. What are your thoughts on that, Ashok?
That's the dilemma, isn't it? So that's why if you are sacrificing the landmark, we should to think very carefully. Think ahead that these are patients with a difficult recurrent polyposis might end up requiring further procedures. This is not their last procedure. And I tend to do, even if I have to sacrifice a middle turbinate for access, I tend to leave a bit of a stump adequate enough so that it can be used as a landmark. So I'm always thinking ahead. What if we have to come back here? What if the other surgeon comes back here? We should have some landmarks to get in there.
Absolutely. I think that's what Dr. Jane was doing earlier this morning when he sacrificed some of the middle turbinate. He always left that stump of the middle turbinate behind, which if any further surgery was needed, then you've got something to go on and you're not without landmarks at all. So I think it's really important to think about any future surgery when you're doing the initial one to make sure that if you have to go back there, you will be able to do it and make your life easier in the future. So it's nice to have that available.
Yes, and you briefly mentioned, Catherine, a very interesting point about inside out and outside in Lothrop. So that can be confusing. So sometimes they tend to find olfactory neuron first and get to your central axis through the interfrontal cell and then spread your Lothrop out bilaterally. So that's another landmark. So what is your approach for olfactory neuron? To find it at the very outset, or like Hisham showed today, you come to it eventually when you done the rest of the Lothrop?
So I tend to follow a similar approach to Hesham, not surprisingly, as I was one of his fellows. But yes, I will always go for finding the frontal recess and try and work from the recess and then go across. Obviously, sometimes that's not possible. And if you have very narrow access, then drilling down your frontal beak and following your frontal beak up to the midline, you're fairly safe in the midline, and then you can open out laterally. Then that can give you a good way in when there's very difficult access in order to get into the frontal sinus. Navigation's useful on those cases as well, so you can show where you are. And if you know you've got thick bone on the frontal beak, then it's sometimes useful to go through that way.
Yeah, absolutely right. And what I like to do is collect as many landmarks as I can. Say, for example, you're elevating the flaps for mucosal lining flaps on 3 mucosal graft when you create your septal window. I think I try to establish my first olfactory neuron, first defining this anterior ethmoid, the anterior nasal artery is a branch of anterior ethmoid, very nicely shown yesterday by Prof. Castanova. We had a situation where that anterior ethmoid was dividing, going to the skull base, and then other was going to as an anterior nasal artery. So that artery, you encounter it first in a groove, and then you hit the first olfactory neuron. So I like to establish that first. So I may not use a central approach, but it is there in front of me. I know that my one landmark is safe, my skull base is safe. So even if I came from the frontal recess to the centrally. And also other landmarks are defining the skin bilaterally. That's another landmark. Then also, if necessary, you can define your lacrimal sac. Not necessarily the whole, you don't have to expose the whole sac, but at least where the sac is. So that also helps. And then you know where is your skull base is, where the lateral landmarks are. And if you have to use either of the approaches, then you have that option. So it's not really one or the other. You should be able to use both approaches.
Absolutely, I agree. And in certain cases, you'll need one more than the other, and knowing the key landmarks around there and being able to work off each of the landmarks and their relation to each other is really important. So that's a really nice technique of going through it bit by bit and showing each bit as you go.
Yeah. Another thing, I think, if you really struggle to establish the frontal recess in a place like this, it is brilliantly done, Hisham, today. But we also have an option of performing frontal minute refine. We have this specialist minute refine kit. So in a very difficult cases, sometimes that helps as a guide to find your frontal recess. So on occasions, I have used that, and then you know your frontal recesses are, it becomes slightly easy. But I know there are some manufacturing issues, and that kit is not really available widely. but we're lucky ones and we have it. So I find it useful. So do you have that?
I don't think we have any of the frontal trephine sets left, so we tend to be down to a drill if we're doing that ourselves rather than the trephine. So we would drill through the frontal table if needed to. But touch wood, I've only needed that for a Pott's puffy tumor when it's been very inflamed and difficult to drain rather than having to get it for the frontal access. So, but I haven't done as many cases as you, Ashok, so we'll see.
Yes, so nice, really lovely case, and nice to see how you work things out when there are no landmarks, and the pathology was also quite challenging. So I think Nagpur has now finished. So that was the last case we just missed, and it was a real dilemma. Shall we go there or there? Both the cases were interesting, but we started with Sham. We decided to stick to it. By the time we shift over, the case was finished. But I'm sure for next event, we'll try and get Dr. Jain to demonstrate this modified dentures, and that's another reason to join back to us. So the next case now is a CSF leak. So they'll probably need some preparation time. So maybe we can take a bit of a break and join back, say 10 minutes.
Yeah.
Is that all right?
Yep, that's great with me. So that will work.
Thank you.
Thanks.
So all those joined us, thank you for staying with us. Now, this is really the last case of the day. There is a CSF leak closure, another very interesting case. So we'll see you back in 10 minutes. Thank you.
Thanks.
The Advanced Image Guidance System for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise. We're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth. Stealth Station ENT, the Advanced Image Guidance System for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise. We're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
We know the world we live in changes drastically, faster than ever before. We are aware of the threat of the environmental crisis as well as the social inflection. Priorities and consumer values change radically. We have reacted. We have initiated major changes already, with many more ahead. Not to survive, but to keep our business ahead in this disruptive world. We have pulled the switch to green power. We have already significantly reduced our global carbon footprint. And we will continue to do so. With energy targets clearly defined, our monitoring systems perfectly control and enhance our energy targets. The integrated water cycle concept of our new production and logistics site in Neuhausen will save about 10 million liters of water every year. Enough to cover the consumption of a city with a population of 78,000 for one whole year. We are planning well ahead for a sustainable future. Our new site in Neuhausen will be as close to carbon neutral as can be. Reusing excess production process heat, modern waste disposal management, PV systems for generating renewable electricity, recirculated wastewater, and an optimized transport system add up to the best resource management possible. Let's shape a sustainable future together.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you. Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
We know the world we live in changes drastically, faster than ever before. We are aware of the threat of the environmental crisis as well as the social inflection. Priorities and consumer values change radically. We have reacted. We have initiated major changes already, with many more ahead. Not to survive, but to keep our business ahead in this disruptive world. We have pulled the switch to green power. We have already significantly reduced our global carbon footprint. And we will continue to do so. With energy targets clearly defined, our monitoring systems perfectly control and enhance our energy targets. The integrated water cycle concept of our new production and logistics site in Neuhausen will save about 10 million liters of water every year. Enough to cover the consumption of a city with a population of 78,000 for one whole year. We are planning well ahead for a sustainable future. Our new site in Neuhausen will be as close to carbon neutral as can be. Reusing excess production process heat, modern waste disposal management, PV systems for generating renewable electricity, recirculated wastewater, and an optimized transport system add up to the best resource management possible. Let's shape a sustainable future together.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you. Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
Hello, welcome back again. So we'll soon join London. We've got a case history up there. So Catherine will be here in a minute, and we'll go through the case history and get started with the case. It's really the last case of this event. So very nice case, CSF leak repair. Yesterday we saw Professor Janki Ram from Trichy, India. He repaired one of the CSF leaks. It was a recurrent leak. The patient had a BIH. They also had a lumbar drain before. So one of the reasons was the lumbar drain could be blocked. So they were changing the lumbar drain. During the procedure, they used the intrathecal fluorescein and repaired the leak with a bit of fat and fascia and mucosal graft turned over it. So it was a flap that they turned over it. So it'll be interesting to see how Professor Saleh today deals with this CSF leak. So hello, welcome back, Catherine. We'll get Catherine to join the studio, please.
Case is interesting, unusual as well. It's a CSF leak case. It's a young lady, she's 29. About 7 years ago or 6 years ago, in March 17, she had a rhinoplasty. And when the surgeon was packing the nose, he seems to have caused a skull base defect. She has very thin skull base bone. So she had CSF leak in March 17, which we repaired. And she's been fine all this time. And then only very recently, she started having headaches. She had an upper respiratory tract infection. And she started having clear fluid coming from the left side again, same side that was leaking before. That was analyzed and it was positive for beta-2 transferrin. There's no history of meningitis. There's no history of head trauma. She's otherwise healthy. There's no history of anything else like increased intracranial pressure or anything. When you see patients with increased intracranial pressure or benign intracranial hypertension, usually overweight females. She's not overweight. She doesn't have any symptoms of recurrent headaches or dizziness or blurred vision or anything like this. MRI, sometimes will show a change in the MRI that, for example, empty cell, which basically because of so much pressure in the CSF, you find that the pituitary shrunk a little bit. There's no signs of this at all in his scan. So it's very unusual for a patient to have a recurrence of a CSF leak that was repaired as a traumatic leak years later on. So I think it's probably because of her anatomy. So we'll probably find out now that we'll repair it and we'll find out if there's another leak from a different site or not. Now I'll show you the scans. Let's show the scan because they suggest that maybe 2 areas. So let's go on the CT scan. Let's go on this next slide. You see, there's the left one is probably the same one. They're suggesting this is the ethmoidal leak. They also suggest there may be a leak in the olfactory area, which is next to it. So maybe. So that's why we're using fluorescein. Let's go to the next slide. This is the sagittal section. It probably shows a bit of weakness anteriorly there. It's not showing it that well, but it's so small. So they were not sure when they reported it. Does she have a defect in the ethmoid and the olfactory as well or not? So we're going to look with the fluorescein. We decided to use intrathecal fluorescein to stain the CSF green. So we'll hopefully find where the leak is coming from, especially if it's very small. I use fluorescein to see where it is. So we'll go ahead and scrub now and have a look and see. Thank you.
So interestingly, it's a very similar case history compared to the like the yesterday's case. So Dr. Janki Ram did the case, but in that case, the patient had a recurrent leak almost at the same site, but the history was different. This is quite unusual. The patient had a rhinoplasty and developed a CSF leak while the patient, the surgeon was putting the pack in, while the other patient had a BIH. So it will be interesting to see how Hesham manages to locate the leak and repairs it. Can you unmute Catherine, please? I think I found.
I'm back on. Thank you, Ashok.
Yes, good.
Yeah, we don't
What's the
often
thing?
see iatrogenic CSF leaks following a rhinoplasty. That's very unusual. I've certainly seen reported, even with septoplasty, though, there are case reports of having CSF leaks with them. And we know that manipulation of the middle turbinate can cause leaks. But imagine if you're putting decongestant or packing in beforehand and you're not careful about your anatomy and put it in blindly. You need to be careful where you go with your tillies, pushing the pack in the nose. But it'll be interesting to see where the hole in the skull base is and where exactly this leak is coming from.
Yes, very strange history indeed. I haven't seen a patient having CSF leak after rhinoplasty.
No.
This probably sounds like it's more related to the way the nose was packed than the rhinoplasty procedure itself.
Yeah, absolutely. So just have to be careful whenever you're putting packing in the nose that you go backwards, not upwards, and make sure you know where your skull base is at the time to avoid the thin area at the lateral lamella and ethmoidal roof, anterior
Yeah,
ethmoidal
that's why
roof.
again, that's why the trajectory is very important whenever you're performing the sinus surgery. When you're introducing your endoscope, your instruments, your debriders, and if you always keep checking your nasal floor, that's one of your landmarks, very important landmark. Where is your nasal floor? Like today, Dr. Satyajan mentioned that the important landmark is the roof of the maxillary sinus, and he follows that as a plane. So similarly, roof of the floor of the nose also serves as a good landmark. So every time you're putting the endoscope in and out, it's good to keep collecting these various landmarks before we advance further. Otherwise, you've got a wrong trajectory before you realize you are heading to antepenile fossa.
Absolutely. And I think in the UK, we have a lot of plastic surgeons doing our rhinoplasty surgery, whereas maybe if it's an ENT surgeon doing rhinoplasty, you'd hope that they might know or be more careful or pay more attention when packing the nose beforehand and decongesting it with the angles. But the plastic surgeons certainly don't have so much training on examining the nose with an endoscope and knowing all the intranasal anatomy in the same way. So something to be aware of for anybody practicing rhinoplasty, to know where their landmarks are and be careful with the nasal floor as they're packing it.
That's right. Anecdotally, I've remember about a case report that some of the neurosurgical trainees were lateralizing the turbinate, which was their first endoscopic procedure. And they put the freer in, and before they realized the freer was intracranial. Again, shows importance of knowing where you are before you take on any procedures.
Absolutely. And I'm not sure what was used to close the CSF leak last time. I don't know. Did Hesham use fascia lata last time, or just mucosal flap, or Duragen or anything? We'll have a look today and see if there's any of the previous closure there, or what's where it's weakened. It'd be interesting to see how he closes it again, whether they need fascia or, depending how big the hole is, what they want to do with it.
Yeah, absolutely. So what was the preparation for this patient? Anesthetic preparation or any, did they put any?
Yeah, so this
lumbar-
patient's had a lumbar drain inserted and has had intrathecal fluorescein, but prior to that, they all get patch tested for fluorescein first to make sure there's no allergic reactions. So this morning when she came in, she will have had her patch test done for the fluorescein to make sure there's no reaction to it. We used to give an injection as well to make sure that there was no problem with intravenous fluorescein prior to giving the intrathecal. We now are confident if the patch test is fine that we can go straight to the intrathecal fluorescein, and we've been doing that for the last few years here to make sure that we can identify a leak intracranially. It does take a while for the fluorescein to get right through the CSF, so you do need to leave it a while prior to starting the procedure, and sometimes we keep the patient head down in the anesthetic room to make sure that we've got a good field. We used to be able to put the lumbar drain in, put the intrathecal fluorescein, and then leave the patient in the recovery room, do another case and then come back, but unfortunately we're not allowed to do that any longer in the NHS. It's only a one-way system. You can't go from recovery back into theatre. So now we have a longer anesthetic time prior to doing the CSF leak repairs if we are using intrathecal fluorescein. And we tend to use the fluorescein when it's a recurrent leak. If there's no obvious site at the time of on the scan of exactly where the leak might be, or if there's benign intracranial hypertension, or sometimes we can get more than one site of leak with the benign intracranial hypertension. So therefore the fluorescein can be really helpful in helping you identify that intraoperatively. It'd be interesting to see if we see any fluorescein today, but certainly this patient in clinic, when she bent forward, she could quite easily fill her pot with CSF. And I think Hesham has a video of it somewhere, so hopefully he might be able to show that for us later.
Okay, so classic case of CSF rhinorrhea.
Absolutely.
And also, how long do you keep them head down position after fluorescein is given in particular?
Ideally, we'd like to keep them head down for over an hour. But in the interests of keeping going today, that might have been a bit shorter. So I'm hoping we will still be able to see some fluorescein when we have a look at the skull base. Yeah, it used to be a couple of hours.
Yeah, I think yesterday, Dr. Jankiram started after 20 minutes of head down position. And towards the end of the procedure, we just about started seeing some color. But before that, there was no fluorescein. But by the time we started seeing it, we had already found the leak and almost repaired it completely. So I think that the timing is the key. And that also explains to our viewers today that why did we have such a longer break than we planned for. We just had a plan for 10-minute break, but because of this CSF, this fluorescein, it ended up being a bit longer break.
Yeah, absolutely.
We should be ready soon. So what would you do with this lumbar drain after the repair?
So we can leave the lumbar drain to take pressure off your repair. And particularly with people with benign intracranial hypertension, we leave the drain in, but we have a strict limit on how much they are allowed to take out per 24 hours or per hour from your lumbar drainage, because you don't want to have a suction effect essentially from your lumbar drain. And equally, if it's a primary repair, or we would take the drain out immediately so that it's less the nursing care required afterwards was different. So our lumbar drain patients have to go to a particular ward for it to be monitored, and not all of our wards in the hospital can do that. So sometimes if we've used intrathecal fluorescein, we will take the lumbar drain out immediately after the procedure, so that the patient can go back to a ward, but that's kind of bed management issues. If it's a benign intracranial hypertension, then we keep the lumbar drain in. It looks like we're ready to go back to Professor Sala. I can see the endoscopic image come on. So shall we see if we can flip back to Charing Cross?
Great. So are we back on?
Yes,
so we're
I
just
can hear you.
inserting the nasal cavity now. The head is still down, so for her to leak, but she's not leaking now. So we're gonna have
Can
to
you
open-
orient us? So which side are you, Hisham?
So I'm gonna show you now. This is the left side. So she's leaking from the left side. Right side is just normal, as you can see. She's got rhinitis, quite severe rhinitis actually.
Okay.
She's got a bit of adhesion here. Just have a suction. We're just gonna clean this. This is the
Hisham,
side.
do you recollect what was the procedure last time for CSF repair, leak repair?
Say it again.
Do you recollect what was the procedure last time? How did you repair the leak last time?
Operation notes, but basically, as far as I remember, she had very thin skull base and multiple fractures in one area. The bone was so thin, so that was repaired with cartilage from the septum and free mucosa and duragen, but no fasciolata.
Okay.
Yeah, and what you can see here now on the left, we're gonna go on the left side now, where the leak was. The turbinate was partially resected here to use as mucosa as a free flap. This is the middle turbinate here. And this is the horizontal attachment. And this is just a new formation within the ethmoid, the closure of the ethmoid, and the skull base is beyond that. So we're gonna open this here to look above there because the leak's supposed to be in this area, but she's not currently leaking. I'm gonna put her head up. So let's put her head up now so can start operating. But I can't see the leak yet. We'll have a look anyway. Hopefully we'll see the defect. So let's have the navigation probe. That's great.
Do you know what was the last time she had a leak?
Sorry?
What was the last time she had a leak?
Very few weeks ago. So this is the skull base. And you can see on the navigation probe, we're just below it somewhere here. Supposed to be just there in this area. So we're gonna open this. Do we have a debrider? Actually, can I just, I'm gonna use this mucosa maybe. Can I have a Blakesley 45? So we'll try to take this, keep this mucosa in case we need it. Seeker, please. Just taking a little bit of mucosa will be useful to use later on. So I'll just peel it off here. I think that's the original mucosa that we used for the repair. Now let's have scissors. If we got the scissor that curved to the left. Yeah. Suction. Scissors again. Normally I take the mucosa from a turbinate, but because that's been used already, so I'm just trying to take something from here just in case I need it. Blakesley? No, straight one. So we'll just keep everything, keep this piece. This is a small part, so this is the biggest one. This here. So we'll just keep that one. So now let's have a look again. interesting, unusual appearance here. We don't know what's going on in here. Navigation probe. This bone is very thin. And you see it's quite low here. It's supposed to be the ground lamella, the basal lamella anyway. But we have to be very careful because her anatomy is a bit unusual here. Suction. I'm not sure why she's got these connections here and here. From there, like this. So the appearance of skull base is a bit unusual. Let's have a Blixley. And we still can't see any leak. So all I'm trying to do now is just trying to create space dissection to see if I can see where that leak is coming from. I want to look at the skull base directly without damaging anything. But I find this is a bit odd, this appearance here. It looks like a cell, but it's just connected here. So let's have the navigation again. So here we're below the skull base there, look. Yeah, it is that cell here, from here to here. So theoretically, you can open it here. And skull base again. So that now is skull base just behind here. Just there. So let's have a 45 Blakeslee. So everything take out, keep it, yeah? I'm gonna give you all these little bits here. Yeah, just keep them. And Blakeslee again. Yeah. So I have to remember the anatomy is really distorted here, so we don't know what is what completely, but here, below the skull base anyway, so we can take this off. To expose the skull base, basically. Suction. Now, is it here? Is it here? We'll see. Blakeslee again. Okay. Can I have a navigation probe? So this. Now that is interesting, yeah. So this is, it's telling us this is skull base. No. So still this can be open. Let's have it brighter for a bit. I'm gonna just open the space a little bit now. Okay, what is this here? Is that green? Small artery there. Maybe. Interesting. We'll have a look in a minute. I have a feeling it's there. Let's have the navigation probe. So I'm going to open everything. I need to see the skull base from back to front. There is the near the olfactory area. And there's a bit of inflammatory change here. So maybe it's here. I have a feeling it is there, but I just want to open the skull base just to see where we are. 45 Blakesley. Let's have a navigation probe. This thick bone here. Okay. To the sphenoid. Section. So I'm still orienting myself, by the way, a little bit, and just seeing, because the anatomy is obviously has changed. So you have to be very careful just to see where we are and find our way around and look again to see if we can see the leak. This is the remnant of the turbinate, slightly adherent to the septum here. Let's have a Frias. Just separate it from the septum. Is this green? This looks green to me there in the back. Yeah. Let's have a suction.
Certainly hint of green even on our screens.
Yeah. So something here. It's obviously posterior because it's trickling backwards, but where it's coming from, we have to see. So that's the superior turbinate here. So we're going to have to reduce that middle turbinate because that's the only way we could see where it's coming from. So I just need to discover what is the anatomy doing here. What is this exactly? And then can gently reduce things. Let's have the 45 Blakesley again.
So Hesham, you do lots of rhinoplasty as well. Have you ever seen many CSF leaks following rhinoplasty before?
No, this patient is the only one I've ever seen with CSF leak after rhinoplasty. It was quite unusual. And when she came with a leak 7 years ago, my observation was that the bone of a skull base was very thin. So it is very unusual. And also very unusual that she has recurrence after all these years. So see this bone is unusual. What is it? It's part of the ethmoids, probably. Can I have the navigation probe? Or is it a remnant of the vulva? I need a cutting, like true cut superior, the 45.
Hisham, what are your thoughts? This is a new site leak or likely to be wearing off of the original repair?
I didn't hear, sorry. What was the
Hesham,
question?
do you think it's a new site or do you think that of leak or do you think it's the original repair that's broken down now?
I have a feeling it's a new site because the original one was in the roof of the ethmoid. This seemed to be coming more medially. Blakely, was it 45? So I'm very gently just removing tissue. So it seemed to be trickling medial to the turbinate from the olfactory area. Navigation probe again. So the brain lab is very useful here, as you can see. This I probably can remove gently. So let's have that true cut again. So you can see it properly into the skull base again. So I need to be seeing the skull base like I'm doing this, so I can see exactly where we are. So orientation, and then we can plan our repair when we find the leak. So I'm just removing a bit more here, gently here. So I'm gonna change my scope now because I want to look right up while I'm doing this. So here's probably the posterior ethmoid artery that's somewhere here. So we're gonna change it to 45 degrees. I want to look right up. So my plan is to reduce that turbinate here, take this off, so I can see into the olfactory area. This is the only way you can actually look at the olfactory area directly. I don't want to just have a freer. So we need to change the 45. You don't want to go with that, with a freer and medialize completely, because you can cause a leak yourself by doing this. You want to gently reduce it here and then look further up. So this is what I'll do in a minute. Now I've freed all the tissues around it here to be reasonably safe to remove this area here, from here to here. And I could use it as a graph later on. You can see the green coming more and more. So it seemed to be trickling from just the olfactory area just here. So let's have the 45 first, then we can do this part. So we change it to 45-degree scope. Most of the time I'm doing CSF leak repairs, I use the 45 because I look directly on them. The first dissections I use the 0, and then I change to 45. I don't use the 30-degree that much nowadays. I find that 45 does give you all the views you want, because it goes really nice up, but also you can look forward a little bit. 30 is a bit less than I need most of the time. White balance again. Yeah. Okay, so now let's change the sucker into curved sucker as well. So this is the original repair. As far as I could see, that here is a thickened bone here. Where the original repair was. This is my feeling, this area here. It's not leaking from here, it's leaking medially. Why would you have a second leak? Also unusual. And the 45 cutting. And let's look up here. That's a frontal sinus. That's anterior ethmoid artery. Looks like that. I'm not sure yet. Let's have a navigation. Interesting that artery going in an unusual direction up there. So let's put the navigation and see where we are here. Just tell us that we're in the skull base. But I see that's what we call Kennedy's something, which nipple. Yeah, I don't want to say that, but you said it anyway. So that's where the anterior ethmoid artery is. So that must be a branch. Unusual to see that. Just there. So we'll leave it alone. It's not leaking there. And this is the frontal sinus. Okay, let's now reduce that turbinate. So suction first. I'm gonna use the scissors to cut it from here to here. And then probably also use the senior, the special, yeah. The green is just there, yeah. So here is our factor area, but where is it coming from? We need to see it properly. Let's have the scissors curve to the right. So I'm gonna reduce the middle turbinate, then the superior turbinate. So we just basically cut below skull base. So we go like this. Sorry, let's get my direction right. So here we are. So with the scissors, we curve downwards. I go like so. Already separate itself immediately. And then I just cut it here. Sometimes bleeds when you do that, so I have to be careful. Suction. Just need to cut the bottom part. Where is this? Somehow it's not very sure. Now the blade, I think it's free now. Let's see. Yeah, it's straight. So here it is. So that's very useful for a graft. Now we look further up. So now we can look behind this. Have the freers. Seem to be interesting that. Still can't see it, so I'm probably gonna reduce the superior turbinate now. Let's have a straight sucker first. Chomper's forward cutting. Forward. Chomper, yeah, that's it. So reduce the superior turbinate. Suction. And let's have a freer now. So I freed that superior turbinate a little bit. Let's see if we could see anything beyond that point. Don't seem to find it yet, but we have to be patient. Just, have the navigation probe. Seems to be an intersinusectomy, sphenoid. We are in the right sphenoid like that. Okay, I'm probably gonna have to remove more of that turbinate now. It seemed to be, often when you have a olfactory leak, it's within the middle turbinate, within the lateral lamellar itself. So it'd be within here. But you don't want to cause the leak yourself. So that's why I have to be careful. But it must be here in this area. It's just very tiny. And that slit here. Let's have the freers again. See that? Yeah, it's not here, it's here. This is it, guys.
Yeah, we can see the fluorescein on the screen.
Yeah. Let's have the navigation probe to point to it now, because it seemed to be just quite posterior here than we thought. It's not coming from the top here. So let's have the navigation probe, compare it to the scan.
Catherine, you got the post-fluorescein timing right.
Yeah.
Yeah, we can see it, fortunately. Needed in this case because it's difficult to identify where it'd be leaking from without it.
See where it is. It's the posterior one. Yeah, it's the one in there. You can see it there.
Yeah.
Quite posterior. Interesting, huh? Okay, let's reduce the turbinate more then, because we can't access it properly unless we do that. So let's have the scissors again. But it is very small. Blakeson.
Hesham, have you opened your sphenoid posteriorly? How close is it to the sphenoid face?
Sphenoid is open already, so then we just go to.
Yeah.
We'll go there. If you look there.
Okay.
Yeah, I'll need to dissect a bit more. Let's have a debrider. It's too small to use fascia, I think. Just very small. So I think we probably use Duragen.
So what sort of size of perforation would you use fascia lata for, Hesham? When do you decide that you would use that?
Yeah. From 5 millimeters onwards.
Okay. And do you ever use a fat plug to close a CSF leak, or is that old school now?
It's a good technique for immediate leaks that you cause intraoperatively, small leaks. I think for ones like this, I mean, it's possible to repair this with that, but she's a recurrence and unusual history and all this. I think probably better use the strongest tissue possible. 45 Blakeson. I find this case very unusual, by the way, because of the nature of happened after rhinoplasty, which is really very odd, and also that she recurred after all these years, and it seemed to be a different site as well. So that is all a bit unusual here. That's why I'm very careful and taking my time here, just to make sure that I look at every possibility. So let's change the suction again to the curved sucker. This is just thickened tissue. This not the leak. So what I'm going to do now, I'm going to freshen the area around that to try to open up a bit more and then to close it. So let's have the bleak, the freers again, sorry.
Hisham?
Yeah?
I present you a scenario. If you went in now and couldn't find any leak at all,
yeah,
there's a clear clinical history and you yourself have witnessed that there is a CSF leak, okay? How would you approach it then?
So first I'll do a Valsalva maneuver to get to get pressure increase and wait. If she doesn't leak still, then I will look for the most suspicious part in the skull base, which I've done that twice. And twice we didn't find the leak in all the cases I've done for many years now. And I look the most suspicious part and reinforce it, Blake's T45. So I basically, the most suspicious part of a leak, I'll dissect it so it can scar down, and then I put piece of cartilage from the septum, glue and a bit of mucosa, and that's it. Just to reinforce it. And it has worked twice in the patient that had that twice in 2 occasions. So that's what I would do. It can happen. The problem with leaks from a small defect are intermittent. So sometimes you just don't want to leak. It can happen. And then it's the best obviously to know beforehand where it is. But if you can't find it, this is what you have to do.
And Hesham, have you ever seen a CSF leak coming from the tegmen presenting as a nasal drip?
Yeah, I had one case, but she was post neurosurgery. She was leaking from the Eustachian tube. So she had a defect in the tegmen after a neurosurgical procedure, and she was leaking from the Eustachian tube onto the nose. So interestingly, the patient didn't want to have big intracranial procedure and asked me to close the Eustachian tube, and she didn't mind staying there. And this is what we did. We just
did it work?
It worked. We published it. Yeah, it was many years ago. That was done here.
Good.
Now let's have the freers again.
So Catherine, I had an interesting one. That patient presented with a classic CSF rhinorrhea.
Let's have
went in, found the leak, repaired it, all well, and then she presented with a CSF otorrhea.
Oh wow!
Say it
A
again.
separate defect or same
patient,
defect?
No, so they just had an undiagnosed BIH. No? So although we had they didn't have the BIH. So afterwards, so you close one leak, so which was serving as a release valve. You switch off the valve, so it's going to leak somewhere else.
We've had a
And
very
then,
interesting case recently as well, similar, but not quite like that. Somebody presented with a neck mass, which they scanned and it was just fluid. They sent the fluid off and the fluid from the neck came back as beta-2 transferrin positive, and it had been leaking from a previous mastoidectomy and through the tegmen. And I don't know how it had got into, you know, a plane into a neck space. So I'd never seen anything like that before. I'm hoping one of our juniors will write up the case at some point.
Yeah, it's visual that. We've had patients who leaked from a second site later on by spontaneous leaks with proven intracranial hypertension.
Yeah, that's what Ashok was just describing. He had one similar. So
yeah,
presented with a nose leak and then came back with otorrhea after he'd fixed the nose.
Yeah.
How did you manage the otorrhea, Ashok?
Oh, then we had to do the lumbar drain and we do the shunt procedure. They had a shunt
Mhm.
and then it all was okay.
Settle down. Do you have any experience of putting patients on acetazolamide for benign intracranial hypertension?
So every patient who comes with benign intracranial hypertension, we put them on acetazolamide before the surgery. Every single patient. So that's how I started avoiding using a lumbar drain on them. So we don't drain them anymore. Put them on acetazolamide for about a week before surgery, reduce the pressure, and then operate with them on acetazolamide. We leave them on it for a few months after. If the cause of intracranial hypertension gets treated, like losing weight and so on, then we can stop it. Otherwise, they have to use it for long term. So that's the thing that I've been doing for the last 4 or 5 years now instead of lumbar drains. 45 Blakesley.
And for any of the patients with benign intracranial hypertension who have a very high BMI, is there a role for bariatric surgery in these patients?
Yeah, so we had one patient that bariatric surgery agreed to do it on them, but for them the limit is have to be a BMI of 40. So if the BMI is 40, they do it, not specifically for the CSF leak, for the other conditions, the diabetes and so on, but they've done it and the patient stopped leaking basically. So there is a role basically because they will increase, if you do a bariatric surgery, it's almost like cures the benign intracranial hypertension.
So did you still have to repair the CSF leak after the bariatric surgery, or had it settled after they lost weight?
Used surgery and she lost the follow-up, but she was not leaking for a year after the bariatric surgery, and she didn't want to have any surgery. We tried. I thought we should still do it, but she wasn't leaking. So the defect was very small. So sometimes you just get infection and you get a bit of scar tissue, so it doesn't leak. So she wasn't leaking it. So we didn't do it. We didn't operate.
Yeah. One of the neurosurgeons once told me that a bit of meningitis makes the CSF sticky, so they can help seal some leaks for you if you want. I don't know what truth there is in that, but it was certainly a neurosurgical myth.
Because scarring, yeah.
Yeah.
So now, see this bit is a bit risky here. The bone of the middle turbinate is still attached, but it looks very abnormal. And the leak is just there. So I'm very gently dissecting bit by bit. Let's have the divider. Do you have a, what divider we have? The curved one. Let's connect the curved one.
Catherine, coming back to your CSF leak in the neck following maxillary surgery.
Yes.
So was that a Bezold's leak or was it a Citylis leak?
Was it what? Sorry, Ashok, I missed the.
Was it Bezold's leak or Citylis leak? You get this master abscess leading to Bezold's.
Yeah, no, it wasn't Bezold's. There was no abscess. So it was the patient had.
I'm just drawing a corollary. That's
But
probably
no.
the likely route it followed.
Exactly. So a similar kind of setup, no pus, but yes, it must have followed similar route to get a neck mass with a CSF or a intracranial problem. So yeah. And Hesham, have you ever seen any complications with acetazolamide use?
Yeah, it causes all these neurological, like peripheral neuropathies. That's the main thing. So a lot of patients give numbness in the fingers and so on. And a lot of them complain about metallic tastes. So it's very common actually to have complications. That's a problem with them. We had a patient who had acidosis, I think.
Yeah, metabolic acidosis. Yeah.
She was very ill with it. So it does have side effects. That's a problem. But we remember it is a standard treatment for glaucoma anyway. But the dose we give for intracranial hypertension is much higher. Maybe we can give her Valsalva because she's not leaking much now. When Mala comes back. Yeah, somehow not actually leaking at all. Disappeared. I've dissected around all the area, so we're completely exposing the factory region here. So it seemed to be that it was here. Yeah. Section. So we have complete dissection here now. This is the area that is weak here. So let's have a happy for a second. So even if it's not leaking, I'm going to lift the mucosa and just repair the area. So just dry it a little bit.
Hisham?
Yeah.
One of the delegates have asked a very interesting question. So for the reconstruction, at what point do you consider using the nasoseptal flap, the traditional Haddard flap?
Yeah. I would use it in very large leaks. So these kind of leaks are very small, so you don't need such a large flap. I use it in very large leak, but mostly it's best suited for the post-operative ones in pituitary surgery and skull base surgery. So I wouldn't use it for most spontaneous leaks are very small, and most traumatic leaks, like from feds, are small. But neurosurgical leaks are large, so it's very useful for that. So I wouldn't use it for a case like this. So the freers again. Just look at other places here, there's nothing there. Something there, look. Suction. Ah. Navigation probe. I'm not convinced yet, 100%, so that's why I keep looking somewhere else. To anterior. Okay, well, let's have the phrase again for a second. So I'm just looking everywhere just to make sure that we're not missing anything. I know we saw the fluorescein, but it wasn't 100% convincing it's the place. So we have to look everywhere. That looks thin. Yeah, that looks like the main thing here, isn't it? Have the navigation probe.
You can see a bit of color as well there.
Yeah, this is what we're suspecting. I think it is a place. It's the olfactory one. So I'm gonna dissect the mucosa here now. This is the most convincing one. Just above here, there. So let's have the seeker. So basically we lift the mucosa to make it, to refreshen it, to make it like scar nicely, and then we repair it. So let's lift the mucosa off this area here. Yes, on the attachment to the turbinate itself. So it's on the attachment to the turbinate. Yeah, now I feel a defect. There. So it's a bit of an awkward place, actually. Difficult to see and difficult to find. But that's definitely not the leak that you had last time. Why is that? Did the trauma affect this area as well and was it leaking all this year? Maybe.
So very interesting, Hisham.
Yeah.
This morning, Dr. Satish Jain, he was showing the CT scan, and he showed the turbinate attaching directly to the skull base and very thin skull base.
Yeah.
So, he was mentioning a caution about moving the turbinate and dealing with it very carefully. Because if you're aggressive, you can cause a CSF leaks, and it's probably. Possibly it was a plastic surgeon doing rhinoplasty, putting the pack in, whether they disturb the turbinate.
Maybe.
Doing that. Yeah, that's quite
possible.
Maybe.
Seeker again. It's interesting. What interesting is that why it happened. Here's the defect. Here's the edge of the bone. Look. You see the edge of the bone here, and this is the defect, this there. So just lift that mucosa a little bit more. So you see how that fluorescein has been useful here, because that is very small and an unusual place. So what I'm doing now, by just lifting all this mucosa, I'm refreshing it, all angles. So posterior defect here, anterior part of the defect, and medial and lateral here. So basically, this looks like it's about a couple of millimeters, really. Let's have a suction. Now, do we have a suction with a smaller head? So now we can see it better.
Yeah, you can see how small it is there in relation to the end of your suction, Hisham.
Yeah, it's smaller than the sucker head, which is about 3 millimeters. So that's why I'm using a smaller sucker. This is like a couple of millimeters, this one. Let's try that. Have a look at it. So the most important thing is just to make sure that we have refreshing the edges. I'm going to use Duragen because this is very small. So I'll use Duragen. It's a bit too tiny to actually be able to get fascia in here. If you see, so here's that smaller sucker. So I measured them by the sucker head, by the way. So this would be 2 millimeter really. So if I show you, yeah, let's have the.
That's nice. We can actually see the fluorescein coming through there now.
Now we can see it because I removed the mucosa.
Yeah.
So open place to repair. Yeah.
As you are just back from Resex Phase course, any thoughts on bath plug technique?
About
the size of bath plug.
How do you measure it? I
measure
bath plug, the fat plug technique.
Yeah, bath plug. So basically, you take fat which usually is described by P.J. Wormald. You take fat from the earlobe, I need DuraGen, and then you stitch it with Vicar repeat, and you go through it with the length of a stitch. So when you pull the stitch, it shrinks. So basically, you put the piece of fat inside the defect, and then pull the stitch that tightens the fat in the defect and acts like a plug in the bath, basically. And it's fat, so fat will cause scarring for the tissue around it. So it heals that way. But it's very useful for fresh leaks, like intraoperative leaks, because they still fresh, they want to heal anyway. So when you put that in, it heals very well. I think just for all the leaks like this, I wouldn't probably do it. But I'm just trying to put some adrenaline on it for a bit to dry it a little bit. Okay, so we need DuraGen. So I'll prepare it with DuraGen and mucosa basically, and we need the glue, please. So if you see this, if I put a nice plug of DuraGen, which really creates healing because it creates that, it stimulates granulation tissue and so on, so creates scar tissue. So it helps. The neurosurgeons use it a lot. I tend to use it a lot in the smaller leaks. Larger leaks, I use fascia because it's a lot stronger. So I'd use it in a leak like this. It's also too small for me to take cartridge from the septum and put it here. So I put the DuraGen, then I put some glue to seal it, then I put some mucosa, and it should be all right.
What glue do you use?
So there's two types of glue. There's T-Seal, which is you mix it and then you can use it immediately. The problem with T-Seal, it doesn't have it's like a transparent in a way. And then the other one, which is DuraSeal. DuraSeal is blue, so you can see it clearly, but also comes with a pump. The good thing about the pump that it pushes away and it doesn't clog the needle, so it doesn't block the needle. The other one blocks the needle very quickly. So nowadays I prefer to use the DuraSeal, not the T-Seal. You used to use the DuraSeal originally all the time until the other one became available. So interestingly, in the past, people used acrylic, which is like Durabond and things like this, and that caused reactions like meningisms and so on. So people stopped using it. So we're sure now this is the only leak. We can't see anything else anywhere. So that's definitely it. You can see the anterior edge, the posterior edge. So, sorry, Kath, question?
Yeah, what post-operative instructions do you give the patient? So post-op, going back to the ward this evening, what do you tell them and how do you manage them?
So we get them to sleep head up, 30 degrees for at least 24 hours, ideally 48. We give them a laxative, so they don't have constipation or push and stuff like this. We tell them not to carry heavy lifting things for about a month, and no heavy exercise for a month. We have neuro-ops, I mean, initially when the ward, neuro-ops as well. And usually I keep them for one night. I used to keep them for 2 nights, but nowadays we keep them for 1 night.
And what about giving antibiotics? Would you give antibiotics after this or not?
You do not because, you know, that there's lots of data showing that antibiotics don't decrease the incidence of meningitis, but because we're using foreign material here, we're using a DuraGen, we're going to use gel foam, we're going to use nasopore, all these things. So that's why I put them on antibiotic for a week. So what we're doing now is we're going to look and then take a small piece of DuraGen to plug this. So let's have the DuraGen. So there's a tiny thing, obviously. So I'm going to take a tiny piece. So also we need, this is the DuraGen. Comes in a sheet like this. And scissors. We'll also need some gel foam and nasopore, and then 140, and then small ones.
So, Hesham, you're saying you pack the nose afterwards with nasopore, or?
pore. But before the nasal pore, we put gel foam to protect the repair. Can I have the 45 Blakeslee? So I tend to put one nasal pore, like the hard one, which is nasal pore 40 first, on the repair, and then a couple of other nasal pores underneath it, soft ones.
You don't use any BIP or Whitehead's varnish anymore, or balloons or anything like that anymore?
No, balloons are useful again for post neurosurgery. See, even this tiny thing looks big, so I'm going to make it smaller. So we used to use in the past until 2003. Let's have scissors again. I used to use basically ribbon gauze covered in Whitehead's varnish, which is iodine and bismuth and stuff like this. And you put this pack tightly inside the nasal cavity for a whole week. We used to send the patient home with this pack and then bring them a week later for a general anesthetic to remove the pack. And that was a bit too much for the patient. Obviously, have two anesthetics and so on. The pack is very, very tight and so on. And then I started in 2003, 2004 using nasal pore. Absorbable pack, obviously can use any similar one. And it was fine. So since then we stopped. I never published that like specifically or separately, but we talked about it in the meetings for years, and colleagues now do the same. So we don't use permanent packs anymore. So now I put this here. So it will be a bit fiddly, it'll be sticky, but you put it like this, and then now, seeker, please. So now we'll ease it inside the, and it's very safe to put this to ease it off into the cavity, like this.
Sham,
yeah.
The delegates have asked this very interesting question. You know, these patients with BIH, they have a leak, we repair the leak, but they are more also likely to have a OSA, and they could be on a CPAP. So what is your advice on patients who have a CSF leak repaired and they're on a CPAP?
Yeah. So we had exactly that, and recently actually I did, see what I've done now is inside the cavity, yeah? So now this is sitting inside the cavity and filling it, just make sure. The patient in CPAP, you cannot use the CPAP. So we get them to get an oral CPAP modified for them instead of the nasal one. And we have had a couple of patients like this, and we managed to get them an oral CPAP. So that is sitting inside that cavity. When you look at it, it does tend to seal it because it's quite thick, it's not porous. So now we have a glue. So I'm going to cover it with glue now. Okay, so watch this glue now, yeah? Is it on? On the pump, yeah?
The pump on.
Pump on?
Yeah, we can see it coming through, beginning to. You've got nice blue spray coming through.
More blue than this. Here we are. So that's enough, yeah? So that's it. Now let us draw a little bit. So the good sign when you put this and you look, if it's still leaking, then you have to put more. So let's have a suction here. So then I'll need the mucosa. Yeah, I need another gel foam. I'm gonna put another one above this because it's slight leak in the top. So let's have a tiny piece. I'll cut it already. Great. Let's have one, yeah, one small one with a Blakeslee. No, this is good because we don't need the small one. We'll cover it. So I put a little bit more above it. They all stimulate granulation. That's why they're very useful. Put this above it here. Yeah, and let's have the Rusk seeker. That's good now. It's actually not leaking now. You can see nothing is coming here. Suction. Obviously, directly suction away from this, otherwise you suck the tear out. So that's okay. So I'm going to put the mucosa. Let's have the big piece of mucosa that got earlier, which is this one. Actually, this is useful. Have a base. It has the turbinate. It has a piece of bone in it. I think it's very useful to put it there. So I'm probably going to take part of it. Too much bone actually. So probably. Let's have a look about what else you have there. Maybe I just use the mucosa, but too thick this one. We don't want to put anything too thick. Yeah, this is curved, perfect. This one, it's a lot better. So let's have scissors. I'm just going to cut this bit. So I have a bit. Remember, I kept all this mucosa from the beginning, so I can use it. Forceps or something. Okay, so let's have the Blixley 45, and I'm just gonna give you this back. There's another piece here you may use. So then I'll use the glue again in a minute. So now I have another mucosa I'm gonna put on the repair. So we need gel foam and we need nasopore 40 and like 2 nasopore normal. You only have standard. That doesn't matter. You only have 40. Wow. Okay, fine. So 240. 240s, yeah. Maybe 3 then. Let's have the seeker first. With seeker. So I'm covering with mucosa now. And this free mucosa, it doesn't actually disappear. It's very, the good thing about the nasal mucosa that it does regenerate, takes a bit of blood supply and sits there nicely. So it is very useful to use that. But you tuck it in properly so it's sitting like I did with the loftrobe. This sits on top of this. Now there's the controversy about putting glue now or not putting glue now. I think I put glue. It's ideally you don't want to put glue between the layers, but the thing is here, I like to seal the gel or the Duragen within. So I put glue in the Duragen, but I left a little bit of the other Duragen without glue on the top here. So that will stick to it. And now that it's all sealed here, I'm going to cover this with glue. And then I'll leave it to dry, then I'll put gel foam, because gel foam will protect the repair and also creates granulation. So now, pump on. Oops. Can I have the seeker? It's too strong to pump sometimes. So gel foam is a protective layer. Yeah. In larger leaks, I use cartilage often. It's coming, is it coming? Oh, I'm pressing the wrong one. Okay, that's it. There we go. That's the blue stuff. We're just closing everything so it's tight and stuck in there. I think that's enough. I'll leave it like this. I'll leave it to dry. Let's have gel foam. So in larger leaks, I use 3 layers. I call it an anatomic repair. We published that many times. I use fascia, scissors first. Fascia lata, then cartilage from the septum, then mucosa. So we just have the 45. I'm going to have to wet these first. So then I have 2 pieces of gel foam, which creates adhesion. Let's try to show you here. The gel foam is very sticky. If you hold it and you try to push it, it will just come out. It will stick to your forceps because it's got as an effect. You have to wet it, otherwise it's impossible to put it in. So let's just put saline some in a little. Yeah, I'm just gonna. So it's gonna wet like this, otherwise it will just annoy you so much. So we'll put 2 layers to protect the repair, and then we'll put our nasopore. Now let's have the seeker. So as you see, like that. Another one. The other one I cut. And we just wet it as well. Let's just stick it in the saline. So another layer here.
Catherine,
Yeah.
As an idea, what do you think for the next Grace Live, probably in a year's time, we could present all these cases that we did over the last 2 days and as a follow-up of them, annual follow-up, and see how they are doing. That would be a good idea, isn't it?
Yeah, no, I agree. I think that would be really interesting to see how everyone's got on since surgery, and it'll give people some feedback on what's been happening. So yes, that would be really interesting to see. Hopefully no recurrent leaks.
Well, I hope so.
Yeah, and on all that very beautiful lothoropathy in that complex patient.
Yeah,
it will be
exactly.
quite an educational. Yeah.
Yeah, it'd be
Interesting.
great to see a nice open cavity in a year's time.
Yeah.
Absolutely.
So that's like
Thank you,
this,
Sam, that's wonderful.
nice and protected. So I'm going to cover it now with the, I'll wait a couple of minutes and I'll put the nasal port. So that's like this is closed now. It's not leaking anymore. So we're going to put nasal port. So I use nasal port 40. Is really, this is really, I'll show you now. This is quite firm. The two types is 40 is firm. So it's really like stronger, it protects the leak. So it's a bit big here, so I'm going to cut it into two. Let's cut it into two, put one by one. Do that, and maybe you can cut the other one as well. So then we squeeze it, then we put it in very carefully so it doesn't destroy our repair. So I'm squeezing it like this. Then I put it onto the floor first, floor of the nose, then I'll push it up. So it's here. And then I'll push it just to support my leak. So it's underneath the repair. Okay. So right at the back there, and then we can lift it up. Like so. Then put another one. Maybe I need a third one, that's all. Again, same idea, put it on the floor, and then lift it up.
And Hesham, when would you see this patient back in clinic next? So say she does well after 24 hours of admission and gets discharged.
So I'll see you in 2 weeks.
Okay.
Check everything. I don't have to remove anything. I leave them to absorb naturally. Obviously, they blocked. You warned them about this, that they're going to be very blocked in this side until these absorb. And they take about 2 weeks to absorb, but there's always some crusting and all that's after anyway. And I don't actually get them to wash or clear anything for a month. I just worry about destroying the repair by if they put too much pressure on the washing or something. So no washing for a month. They get blocked, they get crusty, I don't mind. As long as it's healing. So I put the final one now, and then it's done. So this is the last one. So you can see there's a bit of space here. So it's just basically it's strong support for that repair. So the cavity now is full, so she's definitely now supported completely, and obviously that completely blocking the nose as well. So that's done now. There is a space underneath to breathe from anyway. It's not bad. Done. Thank you so much. All done.
Thank you.
Thank you so much, Ashok. Really interesting case to see, and nice to see the fluorescein coming through, the CSF leak, the repair with the Duragen and the Duraseal over it, and the meticulous searching of the skull base to look for that leak.
Yeah, thank you, Kat. And I think we couldn't have done it without the fluorescein, as simple as that. Couldn't have seen it.
Yeah, very small leak. So
thank you so much. Now we're gonna say bye.
Thank you, Hisham. Thank you from GRN.
Thanks
to you. Really great efforts to organize all these. Thanks to Priscilla, Kat, Mark, then Matthias from the tech team. I can see you took great efforts to organize all this, your theater staff, and everybody, your anesthetists. So really appreciate your efforts. And as far as I mentioned it to Kat, that it takes a whole lot of teams from all these centers. So all the phenomenal efforts to make this event happen. And ever so grateful to all of you for this in supporting GRN. So
thank you very much. And thank you both for moderating very nicely as well. And you take care, and we'll see you for the next one.
See you for the next one.
Great. Thank you very much, Hashim. Cheers now.
Bye.
Bye.
Thank you, everybody.
Kathy.
It was good.
So did you enjoy it, Kathy?
Yeah, really interesting cases today. So fantastic mix that we've seen all the way through. So yeah, great learning and some really interesting tips that we've picked up. So very, very nice. Thank you, Ashok.
And if any of you have missed some of these cases, do check in on our GRN Academy website when they are available as a recording, and we will edit the recording. So the cases will be separate to that surgeon, so to be more user-friendly. So I think it is time to say thank you to you, Kathy. So you really stepped in almost at a very short notice, and it was great to have you on board with hosting, and you made it really engaging, great discussions, and I hope that got some interesting points out for our viewers. So thank you again, and I look forward to have you again on board.
Thank you very much, Ashok, and thank you for inviting me to take part. It's been a really interesting day, and I've thoroughly enjoyed it. And I will certainly be going to look at the cases I missed from yesterday when I did my clinics, unfortunately. But a great thank you to everybody at GRS. So thank you for setting it all up and organizing everything together.
It's also time to say thank you to all of our scientific committee members and the surgeons who operated and their teams, and also to my GRN team members, especially Dimitri. Dimitri always puts a huge efforts behind the scene. So Dimitri Yanadis, he's another GRN director. So thank you, Dimitri. Then the others who have helped in the past, Rohit, Shri, and Ankur, all of them have always contributed to GRN. And a big thank you to them. Our GRN manager, who does all the admin work, Pam Nori, is also an event organizer for ENT UK and Resection ENT courses. So she has put a phenomenal efforts. And there were our tech consultants, Dinesh, then the digital infomedia team, Arvin, then putting the beautiful studio, Anil. So all of you, fantastic efforts, and you run behind, you stayed behind the scene, overseeing this event, almost 12 hours live yesterday. But for them, it is preparation, setting things up, so much more than those 12 hours, and they're really working very, very hard. And today, on our second day in a row. So fantastic. Thank you so much. And for Rucha for our digital promotions of the event. And to our delegates for hanging on with us. And I hope you found all the surgical teaching useful. So stay updated, and we'll see you again on our next event. Thank you.
Okay.
Bye for now.
Okay. Bye. Thank you very much.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise. We're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.